join.
Yes, yes,
So
sir.
we can wait for maybe 2, 3 minutes or 5 minutes.
Correct, sir.
We have just begun the webinar session, and we are just waiting for join and by Right, Tarun, can you hear me?
Uh, there's an issue with the internet, sir.
Right. Am I like, is my voice not clear? Is it breaking?
Correct, it's breaking, sir.
Okay.
Just join with your laptop once, please. This is better, sir.
All right. Can you hear me now clearly?
Yeah, perfectly clear.
Okay, so we have a good number of participants now. So we'll start the session. So welcome back, all the delegates and panelists. We had a great day yesterday. It was a very long day, and we had 2 or 3 very important sessions where we gained a lot of insights into different types of ILDs. So today's agenda will be focused on granulomatous ILDs and rare ILDs. So first we start with granulomatous ILDs, where we will deal with sarcoidosis and hypersensitivity pneumonitis, which are the common granulomatous ILDs. So for the first talk will be on sarcoidosis, how I diagnose it, and we'll have the discussion there and then, because the faculty who is giving the talk is Dr. Amit Chopra. He is Associate Professor of Medicine and Director of Pulmonary and Critical Care Fellowship Program at the Albany Medical Center, New York, USA. His areas of interest mainly include pleural disorders and interventional pulmonology, and he has also worked on sarcoidosis a lot. He has about 90 publications. He joins us from the US at a very odd time, so he just delivers his lecture and then we'll have some discussion on diagnosis, and then we'll let him off so that he can really go to bed. So over to Dr. Amit.
Okay.
You can start sharing.
I'm going to share the video here. Okay. You see my slides. Can you see my slides?
Yes, I can see them. Can you make it full screen?
Yeah. Okay. Thank you so much.
Can you go to the next slide once? I'll just check whether it is moving well. Yeah, that's fine. Yeah. So yeah, you can start. Thank you.
Move the cursor out of the way. Okay. Well, thank you so much for your kind introduction. My name is Amit Chopra. I'm from New York, USA. I graduated from Maulana Azad in 2005. So I left Delhi in 2005. I've been here for about 17 years. So I'm going to talk about diagnosis of sarcoidosis. And I don't have any confident interest for this topic. It's not moving, Sajal. The screen is not moving forward.
Just click on the screen, sir. Just click take the pointer on the screen.
Oh, gotcha. Okay. Oh, very good. Thank you. So these are the outline of my topic. So I'll talk about definition. I'll talk about basic principle of diagnosis, then general approach to granulomatous lung diseases. And then at the end, I'll talk about American Thoracic Society guidelines, clinical practice guidelines, and Indian context. So what is the definition of sarcoidosis? Sarcoidosis is a multi-system granulomatous inflammation of unknown cause, meaning by it can involve multiple systems. Commonly, it involve lung, skin, and eye, but it can involve multiple other systems like heart, neurological system. And it is characterized by granulomatous inflammation. So these organs have granulomas, and the cause is not known. So therefore, you have to exclude the other known causes of granulomatous inflammation. When you make a diagnosis of sarcoidosis, there are 3 steps involved in the diagnosis. First of all, you have to have compatible clinical presentation. So your clinical presentation should be compatible with sarcoidosis, which I'll get into. Second step is you have to demonstrate granulomatous inflammation in majority of the cases, but some cases you may not need biopsy. And third step is, which is very difficult, is to exclude the alternative causes of granulomatous inflammation. This is not always easy to find to exclude other causes of granulomatous inflammation. And most important thing I want to say is that diagnosis is never fully secured. So you cannot be 100% sure this is sarcoidosis, but you can be 99% sure with the good confidence if you do a diligent workup to rule out alternative causes of granulomatous inflammation. But you cannot be 100% sure ever in terms of diagnosis of sarcoidosis. So first step is compatible clinical presentation. So you have to have clinical presentation which is compatible with sarcoidosis. These are the highly probable conditions. For example, if you have Lofgren syndrome, lupus pernio, uveitis, optic neuritis, which is eye involvement, skin lesion, erythema nodosum. If you have imaging showing hilar lymph node, perilymphatic nodules, parotid uptake, or laboratory analysis showing hypercalcemia, or hypercalciuria, then you can think this patient may have most likely sarcoidosis. So these are highly probable conditions. So I'll go one by one, a few of them. Lofgren syndrome is classically characterized by hilar adenopathy and erythema nodosum involving the leg, especially the ankle. Can be also present in an elbow as well. So, and then with fever. So that's a classical Lofgren syndrome. If you have that, you can make a clinical diagnosis of sarcoidosis in majority of cases. Hereford syndrome is another one in which you don't need biopsy. You can make a clinical diagnosis if you have uveo-parotid swelling with fever. So basically, you have parotid gland enlargement bilaterally, you have anterior uveitis, and you have fever. And that is Hereford syndrome, and you can make a clinical diagnosis without a biopsy. And third is lupus pernio, which is a violaceous plaque involving a nasolabial fold, nasal area that can cause significant disfigurement. And some patients actually are more worried about skin lesions than their lung lesions. So this is a very important clinical condition to recognize and also treat in cases of sarcoidosis. Radiographically, you may see perilymphatic nodules along the lymphovascular bundle and also reaching to the pleura. Here also have bilateral hilar adenopathy. So this is a classical case of sarcoidosis with perilymphatic nodule along in a bronchovascular bundle with bilateral hilar adenopathy. The second step is showing granuloma. So then you have to biopsy in majority of cases to show granulomatous inflammation, which is classically the sarcoid granuloma, classically tight granulomas, compact without any necrosis in the center, and you can see in the center macrophages, and you can see surrounding giant cell and epithelioid cells. So that's your second step. So what organ you can biopsy? Most commonly, we biopsy lymph nodes. We biopsy chest lymph nodes using EBUS, endobronchial ultrasound. Sometimes we have superficial lymph node. I biopsy with ultrasound guidance. We biopsy superficial lymph node as well. If you have lacrimal gland swelling, you can biopsy that. Bone marrow involvement, you can biopsy bone marrow. Lung biopsy, recommend transbronchial biopsy, not video-assisted lung thoracoscopy, or those are more invasive. So transbronchial gives you answer in many cases. Skin biopsy is low yield, especially the erythema nodosum biopsy is non-specific often, so it may not give you answer. Importantly, cardiac biopsy should not be done because yield is less than 20% and yield is low and risk is high. So therefore, because granuloma is along the apex, you may not get to that area and it's patchy involvement. Therefore, cardiac biopsy should not be done, and you can make a cardiac sarcoidosis diagnosis based on MRI or PET scan. You don't need a cardiac biopsy. But often you need organ-specific biopsies, mostly lung and lymph nodes. There are 3 guidelines by ATS, American Thoracic Society, regarding these biopsies. First, lymph node sampling. First guideline is that if you have Lofgren syndrome, Hereford syndrome, or lupus pernio, these 3 clinical conditions, you don't need biopsy. You can make a clinical diagnosis. Secondly, if you have asymptomatic bilateral hilar lymph node, so if you have hilar lymph node, but patient has no fever, no night sweats, no weight loss, then you can also make a clinical diagnosis case by cases, but there is no official recommendation because it recognizes that in endemic countries, patient may have tuberculosis or other areas in which biopsy may be necessary. So therefore, at this point, there is no recommendation regarding biopsying asymptomatic bilateral hilar adenopathy. But if you're not biopsying, then you should do a close follow-up with repeat imaging to make sure there is no new development on these adenopathies or new lung lesions. Third, if you biopsy that, you want to use EBUS. EBUS sampling is preferred over mediastinoscopy or conventional lymph node sampling because it has high yield and low risk procedure. Risk of EBUS sampling is less than 0.1%. Third step is not easy. Third step is the most difficult one, is the exclusion of alternative causes of granulomatous lung inflammation. Because why is that? Because there is a long laundry list of diseases which can cause granulomas in the lung. It could be infection. There is a big list of infection which can cause granulomas, like mycobacterial infection, non-tubercle mycobacterial infection. In US, especially funguses, which can cause a lot of granulomatous lung disease. You have to be careful. Parasites, some of the bacterial infection can also cause granuloma. and there are a long list of non-infectious causes of granulomas as well. So therefore, it becomes hard to exclude confidently all the other causes of granulomas. Importantly, for in Indian context, in endemic countries, it is very, very, very important to make sure you're not dealing with sarcoidosis. Do not label sarcoidosis as tuberculosis, because the consequences can be very, very serious. So therefore, I think you want to make every effort to differentiate sarcoidosis from tuberculosis. This is a paper we wrote. It's not perfect again, but it gives you some idea that what favors what. So here there's a breakdown. There are 3 columns. First column is favors tuberculosis. Second column is favors neither of these condition. Third column is favors sarcoidosis. And these are the clinical. These are the demographic and other features which may help you to see to differentiate TB from sarcoidosis. But again, it is not perfect. So if you're from endemic country for TB, most likely it is TB. If a patient is immunosuppressed HIV patient, most likely this is TB. Smokers, if patient is pediatric case, it's very rare to see pediatric sarcoidosis, so it favors tuberculosis. If you have hemoptysis, most likely this is a case of tuberculosis. Hemoptysis is very rare in sarcoidosis unless there is aspergilloma or for stage 4 sarcoidosis. They don't have usually hemoptysis. Radiographic involvement. If you have pleural involvement is very rare in sarcoidosis, especially pleural effusion. Less than 1% of pleural sarcoidosis have pleural effusion. So if you have pleural involvement, you're more likely thinking about tuberculosis. Cavities, again, favors tuberculosis. Tree and bud appearance, that also favor tuberculosis. There are some radiographic feature which may suggest sarcoidosis, like if you have nodules along with the bronchovascular bundle, galaxy sign, which is basically small nodules coalescing into a bigger nodule, like a galaxy. That favors sarcoidosis. And if you have necrosis in ultrasound, that also favors tuberculosis. By EBUS imaging, you can sometimes appreciate necrosis. Laboratory analysis may not help you because the ACE levels, the enzymes, they can all be elevated in both the conditions. Hypercalcemia favors more sarcoidosis, but if you have necrotizing granuloma, that favors tuberculosis. So these table may be helpful to some extent. Again, it's not 100% to differentiate tuberculosis from sarcoidosis on clinical ground, on radiographic ground, and pathology. This is the algorithm we described. Again, this is not a perfect algorithm, which helps working up this patient with the granulomas. I need to move this thing out of my way. Okay. So first step is if you have pathology showing granuloma, that's your first step. If you have pathology showing granuloma, you want to make sure that you're staining for AFB and fungus. Okay, if the staining is positive and culture is positive, you most likely has infection causing granuloma, not sarcoidosis. And if culture was not sent initially, sometimes the patient we have very, very low suspicion, especially in the US for tuberculosis, then we don't send them send the biopsy for culture. But if you have a suspicion, you should send for cultures, AAB cultures and fungal cultures. And if it's positive, then definitely that is likely a case of infectious granulomatous lung disease. If there is no clinical suspicion, there's culture is negative, stain is negative, then you can confidently say this is non-infectious cause of granuloma, such as possibly sarcoidosis. But in India, I think you want to do a diligent, very exhaustive, thorough, diligent workup to make sure you're not dealing with tuberculosis. So you want to do other ancillary testing, molecular testing, etc., maybe biopsying other organ to make sure you're not dealing with tuberculosis. And if your suspicion is still high, then you may want to go to extra step and take extra step and treat the patient. If the patient improves, then this is most likely was a case of tuberculosis. So this is the algorithm by ATS, basically summarize what we talk about. If you have clinical presentation compatible with sarcoidosis, first thing is, do you have these conditions? Do you have Lofgren syndrome? Do you have lupus pernio? Do you have Hereford syndrome? If you have any of those, you don't need biopsy to make a diagnosis in most of the cases. There are exceptions we'll talk about in a second. But if you have any of this clinical condition, your diagnosis of sarcoidosis most likely secured. But again, you cannot say definite for sarcoidosis. You can only say probable sarcoidosis because you cannot be 100% sure this is sarcoidosis. So if you don't, so that's your first step. If you don't have these conditions, if you don't have classical off-granule lupus pernicium, Hereford syndrome, and then you want to biopsy. Okay, biopsy the lymph node, biopsy lung, whatever organ, target organ you think is involved, and then then if your biopsy is positive, shows granuloma, and there is no other cause of granuloma, then this is likely sarcoidosis. Okay, that's your step 2. And then, but if you do biopsy and biopsy is not necessarily sarcoidosis, then you probably are dealing with alternative diagnosis. This is probably not sarcoidosis, you're dealing with alternative diagnosis. Or next scenario is that if you're biopsying and is negative, or you biopsy, or you didn't do biopsy because patient refused the biopsy or some other reasons. In that situation, if in that situation, if your clinical presentation is not compatible, if biopsy is negative, this most likely is alternative diagnosis. Okay, so what is the issue here in Indian context? And pitfall in the Indian context is the biggest issue is that tuberculosis is a very close mimic of sarcoidosis. So you can also see Lofgren syndrome in a patient with tuberculosis. So it can mimic Lofgren syndrome. Therefore, you cannot be 100% sure is this sarcoidosis, this is tuberculosis. Similarly, bilateral retinopathy. I think, and here we don't biopsy asymptomatic bilateral retinopathy, but I think in Indian context, you probably have to make sure it's not tuberculosis. And then and often these patients, in more than 10% of cases of suspected sarcoidosis, may have tuberculosis. Therefore, it is very important to rule out tuberculosis and do a diligent workup to make sure you're not dealing with tuberculosis. Okay, so that's about pulmonary sarcoidosis. So extrapulmonary sarcoidosis, why to screen for extrapulmonary sarcoidosis? Why should you look for extrapulmonary sarcoidosis? Why? Because it's very common. It's very common to have eye involvement, very common to have skin involvement. And therefore, you should screen for extrapulmonary sarcoidosis, number 1. Number 2, the treatment of extrapulmonary sarcoidosis may be organ-based. Maybe if it's eye involvement, you want to give eye drops. Skin involvement, you may want to use different therapy. If you have cardiac sarcoidosis, you might want to use infliximab. As a clinician, you're always worried about cardiac sarcoidosis because cardiac sarcoidosis, if it's untreated, undiagnosed, can be fatal. So if I see a patient in clinic with sarcoidosis, I'm making sure they don't have any symptoms suggestive of cardiac sarcoidosis because they can go home and drop dead, and has happened before. So therefore, it is very important to make sure if you have suspected sarcoidosis, you are asking right question to make sure they don't have cardiac sarcoidosis. And the neurosarcoidosis, we usually have a patient in the hospital with the spinal cord involvement from neurosarcoidosis with paraplegia. So those patients this can be very disabling. So therefore, you want to make sure they don't have extrapulmonary sarcoidosis because it's common, treatment's specific, that could be fatal if you miss it. So how do you screen? Screening is very simple. So there are some blood tests involved. There are some clinical questions you should ask. So these are the 9 recommendations by ATS Society for various extrapulmonary diseases. So you want to check for alkaline phosphatase level. These are conditional recommendations. Blood count for bone marrow, creatinine for renal function, calcium, vitamin D levels. Calcium is a strong recommendation. Eye involvement. Eye involvement is eye examination is important because they can have silent blindness without uveitis. So it is very important to make sure they don't have any ocular sarcoidosis on initial presentation, and then we do annual eye examination to make sure they don't develop any ocular sarcoidosis because it can be a serious issue if they have ocular sarcoidosis. You want to get EKG done to make sure there's no heart block. There's no recommendation to do echocardiography or Holter, and you don't need to go get a full LFTs. So how do you suspect cardiac sarcoidosis? How to screen for cardiac sarcoidosis? You want to ask these questions. Chest pain, do they have chest pain? Do they have palpitation? They have syncope? They have dyspnea out of proportion? Or whenever I see a patient with sarcoidosis, I always get EKG done to make sure there's no heart block or any other sign of cardiac dysfunction. If they have, so how do you make a diagnosis of cardiac sarcoidosis? If you have suspicion based on history, exam, EKG, ECG, the next choice, the next test is you can do MRI or PET scan. You can do either or. MRI by guideline prefers MRI, but in our institute we do more PET scans because of it gives you also an idea about treatment regimen and maybe tapering the treatment regimen. It can help you in treating and tapering the treatment regimen. So either or, both are good, depending upon what expertise in your institute. But guideline recommends MRI. If you have suspected pulmonary hypertension, patient with sarcoidosis can have many reasons for pulmonary hypertension. They can have group 2 pulmonary hypertension from cardiac involvement. They can have group 3 pulmonary hypertension from lung involvement, or they can have just twisting from fibrosis. It can cause arterial distortion of the pulmonary vasculature. You can also have granuloma in the pulmonary vasculature, which can give you pulmonary hypertension. So there are many reasons why you can have pulmonary hypertension. Typically, one of the 4 causes of pulmonary hypertension in sarcoidosis patient. So if they have pulmonary hypertension, they can become very, very short of breath. The initial screening is transthoracic echo. If they have echo suggestive of pulmonary hypertension, then you want to do right heart cath. We often do right heart cath. Sometimes you put them on pulmonary vasodilators, epoprostenol or sildenafil or other medications. And if a TT is sometime, if you are not in the, as you know, transthoracic echo is based on jet of the blood flow. If you're not in the right vector, you may miss the jet and you may underestimate pulmonary pressure. So in those situations, we may have to do right heart cath, which we do in the ICU in patients with suspected sarcoidosis, associated pulmonary hypertension. Okay, in summary, so I hope I was able to clarify that diagnosis of sarcoidosis requires 3 steps. First step is compatible clinical presentation. Do they have highly probable conditions like Lofgren, Hereford, lupus pernio, hyaluronopathy, paralymphatic nodules in the lung, galaxy sign. So then you think most likely this is sarcoidosis. Then second step is biopsying the organ. Most commonly we biopsy lymph node because it's less invasive. It gives you answer, and we do EBUS and bronchial ultrasound to sample the lymph nodes. And if it's superficial lymph node, you can also biopsy that. And third thing is the most difficult thing to do in my clinical experience. I think, especially I can imagine in India. Dr. Judson always says that if I have to make a diagnosis of sarcoidosis in India, I have to be 10 times sure. So I have to make sure that you are doing a very, very thorough workup to make sure you're not dealing with tuberculosis. So that's your third step in excluding alternative causes. And again, it can be challenging, especially in endemic country, making a diagnosis of sarcoidosis can be challenging. And third, if you have sarcoidosis, then you want to make sure you are not missing extrapulmonary sarcoidosis. So those are the 9 recommendations we talk about. Especially cardiac screening should be done. Make sure they don't have palpitations, syncope, chest pain. And I always ask about eye symptom. I always ask about kidney stones, skin lesion, etc. So with that, I'll conclude my talk. Thank you so much for having me. I'm ready to take questions. I think it's your time.
Thank you, Amit. That was very crisp. So we have a lot of questions in the participants' question and answer box. And I would request Karan also to join in here. Karan,
Sir,
can you? Yeah,
yeah, I'm here, sir.
Karan, Mata.
Okay,
Karan,
sir.
can you? Yeah. So Karan is here. So we have both our sarcoidosis speakers here. So we'll just take up the questions from the question and answers box. So one question is the role of ACE in the diagnosis and monitoring of sarcoid. Amit?
Yeah, I think the ACE is not very sensitive. 65-66% sensitivity, so you can miss 1/3 of cases with ACE. But if the and it's not very specific either, because any granular disease can give you high ACE. But if your ACE level is more than 2/3 or upper limit normal, it is highly specific for sarcoidosis. If your ACE level is 200, okay. In US, in New York, is upper limit is 70, but if it's like more than 140, 150, most likely this is sarcoidosis. I'm not sure if you use the same pattern. Can it be used? Can it be positive later in the course? Yes, it can be positive later in the course, but most patients will present with high ACE in the beginning if they have high ACE. But again, it's not a very sensitive marker.
Does it help in monitoring the disease activity in any way?
Yeah, I mean, I think there are some paper. I think there is paper by Judson also about ACE. ACE, you can monitor, but monitoring should be done more clinical. I think when you are tapering steroids, it should be based on clinical organ involvement. So, like if you have lung involvement, you want to look for pulmonary function tests. You want to look for clinical symptom. You want to look for radiographs rather than only ACE. But I think that still goes in parallel in some of the patients.
Karan, do you agree or differ? Do you have anything to add on ACE?
Yeah, I think I would mostly agree for ACE as a diagnostic, marker. It is not, if an elevated ACE in a consistent clinical profile adds to your diagnostic confidence, but a negative ACE does not exclude the diagnosis.
Yeah.
So I think if we have the entire clinico-radiological profile which is fitting in with the diagnosis of sarcoidosis, a normal ACE does not exclude the diagnosis. And this is a very important message because I think many practicing physicians actually rely only on a tuberculin and ACE in isolation for evaluation of mediastinal lymphadenopathy, which is not correct. So you need to integrate everything together, and that's very important. I think once you have a confident diagnosis, I think we don't usually routine ACE for our therapeutic decision making on follow-up. And as Amit rightly said, it's how the patient is feeling, which is the most important parameter. The clinical response is most important, and lung function importantly, but lung function improvement may lag behind the clinical response. Some patients may not get that degree of improvement. So I think clinical is most important. And to add to it, radiology. Radiology is another which is undoubted parameter which indicates improvement.
Yeah. Amit, do you do quantiferon gold or any other form of IGRA, interferon gamma release assays during
Yeah,
the
we
diagnostic
do.
workup?
I think in US, situation is different because, guess I've seen only 2 cases of tuberculosis in the last 15 years. So TB is like a rare bird here in US. So in most cases, sarcoidosis is much more common. And as you know, the diagnostic accuracy of these tests is based on prevalence.
So if you have a patient who you are suspecting sarcoidosis, but if you get an IGRA positive, then how do you interpret it? And how do you manage such a patient?
I think then you have to make sure there's not, and depending on patient where the patient is from, if they have if they're from endemic country, and quantiferon is positive, and there is granulomas, you have to make sure there's not tuberculosis. I mean, you have to do diligent workup, as I listed before, to make sure.
Suppose clinically it fits into sarcoidosis. Say if it is asymptomatic bilateral hilar adenopathy, and you have an IGRA positive patient, maybe coming from an endemic area. Then what do you do?
I would do FNA. I would do
it?
FNA of the lymph nodes.
Yeah, but if you get non-necrotizing, suppose if you get non-necrotizing granulomas,
and then a stain negative, culture negative, I'll send for culture and stain. If they're negative, then I think you probably can make a diagnosis of sarcoidosis. In that case, you don't have to treat. Asymptomatic adenopathy doesn't need to be treated.
Yeah, but in the US you also treat latent TB, so you will be able to. I'll get you Karan on this. So you'll be able to like with a positive IGRA, you'll be able to say that this patient has latent TB. This individual, we shouldn't call it the patient, but this individual has latent TB, and now you also suspect clinically that he has sarcoidosis. This happens because I'm asking this question because this happens a lot of times with us. So we don't treat latent TB as a routine. But then what will you do? Will you treat for latent TB or will you give the full 4-drug treatment for tuberculosis as such?
I think it's a good question. I think if the stain culture, everything is negative, I would just treat for latent TB. But I don't know, man. You guys have more experience in tuberculosis than I do.
Yes. I just wanted to know the practice there. Karan, you can come in now on this. That if we get a kind of suspected sarcoidosis, say asymptomatic person with hilar adenopathy and a positive IGRA. We can also take a positive MAN2, but first positive IGRA. You can unmute yourself, Karan.
Yeah, I think if you want to confuse yourself during clinical management, do IGRA. So I think the bottom line is that, we don't perform IGRA ever. I think because in your decision making, it's the clinical profile. You've got tuberculin, you've got pathology, you've got the radiology in front of you. You don't need to necessarily bring in something which will, confuse you unnecessarily. I'll give you the reason. In our cohort of 327 patients of sarcoidosis, we found a 10% tuberculin positivity. That thereby meaning that a tuberculin reactivity in isolation, does not mean that it is not sarcoidosis. So what I mean to say is, when you are diagnosing sarcoidosis, keep the 20 things which you have in front of you. See where the 19 or 18 out of 20 are fitting in. And if everything is going in one direction, you take decisions. So I think that would not add to, so even we have tuberculin positive patients which are confident sarcoid, treated with steroids and responded. But the bottom line is, you keep a close follow-up in all patients with granulomatous mediastinal lymphadenopathy, because there'll be some outliers who will behave differently, but they will be very few.
So Karan, yeah. So Karan, see, you and me are sitting in referral centers, and we see a lot of sarcoidosis patients. Otherwise, sarcoidosis is not a common disease, especially in, say, northern part. It is still, we see a lot of patients in a specialized clinic. In the southern and middle parts, central parts of India, maybe western parts, it is not so common. So we have such experience that you could call a MANTO positive patient still a sarcoid patient. But for an average general physician who sees sarcoidosis rarely, what should that physician do? Should they send to a referral center, or should they make a decision on clinical perspective or clinical judgment?
So see, this confusion is not very common. Most of your sarcoidosis patients would be tuberculin negative, and you would have, a non-necrotizing granulomatous inflammation. We found, nearly 10 to 13% of the patients may have necrotizing granulomatous inflammation also, but common things are more common. So if you see the entire clinical profile, you see non-necrotic lymphadenopathy, you see parenchymal lung involvement, which is perilymphatic. Those are very strong pointers in a large majority towards sarcoidosis. So I think that's what I said. You integrate, where most of the things are going in. You take a therapeutic call, but you are very right. In tuberculin positivity, the practice, usually is to initiate the patient on, antituberculous therapy, which we see. And there are some patients who get a diagnostic delay of sarcoidosis by that time happens. I think that delay may be harmful in a way, they may have parenchymal fibrosis if it's delayed too long. But mostly what it does, it leads to a delay in steroid initiation. I mean, it is not very harmful in many of the patients, because on the other hand, if you give steroids to a patient with definite tuberculosis, that is actually more harmful. So I think there are no clear answers. It's a clinician's call. But what I mean to say is, you put everything together and see where most of the things are going and take a call.
Right. So there are 2-3 related questions. So as you said, several places it is the practice to initiate ATT, or even people will initiate ATT and steroids together whenever they are confused whether it is sarcoid or tuberculosis. See, if there is AFB, if there is expert positivity, you'll go ahead with ATT. But if both are negative, there might be some necrosis or may not be. But the practice of giving both ATT and steroid to start with, is it a good policy? And the second question is that if you are really confused in a peripheral setup, then what do you do? Do you give ATT alone and just be safe, or how will you go about it?
Yeah, I think a concurrent administration of ATT and steroids is also which we possibly never do. We would try to take a call towards one direction where things are going. And usually it's an addition of, a concurrent treatment which is mostly you add steroids on a background of somebody who's been started on ATT. So I think what we need to do is, educate physicians more that how do you need to integrate all the clinical things together. And I think this is an important area which one needs to work on, that how do you enable physicians at the periphery who are managing mediastinal lymphadenopathy to have clinical radiological algorithms which can increase the diagnostic confidence. So I think those are things which, some directive has to be given. But I think a safer bet is giving anti-tuberculous therapy, which I'm not recommending, because I think a confident diagnosis or a treatment decision can be taken in majority of the patients on the first go. So I think if you started ATT and patient is not improving and you go back to your CT, you see it was all perilymphatic, it was like sarcoid. I mean, then you take a call of adding steroids.
Amit, we have a question that if a sarcoid patient has a raised creatinine, then how to go about it?
Yeah, so raised creatinine in sarcoid could be many reasons, but one of the reasons could be glomerular nephritis. Then you probably have to do biopsy. You have to do kidney biopsy to make sure there's no. So there are two scenarios. One is sarcoidosis diagnosis is already established or is not established. Okay, if sarcoidosis diagnosis is already established, then and there is no other cause of kidney involvement, then you can just treat and see what happens to renal function. That's one scenario. Second scenario is that there is no other there is sarcoidosis diagnosis is not established, and there is questionable other causes of renal failure. Then in that case, kidney biopsy may be helpful to make sure
With an
there's no
established diagnosis, you'll not go ahead with a kidney biopsy, right? And
No, because
also we need to look
unless
at the
patient has like other reasons like lupus or some other rheumatological disease, then you don't need to biopsy kidney. Then you
and
just
we
give
need to
steroids.
look that whether the raised creatinine is due to hypercalcemia. If it is due to that, then we have
alternative
a
cause.
clear
Yeah.
cause.
In that case,
So
also
what is the role?
steroid helps.
What is the utility? Yes. So what is the utility of bronchoalveolar lavage in the diagnosis of sarcoidosis?
I think there is good amount of literature about BAL can be helpful. Like if in a right clinical setting, if you have lymphocytosis with a CD4/CD8 ratio more than 3.5 or 4, depending on what literature report, can make a confident diagnosis of sarcoidosis in a right clinical setting. So there's a right clinical scenario, good compatible radiograph, and then you do a BAL. There's lymphocytosis with CD4/CD8 ratio more than 3.5 to 4. Then you can make a diagnosis of sarcoidosis.
But do you practically use it? Now we have much better tools like EBUS and EBB and TBLBs. We are already doing them. So do you really use bronchoalveolar lavage?
I rarely use BL, but if I'm doing EBUS, I'll just get a BL sample to same time. Because sometimes EBUS FNA, in a 5-10% cases, it could be false negative, right? It may not be non-diagnostic. So that situation may be helpful.
Do you routinely assess the CD4/CD8 counts also?
We always do. Wherever we do bronch, I do EBUS. I always do bronch with BAL and CD4/CD8 extra. In Europe, I think CD4/CD8 they usually go by. They don't do. I mean, some practice I know they do CD4/CD8 and lymphocytosis.
When do you perform endobronchial and transbronchial biopsies for diagnosis of sarcoid? Given that there are mediastinal nodes, you have performed an EBUS TBNA. Will you go ahead with an EBB TBLB?
So we have an on-site. On-site which is cytology in the room. So if I'm doing FNA, I can tell they can tell me if there's granuloma or not. But if the patient has, let's say, difficult lymph node, small lymph node, and you're not confident if you're getting sample, but patient also has some lung involvement, then I'll do transbronchial biopsy and BAL before I come out. So I don't have to go
not
back.
As a routine.
Not as a routine. Only case-to-case basis. I'm not sure if you guys do that, but I just do EBUS first.
We generally tend to perform all the three because it has been shown to improve the yield. Also, ROSE is not routinely available with, at least at our center. At other centers, it is. And so that's why we go ahead. Okay, I think we can pick Karan on this later, and I can let you off and we can really proceed. And all the audience questions on treatment will be answered after the treatment part. We just discussed sarcoid TB treatment because it was relevant for the diagnostic part also. Right. So thank you, Amit.
Thank you for having
so
me.
much. And yeah, thank you. Yeah, thank you so much. Can you unshare the screen? So next we have the management or treatment of sarcoidosis. how I treat it and why so. So, Dr. Karan Madan, an additional professor of pulmonary medicine at the All India Institute of Medical Sciences, New Delhi, will be presenting it. Karan's areas of interest include interventional pulmonology, sarcoidosis, post-TB chronic respiratory disorders, and some bit of meta-analysis. He has over 300 publications, and he is a member of several educational committees and different committees of various international societies, and editor on the editorial board of several journals. So over to Karan. Karan, you can start
Thank you,
sharing
Sejal.
your screen.
I'll share my screen. Do you see my screen now?
Yeah. Can you make it full screen? And just go to the next slide once. Yeah, you can come back. It's fine. So you can start. Thank you.
Thank you, Sejal, for inviting me for a kind introduction, and hello to all the colleagues and friends, many of them who are in the attendees also, who haven't been able to take all the questions because of paucity of time, I think. So I'll be covering the treatment part of pulmonary sarcoidosis. I'll not be going too much into details of individual studies because I think that will be beyond the scope of time, but maybe leave you with some key messages that how do you take treatment decisions once you have diagnosed sarcoidosis. So very importantly, as you heard in the previous talk by Amit, that you need to exclude other possible causes of inflammation. And importantly, is somebody's mic on? Hello? Hello? Yeah. Okay. So mediastinal TB is a very close differential in endemic settings. And as we said, tuberculin skin test, most of your sarcoidosis patients will be TST negative. But uncommonly, it is possible that you may have tuberculin positivity, and that does not rule a diagnosis of sarcoidosis. Everything else is fitting in. And in 10 to 13% of the patients, you may have a necrotizing granulomatous inflammation. And for a confident diagnosis, you really need to integrate your clinical, radiological findings, the lab data, and then you can initiate a treatment. So this is actually the guideline document that Amit was referring to regarding the diagnosis of sarcoidosis from the ATS. And the first recommendation which they have is actually a lymph node biopsy being avoided in patients with a typical presentation of sarcoidosis. Now, this is not a strong recommendation they've given, but I think the evidence to support this is quite weak, and I would strongly go on the side of doing a biopsy to get a diagnosis. And in case your biopsy is not performed, the patient must be kept under close observation and follow-up while you are treating the patient. There was also a mention of cardiac sarcoidosis and how difficult and a non-yielding a cardiac biopsy may be, or an endomyocardial biopsy. This was a small series of patients from our cohort of cardiac sarcoidosis, and what we found was that from an extrathoracic site you can also get good diagnosis. So if you get a referral from a cardiologist for a suspected cardiac sarcoidosis, if you do a CT scan of the thorax, you may pick up lung parenchymal involvement or mediastinal nodes, which may give you a diagnosis of sarcoidosis with a fairly good diagnostic yield. A bit about our cohort. We published this cohort of more than 300 patients of sarcoidosis, and I bring this slide because if you see, a majority of patients which we had were actually symptomatic patients, and this is important because how symptomatic a patient is actually has an impact on what treatment you would give. And you see that a majority of patients in our setting are symptomatic. And if you see, the respiratory symptoms and fatigue predominate these symptoms. And a large majority of patients also have an extrathoracic involvement, but how commonly you would pick it up would depend on how strongly you examine them clinically and you investigate on the slightest suspicion of an extrathoracic involvement. Important to note, most of your patients won't have an organ-threatening or a life-threatening manifestation and would indeed respond well to treatment. So now coming to the topic proper, that is, the treatment of sarcoidosis and how do you proceed. So the first decision which you have to take and always think is to treat and not to treat. The very fact that you got a diagnosis of granulomatous inflammation should not, make you so excited that, okay, I've got a diagnosis and now I'm going to treat. So even once you've got a diagnosis of sarcoidosis, now you need to sit back and think, you need to talk to the patient, see the patient, and you need to see how significant the clinical state of the patient is and how significant is the organ status of the patient is to initiate or not to initiate treatment. So, as you have many patients which are asymptomatic, and the disease may undergo a spontaneous remission in a large proportion of patients. So, asymptomatic patients who do not have any functional or an organ system impairment may be observed, and the disease may improve spontaneously in many. It is commonplace to see a patient who was having mediastinal lymphadenopathy, patient had fever, had some symptoms at symptom onset. The patient delayed any investigation, patient comes to you 2 months, 3 months later, you do a scan and you find there are no nodes. So basically, it's important to note that spontaneous resolution does happen. And in patients who are minimally symptomatic, you can go without treatment with careful observation. Now, what is your goal of treatment? Your goal of treatment is, to improve the organ function if there is any impairment, to improve the clinical state of the patient, improve the quality of life, and eventually to prevent any end organ damage. Because symptoms of sarcoidosis are not the ones which are going to have a long-term impact mostly, but it's the organ system, involvement. If you don't treat it, which lands up in, you have patients who may land up into pulmonary fibrosis. Many patients in which the liver disease goes undiagnosed and they end up with, cirrhosis. So these are the things you actually want to prevent. So I brought this slide because this is one slide which nicely brings up, how to classify, patients who are possibly say low risk, intermediate, and high risk sarcoidosis. Now, this has not been clearly defined, or consistently agreed upon, but this is an article from a European setting which shows you that if you have some, low risk phenotypes like a localized cutaneous involvement or a single joint arthritis or a lymph nodal sarcoidosis, they have classified them as low risk sarcoidosis, including Lofgren syndrome. These are the groups which may do well with minimalistic or a no treatment approach. Then you have an intermediate group which includes uncomplicated uveitis or a mild hypercalcemia or lung parenchymal sarcoidosis without lung function impairment and hepatic sarcoid. And then you have high-risk sarcoidosis, which were highlighted by Amit also. Lupus pernio, we don't see in India. We've not come across, lupus pernio. And you have severe uveitis, severe hypercalcemia, definite cardiac sarcoidosis, fibrosing or a progressive pulmonary sarcoidosis, CNS sarcoidosis. These are the ones which, you need to treat well with a good treatment initially, because these are the ones in which any degree of fibrosis or a scarring in an organ can lead to end organ damage. So this is the the weighing balance which you always need to keep in front of you when you want to start treatment. That do you favor a treatment or you favor an observation? So if you have a symptomatic patient, organ system impairment, organ endangered, progressive disease, severely symptomatic, a cardiac sarcoid, neurosarcoid, or a lung sarcoid with fibrosis, you would like to, go strongly on treatment side. But if you have an asymptomatic or a minimally symptomatic patient in whom you don't have evidence of, lung function compromise or an end organ damage, you may, favor observation. So these are the treatment indications which we have discussed. You want to take these decisions also taking into account the comorbidities, because we've seen diabetes is a very is a very frequent comorbidity in sarcoidosis patients. In our cohort, it was, I think, one of the commonest comorbidities. And if you give them high dose prednisolone, it can actually get their glycemic control out of the way, and you really don't know whether you are doing much benefit or much harm. So you always take into account whether the patient needs treatment and to what degree. This is also important because in most of the trials, the treatment goals of minimizing danger and maximizing the quality of life are not actually there. So how the treatment impacts these parameters is actually lacking in literature. Other important thing is that the interstitial lung disease and pulmonary hypertension are important parameters which would predict mortality and a lifelong exercise intolerance. So you should be very careful in watching for lung parenchymal disease and pulmonary hypertension. You pick it up early and you treat it early. So this is a bit about the workup. Workup is not very extensive because for monitoring, you really don't do a lot of fancy stuff. Once you've diagnosed, the monitoring is usually by a chest radiograph, a spirometry. You may add on diffusion capacity to it. And if you have, the facility and you do a 6-minute walk test regularly, this can be quite useful because it's actually the patient's overall clinical profile and exercise tolerance, which is most important parameter of treatment response. And as you heard from the previous talk, that it's not essential to do an echo and all, but I think an electrocardiogram, and if you have symptoms of cardiac involvement, you do a targeted echo, and at the slightest suspicion, you may undertake a cardiac MRI to rule out a myocardial involvement. Now, regarding the treatment and the drug treatment per se, so recently you had a treatment guideline from the, which was published in the ERJ, from the ERS regarding the treatment recommendation, in which they have tried to give some evidence base to how do you take these treatment decisions. So I'll just read as it is from that guideline, that for untreated patients who have a major involvement from pulmonary sarcoidosis, who are believed to be at higher future risk of mortality or permanent disability, we recommend the introduction of glucocorticoid treatment to improve the preserve the function, the forced vital capacity and quality of life. So, given that fact, if you have pulmonary sarcoidosis, patients who have significant parenchymal involvement or lung function impairment, and they're severely symptomatic, you would go on the side of treating them with systemic glucocorticoids, and they are the mainstay of pharmacotherapy. And it's usually a 20 to 40 milligram, which is the usual initiation dose given for usually a 6 to 12 months in a tapering dose. And important to note that lung disease is one of the major indications of long-term treatment. The other important thing is that we really don't have standardized and reliable or a gold standard measure of disease activity in sarcoidosis. So, it can be a difficult and a challenging call. That is why you take, most importantly, the clinical state of the patient, which is most important, and you integrate radiology as the second most important parameter, and then the lung function. Because lung function improvements may lag behind. It's the clinical, and if any of your patient is confidently improving clinically and radiologically, that patient is usually improving, and you won't have discordance on follow-up. It is usually, the lung function which may fail to improve as much, but I think lung function does tend to stabilize in majority of patients. So this is regarding the glucocorticoid effects. The data shows that clinical improvement does occur. There are fewer patients who experience clinical deterioration. Radiographic improvements also favor glucocorticoid treatment. Patients tend to deteriorate less radiologically. And pulmonary function, patients who have initial lung involvement, they tend to show a lung function improvement if you see them as a group. So this is what you do. Usually a 20 to 40 milligram of initiation prednisolone dose. There are varying, tapering regimens. But I think usually what we do, if you start with a slightly higher dose, try to get them to 20 milligram at up to 6 weeks to 2 months. And then you taper, and then you give a treatment for 6 to 12 months. You watch the patients for, most importantly, glycemic control, because a loss of glycemic control is the most important thing or most common thing which happens. Although a lot of other side effects are described, but in clinical practice, they are in my experience, they are not very, very common. But I think it's the glycemic control which really goes out in some patients. A trial regarding the dose, which was recently published from PGI by Dr. Sejal, was it was a relatively small sample study of 40 patients each in each group, regarding a higher dose versus a lower dose prednisolone for treating acute symptomatic sarcoidosis, with an initial dose of 40 milligram versus a 20 milligram. And what was found was that nearly half of the patients relapsed in each group, thereby meaning that there were no differences in prevention of relapse with a higher group, and the time to treatment failure, overall response, and lung function changes were also similar between the group. So this trial does add to knowledge in a field in which data is not very good quality and strong, that using a lower dose maybe is feasible, and it may have an equal beneficial effect in sarcoidosis. But I think there are a group of patients who are a little bit more in the higher risk category or a low risk category. So I think we do need actually larger and more powered trials, which may also give you a subgroup data that are these effects consistent across all the phenotypes of sarcoidosis. Cardiac sarcoidosis is potentially life-threatening. It can lead to sudden arrhythmias, even a sudden cardiac death. That is why important to diagnose. And it is important to note because you are a little more aggressive once you have a sign of a cardiac involvement. We don't see diagnosed neurosarcoidosis very commonly, but it's a cardiac sarcoidosis which we come across quite frequently, because the more the cardiologists have become aware, the more they are picking up. But I think the role of a pulmonologist comes in because you can give good inputs regarding the treatment dose, the duration of treatment, and add to the patient outcomes if you work in collaboration with your cardiologist. Regarding inhaled glucocorticoids, the RCT data does not really support strongly that inhaled glucocorticoids have strong benefits. And so the bottom line is that glucocorticoids are the first agent, and there are still unmet needs regarding the data of how to treat. You have the unmet needs regarding risk assessment, that which patients will progress to a higher disease. And there is also uncertainty because there is a practice with some physicians to add a combination therapy in severe disease upfront, that whether you hit hard initially, and then, as Amit also highlighted, that they use PET scan in disease activity assessment. We've got data that PET can actually give you a good assessment of the systemic disease, but I think there are radiation concerns that, and how frequently you can do a PET scan is also needs to be kept in mind. How high the initial glucocorticoid dose should be, we have this trial, but I think still we need more data that as a group, how it has a interclass difference between the various phenotypes. How long to stay on that dose and how to taper are also areas which one needs to see. Now coming to the second line agents, so there are certain patients who would require another agent because either of a glucocorticoid side effect, or once you've given them a glucocorticoid, they have relapsed again or have a treatment failure or a recalcitrant disease. So from the ERS guideline, for patients with symptomatic pulmonary sarcoidosis who are believed to be at higher risk of future mortality or permanent disability, who've been treated with glucocorticoids, have continued disease or an unacceptable side effects from glucocorticoids, there is a recommendation to add methotrexate to the treatment algorithm of these patients. So where do you use second line agents? Either your disease is progressing despite an adequate glucocorticoid therapy. This is basically a refractory or a non-responder patient we would call, or you have an inability to taper the dose, say below 10 milligram of prednisolone equivalent, and the patient says that once my dose is tapered, my symptoms can come back, or sometimes the radiology also comes back. Patients who have relapsed, patients who have intolerable side effects, and rarely it will be due to a patient's refusal or a preference, you may need to consider a second line agent. So you have many second line agents which are available, that is like methotrexate, azathioprine, mycophenolate, and leflunomide. Infliximab and adalimumab, which are the anti-TNF agents, I would put as third line agents because they are not very commonly required in our setting. So what you would commonly be dealing with are the first four agents. Out of them, the most common go-to agent which we have is methotrexate. And with azathioprine, you need to be careful about increased risk of infections, and you need to monitor liver toxicity with methotrexate. Although liver toxicity, which is manifest, is also not very common in this setting. So there are minimal randomized data and a few observational studies which have supported the role of methotrexate as a good steroid-sparing agent and does improve lung function. So this was one a retrospective study published in Chest in 2013, in which the authors had tried to see that whether there are any differences between methotrexate and azathioprine when you use them as second-line agents. And what was found that as in terms of clinical response and lung function changes, both the drugs fared equally well, but in the azathioprine group, there were more infections. So this is the dose algorithm. We usually start methotrexate as the preferred drug, and the usual starting dose is indeed 10 to 15 milligram given once a week, and you fix a day of the week, and then you give folic acid along with it on all the days, excepting the days of methotrexate. And the other drugs are also available, like leflunomide. Mycophenolate is also one drug which is coming up as a management agent for sarcoidosis. There is no large patient data. There's a small, around a 40 patient data regarding the utility of mycophenolate in sarcoidosis, which does support that, in patients who have some kind of intolerance to other agents, mycophenolate may be a suitable alternative. Although that data is lacking, that if they have not responded to a second agent, whether mycophenolate will be a useful agent in them. So these are the options you have, but I think in clinical practice, the most common agent would be methotrexate. So then you have, the third line drugs, which are for the same indication that if your patient continues to relapse or has a refractory disease, that even despite steroids, methotrexate, your disease is just not coming down, and patient has progressive organ dysfunction, extensive lung parenchymal involvement, you may consider the addition of infliximab. And we, in our practice, have found very few patients, I think, who would qualify into this group of refractory sarcoidosis. And I think in most of the patients, if you treat them for a good duration and time, this situation won't arise. But I think this situation can happen. And if you indeed have a patient who has failed to respond or is refractory despite everything, you may need to use anti-TNF agents. But our experience with anti-TNF agents is very minimal. So these are the agents, the infliximab or adalimumab. And there are also data coming on anti-B cell agents like rituximab, which may be considered in patients who are not responding to the usual second-line agents. Another drug is hydroxychloroquine. There's data on hydroxychloroquine for possibly treating milder forms of the disease, especially cutaneous disease, or for possibly people also use it for minimally symptomatic pulmonary disease. But good quality data on the outcomes and relapse rates is actually lacking. So summarizing, this is the algorithm which the ERS has given, that once you have a patient, you've diagnosed, you don't jump to starting treatment. You first assess the need for treatment. You see whether this patient actually requires a treatment or not. And then you try to, make some assessment of a low risk, intermediate risk, and high risk. And if your patient does fall into a low risk group, you observe the patient. You follow them up based on the organ which is involved. And then if on follow-up you feel that there is a need for treatment, you go ahead and start, glucocorticoids. In the intermediate group, you do start glucocorticoids, but go with a minimal possible dose. And now you have data that you can indeed go ahead with a 20 milligram dose. So if your patient is falling into possibly, an intermediate kind of group, I would think that this is the group you may consider, a lower dose, or if your patient is on a higher, risks of getting steroid-induced complications. If the patient responds well and good, you taper steroid. If it doesn't, you consider the second-line agents, primarily methotrexate. If you have a high-risk group, I think you would go ahead with a higher dose of glucocorticoids, and that's what is done for phenotypes like cardiac sarcoid, neurosarcoidosis, renal failure, hypercalcemia-induced renal failure, that you do start with a higher dose. And we would usually start with a 40 milligram dose, or sometimes up to a 60 milligram dose, up to a 1 mg per kg dose in patients who have high risk or a life-threatening involvement or an organ-threatening phenotype which is there. And then if there's a response, you do undertake taper. And if you feel, there are side effects or, relapse, you consider additional, switching to methotrexate. This cartoon I have brought, this is from a recent article. This is not a recommendation. This is a thought-provoking, approach that, what is usually done is steroids are given and then a tapering is given, and then you add other agents depending on the need. The authors in this group, have a thought-provoking approach that is early initiation of a hard-to-hit approach more useful in severe disease phenotypes rather than going with a glucocorticoid-based single-agent approach and tapering. So I think we'll have more on this, I think, in the years to come, that whether in the severe phenotypes of the disease like cardiac sarcoid or neurosarcoidosis or extensive pulmonary sarcoidosis, I think can you take this approach? But I think this is more thought-provoking rather than practical at the moment. And I think we'll see more of this in the years to come. Last but not the least, lung transplantation. It is an option in a minority of patients with sarcoidosis when all medical therapy has been exhausted. And according to the data, nearly 2% of all lung transplant are sarcoid-related indications. Indications will be NIHA functional class 3 to 4, resting hypoxemia, or a severe pulmonary artery hypertension. It may be challenging for the transplant surgeons because many of the patients who actually go on to require a lung transplant have an extensively fibrotic disease, fibrocavitary disease with maybe chronic pulmonary aspergillosis, or a lot of adhesions. So with bulky or fibrous hilum. So I think the lung transplantation per se is sometimes also challenging in these settings as compared to other settings of lung transplant. But the reported literature does suggest that long-term outcome after lung transplant for sarcoidosis in general, these are comparable to other indications. So concluding, sarcoidosis is a common cause of mediastinal lymphadenopathy in India. It is a very common cause of mediastinal lymphadenopathy. And I think you always need to keep it as a prominent differential once you have a patient with mediastinal nodes coming for evaluation, especially if you have a bilateral adenopathy. So if you have a right paratracheal, subcarinal, and bilateral interlobar or a hilar node, you would tend to think of sarcoidosis more than tuberculosis a large majority of the time. The clinical presentation is varied. Many patients are asymptomatic. And this is very important. To diagnose, you need to sit down with all the information you have, the clinical data, the radiological data, biopsy data, Montu test, and then you integrate together and see where most of the things are going. Mediastinal TB is a close differential diagnosis. Merely diagnosing sarcoidosis does not mean you start treatment. Many patients will improve spontaneously. So do try to categorize your patients to low risk, intermediate risk, and high risk, and also symptoms, and take a treatment call. And very importantly, you need to have a close clinical follow-up during clinical management, because I think I saw a question in the Q&A that whether, how frequently you see TB coming up after sarcoidosis treatment. It is not very common, but uncommonly, you will have situations in whom a reasonable degree of time after giving treatment and after tapering also, patients develop TB, but that does not mean there was TB from the beginning. Patients can have reactivation TB on background of sarcoidosis. So I think these are things which are only can be answered clinically and by closely following up these patients. Thank you.
Thank you very much, Karan. That was very nice and covered in detail. So we have some questions on the treatment in the Q&A, so I'll take them up. So first of all, what should be the duration of treatment? That is the most common question being asked.
Yes, very important question. I think a 6 to 12 months is what is recommended, and that is the clinical practice also. So I think you take those decisions also based upon what is the clinical response, say at 6 months, whether you have persistent clinical or a radiological activity, and many of the times you have to individualize these decisions. There are no clear answers. And I think we would usually give up to 9 months to 12 months, and some patients who have a very good response maybe stop at 6 months.
Right. Is there anything like fibrocystic sarcoidosis?
Yes, I think.
How do you manage it? How do you treat it? Also, there was a related question that if there is fibrosis, if there are signs of fibrosis on radiology, can you stop treatment after say 6 to 12 months, or do you like to continue?
Yes, so fibrocystic sarcoidosis, it is actually a radiological phenotype in which you have fibrosis, upper lobe fibrosis, and kind of scarring leading to a cystic appearance. Basically, it is something like a stage 4 sarcoid, mostly in which you would have a lot of fibrosis and cysts happening, because most of the patients who present upfront as pulmonary sarcoidosis really don't have a lot of cystic change. Some degree of fibrosis is common, but a cystic change is distinctly uncommon. So if you see a lot of cystic change in a diagnosed sarcoid, you know that this thing has been going on for quite some time, and you would like to treat the patient aggressively because you want to save every possible bit of lung which you can save, because already the disease is kind of an aggressive kind of disease. So the second question you had was, I missed the question on the
on the treatment, how you treat it, how long
Yes.
do you treat it?
So, yeah. So I think
Fibrotic sarcoid.
yes, I think if you treat active sarcoid, patchy linear streaky fibrosis is common. So even in treated patients who have responded well, you would tend to see some patchy. So it is the active nodularity which is most important. So if you compare the nodularity which is disappearing and you are left with only a fibrotic streak and patients clinically responded and lung functions are fine, I think just a mere presence of fibrosis is not an indication to unduly prolong the treatment.
Okay. Do you use antifibrotics in sarcoid? Is there any role or place of antifibrotics?
No. So in an upfront management of active sarcoidosis, we don't use antifibrotic agents. And the number of fibrosed sarcoid in our cohort are also not very much. And I think they are essentially like a progressively fibrosing ILD. So I think on a case-to-case basis, if you are dealing, you may take that call. But I think if you follow up a patient from a beginning, them evolving into a fibrocystic sarcoidosis is uncommon if they are treated well. Are you there, Sajal? I think Dr. Sajal has gone into a meditative mode. Okay, maybe if till Sajal joins, maybe we can take some other questions which we have.
Sir, Karan sir, can I ask a question?
Please go ahead. Please go ahead, Dr. Mansi.
Sir, regarding PET CT, when do you use PET CT in your treatment plan for a sarcoidosis?
So we don't use it routinely. We would go ahead with a CT scan and use an HR. An initial CT will be a contrast CT to give an idea of the nodes and the lung parenchyma along with high resolution cuts. The follow-up will be chest radiograph based. And then once you are wanting to take treatment discontinuation calls or you are following up, we'll follow them with HRCT. We have used PET CT for disease activity assessment and also for response monitoring as a part of a study protocol, but not routinely. What we found in that was that once you do a PET scan, PET scan will show you much more than what a CT is showing you, because it will pick you and give you the systemic sites of disease also. But then, do you really do PET scans, expose patients to radiations, and does it actually lead to a clinical benefit is something which we don't know. So that is why we would not use it routinely in all patients to, do response monitoring. In a difficult patient, you may do it, because, that will be a case-to-case decision.
Yeah, so there is a question on calcium. Like, do you supplement calcium during the treatment of sarcoid when you're using steroids? And when do you do it? Can you start it immediately when you're starting treatment, or do you add it in follow-up? How to go about it?
Routinely, we give it routinely at the time of treatment initiation in all patients, except the patients who've presented with hypercalcemia. So our patients who have presented with AKI due to hypercalcemia or severe hypercalcemia, those are the ones in whom we would avoid. But otherwise, we would supplement calcium and a proton pump.
How do you follow up patients on treatment? How
So-
often and what do you do during follow-up?
So the initial follow-up will be at 6 weekly for first 2 visits, maybe. And then we would maybe do a follow-up of 2 to 3 monthly can be also possible. The follow-up, because the first follow-up visit is the most important, because those patients who have to improve would show you a response dramatically within the first 1 month or 6 weeks. We would follow them up with a chest radiograph, a spirometry, and a diffusion capacity if it is available. And I think because we are also, followed them up as a part of, study. So we do a couple of more things like a 6-minute walk test and other things also. But I think a chest radiograph and a spirometry and a serum ACE level is something which you can use if the initial ACE level was elevated.
Tell something about aspergillosis in sarcoidosis. For example, fibrotic sarcoid patients might develop chronic pulmonary aspergillosis. So how often do you see it?
Yes. So out of the patients of sarcoidosis, we see the fibrocystic phenotype is itself not very common. If you do come across a patient with sarcoidosis who does have a lot of fibrocystic disease, you would, have a look at their symptoms and have a close look at their radiology. If on the radiology you see thick-walled cavities with intracavitary soft tissue, you would like to see the previous radiology. So if you have serial radiologies showing an evolution into cavities in which the walls are thickening and the intracavitary soft tissue is appearing, along with persistent clinical symptoms and serological markers like Aspergillus specific IgG, which is elevated, you would tend to diagnose CPA in these patients and then treat them appropriately.
Do you tend to add methotrexate right from the beginning? Like when we start steroids, can we also start methotrexate in some patients? And how do you select those patients, or is it not a practice at all?
So we don't do it upfront. Most of the times we'll do a glucocorticoid regimen in isolation, because if you see a large proportion of patients won't relapse. But I think an interesting finding is that in your cohort also and ours also, the relapse rates are quite high. So we have an excess of 40% relapse rate. So I think because every drug also has its toxicity, and you won't give methotrexate in isolation. So we would give steroids alone as the first agent in nearly all our patients. It's the one who relapse, the ones who develop steroid-induced side effects, or the ones who are kind of non-responders. We would consider methotrexate early.
So I think we can wind up now for the sarcoid part and go ahead with the next two lectures on hypersensitivity pneumonitis. Karan, I would love you to be here till the very end of the session, so you can participate in the next discussion also. We can take up some more sarcoid questions at that time if we have some time left at that time, because there are a lot of questions in the Q&A. You can also answer some of them by typing in. So thank you so much, Karan.
Okay, do I get a chocolate for that? Staying longer?
Yeah, sure.
Thank you.
Okay, so the next speaker is Dr. Mansi Gupta. She is associate professor at the Department of Pulmonary Medicine at the Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. Her areas of interest include mechanical ventilation, ILDs, endobronchial ultrasound, and other interventional pulmonology procedures. She has several awards to her name, and she's also actively working in an RCT, a multi-center RCT on hypersensitivity pneumonitis. So she's going to be talking about diagnosis of hypersensitivity pneumonitis. So over to Mansi.
Good evening, everyone. Good morning, everyone. Can I share my screen now?
Yes, you can, Mansi. You can start sharing your screen.
Yeah, is it visible?
Yes, it is visible. Make it full screen. Yeah, please make it full screen.
Yeah, I made it full screen. Just a second.
I think you need to share again. Just share the PowerPoint itself. Yeah, now make it full screen, please. Yeah. Can you move it to the next slide?
Sure, just a second.
Just try moving to the next.
Is it working?
Just click on the screen and try to move it. No, yeah, you can go back now. It is working well, so you can go back. Now you can start. Thank you.
Okay, so I'm going to talk about diagnosis of hypersensitivity pneumonitis. A lot has been covered in previous days' talks as well, but just the basic concept of hypersensitivity pneumonitis. It is very complex disease which is immune mediated, and it is a inflammatory as well as a fibrotic disease which starts at the airway level, and then it involves the entire lung parenchyma and interstitium in many cases. Now, it is also considered to be one of the commonest ILDs that we are encountering in our clinical practice, which is basically an exposure-related disease. And the exposure could be to a wide variety of identified and yet unidentified inciting antigens in typically susceptible individuals. And these antigens can be mostly of organic nature, but they can less commonly of inorganic nature as well. Now, the pathogenesis is not going into much details, but yes, it causes T cell and B cell hyperactivation, causing bronchiolocentric granulomatous inflammation. And with that, there is a complement cascade which allows further inflammation in the alveoli and the interstitium. And in many cases, there is fibroproliferative activity, which these cases may actually land up to become progressive fibrotic disease as well. Now, going to the diagnostic approach, as I said, it's a complex disease, and the diagnosis or making an accurate diagnosis can become quite challenging for the clinicians. But what is important is having a high index of suspicion in most cases of ILDs that they can be having in hypersensitivity pneumonitis. As all ILDs are now, we are following a multidisciplinary discussion approach in HP as well, and it is far more important in this disease because it is not only coming to pulmonologists and general physicians. Many a times patients are just carrying their scans to the radiologist, and they are having findings which could be suggestive of hypersensitivity pneumonitis, and then that is how interdepartmental discussions would increase the diagnosis in such cases. In many cases, the patients which are difficult to diagnose just by pulmonologists and radiology inputs, we need to have pathologists on board who have interest in ILD, and because these patients would be going biopsies sometimes. Now, these are the targeted diagnostic steps which we're doing in our patients. First is definitely evaluation of clinical symptoms. Then second is detailed assessment of the exposures. As I said, it's an exposure-related ILD, so we need to dig deep into the occupational and the environmental antigenic exposures of these patients. The next step is doing a good quality HRCT scan. This has been talked about yesterday also in all the sessions. The next would be whether we are doing serum-specific IgGs for the inciting antigens for confirmation of exposure or maybe as a screening tool. We will discuss that. And the role of bronchoalveolar lavage and histopathological findings. Now, why is it a diagnostic challenge? It is a heterogeneous clinical presentation. Not all presentations would be similar in terms of their onset of symptoms, in terms of their age, gender, and the type of morphology they bring, because it will all depend on individual genetic susceptibility, the type of antigen exposure, because there's a huge list of antigens, the extent of exposure, and also the role of other factors which could actually potentiate development of HP, which could be smoking history, viral infections, air pollution, drug exposures, and many other things. The second thing which challenges us is the exposure. Now, this is very difficult to identify, even in advanced centers in which have, ILD referral centers. The exposure could be sometimes very difficult to identify. And this basket of hypersensitivity pneumonitis would be called a cryptogenic HP or HP of undetermined cause, which could either represent an unidentified exposure or maybe an inherent intrinsic process. The other challenge that clinicians faced, as we are also facing in our center, because patients are going to multiple places for their diagnosis, we don't have a good quality HRCT scan as per protocol. And it has been highlighted enough in all the sessions that HRCT is the pivotal thing which is needed for diagnosis and classification of ILDs. Now, also, there is another thing which we should also keep in mind, that it was earlier classified as acute, subacute, and chronic, which was based on the duration of progression and onset. However, there was no clear-cut demarcation to these terminologies. That is why the latest guidelines, they have kind of, they don't want to continue with this kind of classification. And now they are coming up with a more objective classification, just classifying the patient based on their CT scan findings as fibrotic or non-fibrotic hypersensitivity pneumonitis. It not only represents the disease presentation, but it also is consistent with patients' clinical course and treatment-related outcomes. And the last thing is the challenge is that many of the patients would require evaluation at centers of expertise, because some patients would be requiring bronchoscopy, biopsies, and even surgical lung biopsies. There is nothing very specific about the clinical manifestations. The patients have similar symptoms like all ILD patients would have, but for HP per se, it is more commonly seen in women or older individuals, which the average age of diagnosis would be after 4th decade. And onset, as I said, that it could be acute onset disease of subacute, which could be in weeks to months, or it will have a more insidious onset developing over months to years. Now, the duration of symptoms, as has been highlighted by me earlier also, it has no relation, it has not been rigorously characterized to the development of fibrosis, as acute patients can also progress to chronic disease, but this is never not always the case, and maybe some patients never had an acute episode in their history. Acute and subacute symptoms would be after heavy or short-term exposures, and they will present mostly like flu-like symptoms in terms of fever, fatigue, malaise, chest tightness, and wheezing. And many a times at physician level, they get wrongly diagnosed as bronchial asthma and started on bronchodilators. Now, the symptoms in these cases may improve spontaneously or may require short-term treatments, but chronic symptoms, which we are concerned about, is they present at a longer time, they have low levels of exposure which are continuous, and they are mostly presenting with dry cough and shortness of breath. And these symptoms, patients may give history that they worsen at specific exposures that would be at work or at home or whenever the inciting antigen is exposed to. In physical findings, we'll typically get the crackles that we get, which are also known as chirping growls, and mid-inspiratory squeaks. And in advanced cases, we can have patient having respiratory failure, signs of respiratory failure. He may develop clubbing and cyanosis. Now, regarding exposure to inciting antigens, the list is, as I said, is quite long, and more antigens are being added to the list. But the most studied one are avian antigens, which are mainly from the birds, and fungi, then thermophilic bacteria, which can be from your home or working environment. But nowadays, more data is coming up towards inorganic chemical compounds as well, which are of low molecular weight nature. Now, as I said earlier, that in 30 to 50% cases, as per literature, the inciting antigen cannot be identified. This is a big chunk as we are dealing with, because otherwise, if you're able to identify antigen in a person, it definitely would help in the treatment outcome of the patient, because then you'll be more confident in removing the antigen exposure, and the treatment, the natural history of the disease might have an improvement. This is a list that I have picked up. I'm not going to share and speak about it, but there's a 4-page long list of antigens which are going to cause hypersensitivity pneumonitis. These are the documented ones. And there's fungi, there's yeast, and there's animal proteins in terms of animal dust and feathers. There are plant proteins as well. Amongst bacteria, we have thermophilic bacteria, then we have protozoa. There are chemicals that I have already said. So there's a huge list. Now, how do you identify the exposure? It could be very difficult to get, but again, the key lies in the detailed exposure history. So whenever we have a patient of suspected HP, we have to sit down with the patient, and we have to really spend time in discussing his residential location, the environment he's living, he's working into, the occupation, the type of exposures he's getting at his work, the hobbies that he's having, the people he's meeting. So it is a huge work to do when you're suspecting an HP. And in our busy practice, sometimes we're still not able to find out the exposure history very well. There are talks about development of relevant questionnaires which could bring about the exposure history, but as of now, unfortunately, we don't have validated regionally relevant questionnaires available. But there are many available in different studies which have been used. But the sensitivity obviously would be related to the regional relevance of the questionnaire. In India, we don't have a questionnaire which at least at our center, we don't have a locally relevant questionnaire that we. The most important job is to have a detailed history. Now, when you're taking history, you should also pay attention to the type of exposure. Just by merely asking that whether you are exposed to pigeons does not solve the problem. You have to understand that it has to have a temporality, it has to have a consistency and the strength of association. It probably, you can ask about the reversibility of symptoms, and those kind of things have to be looked into. You have to be more specific in terms of the exposure that you are defining. Now, here comes the role of HRCT. As for all ILDs, the HP, it is a very important and probably the most important when you start off working on a patient of suspected HP. So typically, you need a HRCT for two things, to find out the findings of bronchiolocentric inflammation, which is the characteristic feature of hypersensitivity pneumonitis. It will also tell us about the interstitial involvement and signs of developing fibrosis. So this is the key step in evaluating patients of HP. Now, another important thing in doing a HRCT is you need both inspiratory scans as well as the expiratory scans so that you can find out the features which are more accentuated on expiratory scans. So I will be coming to detailed CT scan findings in later slides. But one important thing is that CT scan, if you have a triple density sign on CT scan, it is quite specific for diagnosis of hypersensitivity pneumonitis in a clinically suspected patient. So coming on to the radiological features, as I've said, you have fibrotic and non-fibrotic HP. So non-fibrotic HP, you should have, the CT pattern can have 3 types of patterns. Either it is a typical hypersensitivity pneumonitis pattern, or it can be compatible with HP or indeterminate for HP. For these patterns, you have to see at least one finding indicative of small airway disease, which would be in the form of ill-defined centrilobular nodules, which are less than 5 mm, or features of air trapping. For feature of air trapping, you need to have a good quality expiratory scan as well. Then there would be one finding indicative of parenchymal infiltration. If you have mosaic attenuation and GGOs, along with the airway finding, it is going towards typical HP pattern. But if you have subtle GGOs, airspace consolidations, and lung cysts, along with the features of small airway involvement, it can still be compatible with HP. Also, we should also look at the distribution of findings, but if they are diffuse in the axial cuts and if they are diffuse in the craniocaudal cuts, then probably you're dealing with a typical HP if other findings are also supportive. But in compatible with HP, it could be a variable distribution. It could be a lower lobe predominant disease or a peribronchovascular disease as well. So look at the CT scan of this patient. This is a typical non-fibrotic HP. The upper cuts show the inspiratory scan and the lower cuts show the expiratory scan. And as you can see, there's a bilaterally diffuse axial distribution of GGOs. You can also see a lot of mosaic attenuation, some ill-defined nodules in the inspiratory cuts. And to accentuate the air trapping, they have done the expiratory scans, and this consistently fits with the typical scan in a non-fibrotic HP. For the fibrotic HP, again, it is classified into typical HP pattern, compatible with HP, and indeterminate for HP. And as I have mentioned earlier, in typical HP, you have to have at least one finding indicative of the small airway disease, which could be in the form of air trapping, ill-defined nodules, or a triple density sign, and at least one finding suggestive of fibrosis. Now, for fibrosis, what are the signs of fibrosis? You can have coarse reticulation with architectural distortion. You can have traction bronchiectasis, and you can also have honeycombing. And again, distribution of findings will be same as I've mentioned, that they could be random axial distribution and craniocaudal distribution. Incompatible with HP, you will have at least one finding suggestive of small airway disease, but you'll have variable pattern of fibrosis. You can have UIP pattern in this, or extensive GGOs, or with superimposed subtle fibrosis. And distribution of fibrosis will also be variable. It would be either upper lobe predominant disease or a peribronchovascular disease. So let us look at a fibrotic. This is our patient, one of our patients. She's a 56-year-old female with symptomatic disease for last 2 years. And she had significant exposure to pigeons and poultry birds. She had her own farm. And the CT scan that you saw, the lower cut on the left side, it shows the inspiratory scan. You can see typical signs of fibrotic HP. There is a random distribution of fibrosis with coarse reticulations. There's a lot of architectural distortion and traction bronchiectasis, and a lot of patchy GGOs and mosaic attenuation. Now, this is visible in the upper 2 cuts, and as you can see, when we have performed an expiratory scan, there is a triple density sign which has been highlighted. And triple density sign is basically that you have 3 different zones of attenuation. There is a normal attenuation coming from the normal parenchyma. There is a low attenuation coming from the air trapping and the decreased vascularity. And there is a high attenuation coming from the GGOs and the alveolar interstitial inflammation. So this is quite specific for HP. Another fibrotic HP, which is going towards compatible with HP findings. So the upper cuts are depicting the inspiratory scan and the lower cuts are depicting the expiratory scans. You can also see that it is an upper lobe predominant disease. The distribution is mainly in the upper lobe in the form of subtle fibrosis. There are ill-defined nodules, and there is some scattered mosaic attenuation. In the expiratory scans, you can actually see that the air trapping is getting more and more accentuated, and in some areas you can actually see the triple density sign here. Now, what about the diagnostic detection of cellular response to HB antigens? Now, should we be doing serum Ig testing against the potential antigens? What are the drawbacks of doing this test? Now, most centers and the labs that are performing these tests, they don't have standardized antigen preparations, and the techniques are still not standardized. There are variable diagnostic cutoffs. We still don't know which cutoff is valid for disease the causality, and the validation of many of the antigen preparations have been done in very limited population settings. So these are some of the drawbacks. But as per guidelines, what literature tells us that serum Ig testing against potential antigens, it distinguishes HB from other ILDs with a sensitivity, pooled sensitivity of 83%, but a specificity of only 68%. As far as distinguishing HB from HB patients with HB from exposed individuals is concerned, it is doing much better in terms of sensitivity and specificity, which is around 90%. And if you are doing this testing, it is distinguishing HB from other patients of unexposed control subjects with a sensitivity of almost 93 to 100%. This data is from recent literature. With the study population, the number of studies are very limited. But let me tell you one thing, that this test only tells you that the person has been exposed to the antigen, but again, it will not clearly tell us that the patient the disease is caused by that particular exposure. So it is neither confirmatory or not accurately diagnosing HB. Neither can you exclude the diagnosis of HB based on the reports of these tests. So when do you actually do these things? When there is a questionable exposure history, there is some bit of forthcoming history regarding an exposure, then you can actually perform these serum-specific IgGs to suggest a putative exposure. And when you have a typical HB pattern, it may raise your likelihood to make a diagnosis of HB. So under the guidelines, they have suggested the use of these tests, but with a very low confidence. Regarding other tests, tests like antigen-specific inhalation challenge or antigen-specific lymphocyte proliferation, this is not recommended as of now by the guidelines, again for the same drawbacks that I mentioned earlier. Regarding the role of BAL, so BAL fluid analysis, it plays a key role in distinguishing fibrotic HB from IPF and sarcoidosis. The data for other ILDs, distinguishing other ILDs from HB, it is not very robust, and in distinguishing non-fibrotic HB from sarcoidosis. So its main role is in distinguishing HB from either sarcoidosis or IPF. And if you look at the literature, the pooled sensitivity in distinguishing non-fibrotic HB with sarcoidosis ranged from 75 to 95% at BAL lymphocytosis. The cutoff was around between 20 to 40%. So what the guidelines recommend that for newly diagnosed identified ILDs whose differential diagnosis includes non-fibrotic HB, BAL lymphocyte fluid analysis is recommended, but again with a very low confidence. Regarding fibrotic HB, the sensitivity is a bit poor. It is around 40 to 70% with cutoff at between 20 to 40%. And it is the specificity is a little better when you are distinguishing it from IPF based on the clinical parameters. So as per the guidelines, they suggest that you can use BAL lymphocytosis as a criteria in cases of fibrotic HB when you're differentiating it from IPF or sarcoidosis, but again, the confidence is very low. What is the cutoff? There are different cutoffs which have been used in studies. In guidelines, if you ask, then latest guidelines by ATS recommend at more than 30%, and CHEST recommends it at more than 20%. So this is the final diagnostic algorithm. Then a newly diagnosed interstitial lung disease, you have to assess the exposure very deeply through the history. You perform a good quality HRCT scan, and then you do a BAL lymphocyte cellular analysis. You can perform biopsy here. I will come to that, when do you perform or not perform. And based on these, if you have identified an exposure with a supportive IgG test C1, and you have a typical pattern on HRCT, and you have biolymphocytosis more than 30%, after a multidisciplinary discussion, you can make a highly confident diagnosis of HP, and you can actually take decision regarding the treatment. In other cases where there are all other combinations of exposure, like history is not there, probably the findings are not typical of HP, the BAL findings are not supportive, you have an unclear diagnosis here. Again, you go for an MDD, you have to reconsider the exposure history and probably go for a biopsy in terms of a transbronchial cryolung biopsy or a surgical lung biopsy, and then you make a diagnosis based on the flowchart that I'll be talking about. So this is the flowchart that is very nicely elaborated in the ATS guidelines. So this says that if you have typical findings for HP and your exposure is documented through history or serum IgG testing, and you are performing a BAL, which is showing lymphocytosis, you can make a high confident diagnosis. But other than that, if you do a biopsy, you can make a definite diagnosis in such patients. So histopathology will give you a definite diagnosis even in such cases. But what about other cases? If you have compatible or indeterminate for HP pattern, then also you would require biopsy to establish at least a high confidence or a moderate confidence diagnosis in many of the cases. So biopsy should be avoided, as I've already clearly mentioned, that if you have a high confidence diagnosis can be made through MDD based on clinical and radiological findings and exposure history and lymphocytosis, biopsy should be avoided. When do you consider transbronchial lung biopsy? So the yield of transbronchial lung biopsy has been found to be better in cases of non-fibrotic HP cases than fibrotic HP, and also because of the very low complication rate in such cases as compared to fibrotic HP. So the guidelines have suggested that you can use TBLB in non-fibrotic HP cases, but they haven't recommended for or against its use in fibrotic HP. If you compare transbronchial lung biopsy with TBLC, the reported diagnostic yield with cryolung biopsies is a bit higher. But then again, the incidence of bleeding in the latest studies was in the tune of 10%, which is more as quite a lot in terms of if you compare it with transbronchial lung biopsy. Therefore, in suspected fibrotic cases, TBLC is suggested by the guidelines, but not in cases of non-fibrotic HP. And they have not actually made any recommendation for or against its use. There is no recommendation regarding using cryolung biopsy over surgical lung biopsy, but the diagnostic yield actually was found to be similar statistically, around 91% and 96% in HP. So they have no recommendation. But if you look at an meta-analysis published recently of 450 patients, they suggest that cryolung biopsy poses a low risk of morbidity and mortality over surgical lung biopsy, where the peri-procedural complications were in the tune of 2 to 3%. So I'm not going to elaborate on the histopathological features, just to tell the residents that there are non-fibrotic HP. 3 important components that they are looking at is cellular bronchiolitis, cellular interstitial pneumonia, and poorly formed non-necrotizing granuloma. This is the feature of non-fibrotic HP that they have to look at. And in fibrotic HP, there will be poorly formed non-necrotizing granulomas, airway-centered fibrosis, and chronic fibrosing interstitial pneumonia. These can be, but the presence of non-necrotizing granulomas are not essential to make a diagnosis of fibrotic HP. However, there should be absence of features which are typically excluding HP in the findings, which is presence of plasma cells more than lymphocytes, lymphoid hyperplasia, extensive well-formed sarcoid granulomas, and presence of aspirated particles. So if you have these features, you have to exclude the diagnosis of HP. Just a word about other assessments at the time of diagnosis. Never forget to do a good functional PFT, functional assessment with a PFT. Spirometry would reveal typically a restrictive pattern with significantly reduced maximum expiratory flows because of small airway involvement. And in lung volume measurement, you will have restrictive ventilatory impairment. You can also have, in many patients, a mixed pattern, and there will be significant impairment of the DLCO. Patients have to undergo 6-minute walk test as well, which would be later on required in the time of treatment assessment. And we also perform an arterial blood gas analysis, and we look at the right heart dysfunction by echocardiography. So the key points is it requires a high index of suspicion, as I mentioned, because you are whenever you're evaluating patients of recurrent flu-like illnesses or newly diagnosed ILDs, you have to employ a patient-centered approach in terms of obtaining a comprehensive and detailed patient history for their exposures. And if you have a history of clinical improvement with antigen avoidance, you may have a support for the diagnosis of HP, but the absence of clinical improvement will not rule out the diagnosis of HP. And sole reliance of IgG testing is strongly discouraged. It is neither to confirm or rule out the diagnosis of HP. You have to integrate the CT findings with the clinical findings of HP. So do not make just the diagnosis again on the basis of CT findings. Therefore, we need a MDD to make a highly confident diagnosis before performing even invasive procedures like bowel or lung biopsy. And in many cases, biopsy does give you a definite diagnosis and may be needed. So thank you for your attention, and questions will be taken now.
Thank you, Mansi. We'll take up the questions after Shitu's talk. So,
Okay, sir. Okay.
can you please unshare your screen? Yeah, so next we have how to treat hypersensitivity pneumonitis. And we'll listen to Dr. Shitu Singh. She is director of the Lung Center in Rajasthan Hospital, Jaipur. She is also an associate editor of the journal Thorax, also editors of various other journals. She has several awards to her name and about more than 40 publications in peer-reviewed journals. So over to Shitu. Yeah. Shitu, can you make it full screen? Yeah.
Yes.
Okay.
Very good morning to all of you. At the outset, I would like to thank Dr. Sehjal for inviting me here. It is my honor, and thank you for the kind words of introduction. And he has given strict guidelines to all of us to stick to time, and I'll try my best to do that. So, the talk that I have been assigned today is hypersensitivity pneumonitis, how I treat it, and why so. So now this is something that has a lot of gray areas, unfortunately, because we have very little data on it. But let's discuss what we have and what we are currently offering to our patients. So just previous to my talk, Dr. Mansi had beautifully described about non-fibrotic HP and fibrotic HP. So for the treatment of HP, this classification is also important because the treatment varies according to the type of HP. Just to simply summarize before I go into detail, non-fibrotic HP, the most important thing would be antigen avoidance. Then we have other classes of drugs which include corticosteroids and immunosuppressants. In fibrotic HP, antigen avoidance, corticosteroids, we don't know yet, immunosuppressants, question mark, and antifibrotics in cases of progression. So let us first and foremost discuss about antigen identification. Dr. Mansi had beautifully described how it is important that you need to identify the antigen, take a very good history, and then subsequently try to avoid it. So this was one very landmark paper published in Chest 2013 of 142 patients with chronic HP, as it was called back then. And here you can see the Kaplan-Meier shows the dotted line here is patients who had unidentifiable antigen, and the solid line is identifiable antigen. So patients who had identified antigen had a better prognosis as compared to unidentifiable antigen. However, surprisingly, when most studies evaluated the effect of antigen avoidance on survival, what they found was that there was an equivocal result. Some studies said that there was an improvement, others said that there was no improvement in survival. Why? Probably because, it is very difficult to quantify antigen and to tell that this is a particular antigen causing HP. Many times there may be multiple antigens. Sometimes it is also difficult to completely remove the exposure. There may be some exposure going on at microscopic level, which the patient may not be aware of. What about the drugs? So before I go to the individual medicines, how many of you use corticosteroids in the treatment of HP? I do. So I think many of you would be doing that. However, do you know on the basis of what are we giving the corticosteroids? On the basis of this 30-year-old small randomized controlled trial done on 36 patients of acute HP. That, mind you, this is 30 years back. We did not have the guidelines of how to define HP. We did not have good quality CT scans back then. And what did this study find? It found that at the end of 1 month, there was significant difference in diffusion. However, at the end of 5 years, there was no significant difference in the lung volumes, including FVC and diffusion. So this was a small study on 36 patients with acute HP, which did not show long-term benefit on the lung functions. Recently, there have been certain retrospective analysis of data which have given certain surprising results. Now, let me show you this. This particular study got published a couple of years back, retrospective, and they divided the patients on the basis of radiology as fibrotic and non-fibrotic HP. So what they found was that the median survival for patients of fibrotic HP was worse. So what you see here is the red is the fibrotic HP having worse survival. What we also see was that there was no difference in survival in corticosteroid treated and naive patients. However, there was a trend towards worse survival in those patients of fibrotic HP who were being treated with corticosteroid. So, no difference in survival in the first graph, but when you see the second, the fibrotic HP, those patients with corticosteroid treatment were having a worse survival. Again, you have to interpret this data carefully. This is a retrospective study. So it could have been that those patients who were more severe were getting steroids. Now let's have a look at the impact of corticosteroids on lung function. So in non-fibrotic HP, there was an improvement in the FVC after the patients received steroids, but no improvement in diffusion. In fibrotic HP, there was no improvement in either of the parameters. About avoidance of exposure on survival, again, they also showed that there was a worse survival in patients with an unknown antigen. However, avoidance versus unknown avoidance made no impact. So the plausible cause could be that I had previously discussed with you. So this study concluded that fibrotic patients experience a dismal prognosis without any therapeutic effect of steroids. Whether antigen avoidance is useful is still unclear. However, I would still recommend you all to avoid the antigens. Non-fibrotic HP patients experience an excellent survival with good therapeutic effect on pulmonary function test with both corticosteroid initiation as well as antigen avoidance. However, all these results have to be interpreted carefully because this was a retrospective study and referral bias was there and immunosuppressants were administered to a small group. So the dictum on antigen avoidance and corticosteroid use in HP with the current data is identify and avoid the exposure to the inciting antigen in non-fibrotic and fibrotic HP. Corticosteroids in non-fibrotic should be given at least for 6 months to 1 year and subsequently weighing the risk benefit, you can continue or discontinue them. Corticosteroids in fibrotic HP trial may be given after weighing the risk and benefit ratio. Now, what about the second class of drugs? How many of you are giving azathioprine or MMF in the treatment of HP? So I do give, but sometimes I may not give if the patient is not tolerating. So let us see what is the evidence that we have. Should we give or should we not? Unfortunately, again, we have only got couple of studies. Again, they are retrospective studies. So these have to be interpreted very carefully. So these studies got published in 2017, where this first study showed that the use of MMF or azathioprine was associated with decreased incidence of adverse events and no difference in lung function decline or survival when compared with prednisolone alone. The second study analyzed that treatment with MMF or azathioprine is associated with improvements in diffusion in patients with fibrotic HP. So the current dictum of using immunosuppressants in HP is if you have difficulty in weaning from steroids, there is steroid side effects or toxicity, or nowadays many times it happens that the patient refuses to take the steroids. So these are the subgroup of patients in whom I would like to give immunosuppressants. We had these similar data questions in our consensus statement on ILD. And at that point also, we discussed quite a bit. And due to the limited evidence we had, what we had inferred was that oral corticosteroids is appropriate for 4 to 12 weeks for acute HP with monitoring of lung function and side effects. Prolonged use of oral steroids or azathioprine or MMF should be based on the clinical picture. Now, what about the new kid on the block? That is the antifibrotics in fibrotic HP. So this was the inbuilt study. I think one of the most important and landmark study despite its limitation, where this study was a double-blind placebo randomized controlled trial in patients with fibrosing lung disease with more than 10% of the lung volume involved. And what they found was that the decline in the lung function in patients who were treated with nintedanib was much lesser than the decline in lung function in patients who were treated with placebo. So these were all patients who had a fibrosing lung disease, and what diarrhea was a treatment related side effect. However, again, there were certain limitations. It was unclear how the diagnosis was established in these patients, and only a small subgroup of patients were having HP. And there was a small group of patients who were actually labeled to have idiopathic interstitial pneumonia having a UIP pattern, which may be actually IPF, and thereby they were having they were being given nintedanib, which was already recommended for IPF. So the dictum on nintedanib is you can give it for patients with HP having a progressive pulmonary fibrosis, that is with worsening symptoms, or fall in FVC more than 5% or more than diffusion fall 10% in 1 year with worsening radiology, which may be increase in GGOs, increase in honeycombing, traction bronchiectasis, increase in coarseness or new reticulation, and lung volume loss. So I will now like to share a couple of slides of a case of a 32-year-old unmarried female presenting with shortness of breath and cough since 2015. Now, she had significant exposure. So she used to say that there was a AC on her bed, and when she used to come in the evening, her bed was full of pigeon feathers. So some pigeon feathers used to come through the duct of the AC. This was the CT scan. Now, this was 2015, where there was some GGOs, centrilobular nodules, some air trapping. We labeled it at HP in view of the pigeon exposure and classical radiological findings. I would apologize for the poor quality scan, but this was the time 2015, so I did not have the DICOM images with me. So we told her to avoid the pigeons, started her on steroids. She improved, though exertional hypoxia persisted. Now, one challenge is how to identify exposure. Dr. Mansi had beautifully described, to see how much it is, to see whether it is temporally associated or not. But having said that, it is still very difficult to actually clinch what is causing the diagnosis, what is the inciting antigen, because the things are not very clear clinically and when we encounter patients. So detailed history is very important at home, at work, and at places where the patient frequently visits. And sometimes patient feels that it is innocuous and it will not be of relevance to you, but dig deeper, and we still need validated questionnaires, which the ETS-ERS statement has also highlighted. Now, this patient was given azathioprine also for a couple of years. 2018, 2 doses of rituximab were given because there were some ancillary reports. She was doing okay. 2018, she got married. 2021, she conceived after understanding that she will have a difficult pregnancy. And this was the scan in March 2021, prior to the time she got pregnant. So what you saw was in the scan that showed initially some ground glassing, some air trapping, had now converted into a more of a fibrotic disease, upper lobe predominant. Pregnancy for this patient was, she was kept on steroid low dose, stable without increase in oxygen. 32 weeks, oxygen requirement shot up. She had to be taken up for C-section at 37 weeks. Delivery was uneventful, kept on 2 liter and 10 mg of prednisolone. However, third day, my resident calls me up, patient is having increased dyspnea, oxygen requirement shot up. We had to shift her to ICU on high flow and subsequently had to be taken up on HFNC. This was the chest X-ray. It showed florid infiltrates. Now, because we thought that there was an increase, we also did the CTP at that point, which showed no thrombosis. At this point, we made the diagnosis of an acute exacerbation of ILD. So this is one important challenge that we face clinically. Sudden worsening in respiratory symptom less than 1 month duration with new infiltrates, and you have ruled out the other causes such as infection, pneumothorax, and pulmonary edema. You can make a diagnosis of acute exacerbation, symptomatic care, maintaining oxygenation, and query steroids. So we started her on pulse steroid, intubated her due to respiratory distress. Despite adequate ventilator settings, she had acidosis and increased peak airway pressure. We had to initiate ECMO. Steroids were tapered, gradually oxygenation improved. And this, on day 10, this was her X-ray. ECMO ventilator were weaned off. She was maintaining oxygen on nasal prong, underwent pulmonary rehab, and started walking by the time she was discharged from hospital. So this was the X-ray, marked infiltrates which resolved. And this was the patient at the time of her discharge. So this is the joy. So many times my junior doctors question me that treating ILD is a depressing point. But, I always tell that there are certain joys, like we could give this child her mother. So similarly, these many patients do succumb to the disease, but till the time they do not, you need to cater to their symptoms, the complication of the drugs, their oxygenation, their quality of life. So I think it is a rewarding field, and you have to stay connected to the patient till the time they are. So this particular patient underwent 1 year of extensive physio. She was also given nintedanib. She underwent transplant 3 months back and discharged on room air on day 21. And do you know what was the diagnosis in her explanted lung? It was usual interstitial pneumonia. So one very remarkable thing is that once the inciting antigen has initiated the fibrosis, it may become self-sustaining at a point which can lead to end-stage lung disease. So this patient had HP, which later turned to fibrotic HP, and end-stage fibrosis at the end had a UIP pattern. So lessons learned is to differentiate acute exacerbation of ILD from an infective cause. High dose of steroids are useful in these patients. Early ECMO initiation in cases of high peak airway pressure, low PF ratio prevents the barotrauma and preserves lung mechanics. MDD, including pulmonologist, obstetrician, pediatrician, anesthetist, intensivist, and physiotherapist are important. Take-home message from today's case presentation were that every effort should be made to identify the antigen and avoid it in both fibrotic and non-fibrotic HP. Corticosteroid may be given in non-fibrotic HP. Benefit of corticosteroid in fibrotic HP is unclear. Immunosuppressants may be tried in patients with HP having weaning difficulty in steroid weaning, steroid intolerance, or side effects. In patients with HP having progression, nintedanib may be initiated. So we have come a long way from the ILD India registry and the PGI paper, where now we have an insight on the type of ILD in our country. We know the pattern, but a lot of questions still remain unanswered, especially when it comes to the treatment of hypersensitivity pneumonitis, such as what medication should be used, would MMF help, would azathioprine help, would steroids help in fibrotic HP. So something to look out for is probably Dr. Sehjal Dhuria's MycoHype study, that is the randomized control trial on MMF in fibrotic HP. And the second study that I'm actually looking forward to is the CHORUS study, which is a randomized control trial on steroids in fibrotic HP, which would be starting recruitment very soon in UK. So to sum it up, the woods are lovely, dark and deep, but I have promises to keep and miles to go before I sleep. So Dr. Sehjal, was I on time?
Yeah. So thank you, Shitu. We can take up the questions now. Mansi can join. Mansi, can you put on your video also?
Yeah, sure.
So recurring question is that what is the dose and duration of steroids in non-fibrotic HP and fibrotic HP? You have covered, but let us discuss it.
Yeah, so I think I did not cover the dose and duration because it is not very clear. We do not have any evidence. We still need studies, but what we are actually doing as per the experience is 0.5 to 1 mg per kg for a duration of 4 to 6 weeks, and then taper it subsequently at 5 mg reduction every 15 days of time. So this is how we go about, but we still need, should we start at 40 mg and 20 mg, a study similar to one that was done in the sarcoidosis. So a similar studies on this line for our HP patient, and we do need to know whether steroids would be working in patients with fibrotic HP.
Whether we'll make any change in the doses if patient is a diabetic or there are other contraindications to steroid?
Yes, I think if the patient is a high-risk group, immunosuppressed, already kidney disease, diabetes, then we can start at 20 mg also. So this is what I follow also, that any patient immunosuppressed, I start at lower doses also. And that low dose would take a little bit longer to respond, but the patients do respond.
Right. So somebody has asked whether non-fibrotic HP, how long will you treat non-fibrotic HP, and whether we go for a complete radiological clearance in that case, or what to do. Like sometimes In the literature, it is said that only antigen avoidance can also work in non-fibrotic HP. So how do you go about it? Do you just go for antigen avoidance? Do you go for a short duration of steroids?
I usually give for at least 6 months to a year period of time if the patient tolerates and the benefits are good, and then try to taper and stop it. Uh, However, having said that, I have noted only very few of my patients who actually completely are cured of HP, probably because we don't get that pure non-fibrotic HP very commonly. These patients generally present to us after they've had a longer exposure, say 6 months down, where the non-fibrotic disease has converted into the irreversible fibrotic form. So yes, probably if we get more aware and we are able to capture it sooner, we would be able to stop the steroids in 6 months to 1 year period.
Yeah, so what I think is that in clearly non-fibrotic HP, the one with the central lobular ground glass nodules, sometimes even antigen avoidance works. For example, if the patient completely changes his or her surroundings and we have identified an antigen. So there are a few, maybe a couple of patients who I saw who were able to regress without steroids. But yes, mostly steroids will be needed because if the patient is symptomatic, maybe 3 to 6 months for non-fibrotic HP. Complete clearance does occur in some patients, but sometimes what we think is all inflammation is not inflammation. Sometimes some amount of fibrosis has already started occurring, as Shitu pointed out, even if it is not showing up on the CT. So sometimes you see some vestiges or ghosts of those nodules, despite the patient completely improving, spirometry getting normal. Mosaic attenuation is more difficult to really take care of because once small airway involvement and a lot of obstruction has taken place, sometimes mosaic attenuation will not disappear, it will stay. So that was one of the questions along with the steroid thing. So another question to Mansi is that when we need to differentiate between fibrotic HP and IPF, so what to do for the biopsy part, whether we should go ahead with a cryo biopsy or a surgical lung biopsy?
We are already mentioned in the talk as well. We start with BAL actually. We are doing BAL a lot because especially our pathologists are helping us out with that. And BAL will help us in differentiating if you are using, if you are strictly asking about IPF versus fibrotic HP. Regarding the biopsy, patient's fitness is also very important. So depends on at what stage we are getting the patient. But at our center, we are doing far more cryo lung biopsies than patients being posted for surgical lung biopsies. And the yield of this is actually good in cases. But those patients who do not classify, who would not come for the they are not having the indications, they are contraindicated for undergoing any kind of biopsy, those patients we have excluded. So not all patients can undergo biopsy. I agree there on that.
Shitu, what is your opinion on BAL? Because we shared our experience that we are not finding a lot of BAL lymphocytosis even in clear cases of fibrotic HP.
So there is one thing is that fibrotic HP already we have in our country more of fibrotic HP compared to the West, I think. And that is why I think that we are getting less of lymphocytosis. We are routinely doing BAL for all our patients. However, it has taken almost 6-7 months period of time. We are trying to, logistically make it possible to send the sample in time. There are actually a lot of important things. One is it has to be taken in the proper manner. You wedge it, push in around 100 to 300 ml saline, then have the 30% return, then send it to the lab within like 15 to 20 minutes. If there is a delay, the cells may decay. Then your technician should be aware that that sample is arriving and they should do the cytospin in time. And your pathologist should be aware of what they are to look at. So there is this whole thing that you have to establish before you routinely start doing it. So we are still in the process, but yes, we are getting less number of our HP patients having BAL lymphocytosis. Couple of our patients had a biopsy showing HP, but the BAL did not show lymphocytosis. So as you had also mentioned.
Yeah. So it happens quite routinely with us because So, because patients come to referral centers late, and sometimes they have received short courses of steroids in their previous visits to other doctors. Even if they are now currently not on steroids, they might have received, and that might have some effect on the cell counts. So pure fibrotic HP patients coming in a reasonable time, say within say 1 year of onset of symptoms and without getting any steroids, that is a rarity to find. So possibly that is the reason that we are not finding a lot of
This is quite
lymphocytosis.
different from Europe also. Like we were there at ERS and everyone was there quoting, a bar lymphocytosis. But
Yeah.
in India, I think it is less common.
But in the mycoid trial, I see at Mansi Center, for
Yeah,
example.
I actually I'm sort of differing on this, but I'm not saying that in my center, when I started doing it in protocolized way for the trial per se, we are getting lymphocytosis. That is what I'm
Because
saying.
I see in your CTs also, the patients are presenting earlier to you than what we
Oh,
see at
gotcha.
our center. They
Okay.
come earlier, they have more ground glass and less of fibrotic change at your center. So possibly that is the reason. So these are the factors which one must consider. So if you, for the audience, see if you have a very fibrotic kind of disease, a long-standing disease, then you cannot really rely on lymphocytosis to differentiate between IPF and chronic HP. But if you have relatively a kind of fresh disease, lesser duration of the disease and less of fibrotic change on the CT, then it is likely that you will find more of lymphocytosis. So another question is how to treat acute exacerbation of ILD in a case of hypersensitivity pneumonitis. Shitu?
So the most important thing is symptomatic management. Manage the oxygenation, ventilation. Steroids may be tried, but first and foremost, you need to rule out infection in the form of, patient's symptoms like fever was there to start with. Was there purulent sputum? How are the counts? How is the procalcitonin? How are the cultures? Also, you need to rule out all the other causes that can cause worsening of symptoms, which includes pulmonary embolism, pneumothorax, cardiac failure. So once you've ruled out all of this, you can give a trial of steroids. Now there is a lot of pros and cons about the dosing of steroids, whether to give pulse steroid or not, what should be the dose. Further, we need studies on the dosing, but some steroids may be given ranging from 40 mg to 500 mg, depending on your experience, what you feel that the patient has a pure exacerbation and there is no infection. I have given 500 mg pulses also. Then there is certain medicines like rituximab, which have some experimental role. Some case reports have been there, but still we don't have good evidence how to treat. So it's more of a symptomatic approach.
Yeah, I'll agree on that. That going for steroids and especially pulses is a very individualized decision. First, you have to really rule out other causes. Sometimes it's a viral pneumonia, sometimes it's a PCP. So always be careful in a immunosuppressed patient about PCP. So you have to take a very individualized approach. There is no literature to support. There is no blanket suggestion that we can give. So another question is how to follow up patients with HP on treatment. How frequently to perform spirometry? Should we go for other pulmonary function tests? Do you perform a CT on follow-up?
So I think
Basically, okay,
Yeah,
yes.
Mansi.
Mansi, go ahead.
So but I just wanted to point out because this was not part of the diagnosis, but what studies and literature, this progression of disease is quite common in fibrotic HP. So if as per the literature in our center also, we are finding because maybe the burden of HP is very large, uh, uh, almost like 40 to 50% patients of progressive ILDs are coming from HP group, fibrotic HP group. So in those patients, definitely, as guidelines also point out, and those patients require regular follow-up in terms of spirometry as well as radiological scanning. But we are doing pulmonary function test more frequently than CT scans, which is usually what other physicians are sometimes practicing. Almost 3 monthly is the protocol. In a patient who's stable, we can do it 6 monthly also. So 3 to 6 monthly, we are doing spirometry for our patients. And in case the patient is showing any signs of clinical worsening, then we are also performing CT scan within a year. But in those patients who are stabilized, we are not performing routinely doing HRCT scans on follow-up.
I will agree on that. So routine HRCT on follow-up is not needed. Where we do perform for documenting improvement is where, say, there's some fibrotics, there are some signs of fibrosis on the CT, but there's a lot of ground glassing and certain areas which look with some reticulation, some fine reticulation, which appears to be somewhere in intermediate between inflammation and fibrosis. So there we sometimes do perform repeat CT after 3 or 6 months, just to document whether those areas have cleared up or not, so that we have a new baseline CT for looking for any worsening in the future. But if you have already a fibrotic disease, then you needn't go for a CT to document improvement, because if there's a lot of traction, a lot of honeycombing already taken place, then you are not expecting them to actually regress. And that's true that if you have any worsening, then to really identify progressive pulmonary fibrosis, CT might be done, as Mansi pointed out. So role of antifibrotics and nintedanib in fibrotic HP, Shitu?
So as we were discussing just now, that any patient who has a worsening of the symptoms or fall in the FVC of more than 5% or diffusion more than 10% in a year's time, or worsening radiology. Worsening radiology in terms of increase in the ground glassing in the area of fibrosis, increased traction bronchiectasis, increased honeycombing, reduction in the lung volume. All these things, 2 of these features would tell that this is progression. And one of the most common causes of progressive pulmonary fibrosis is fibrotic HP. I think this is all across the world. I recently had a chance to see some data from UK, and there also the most common cause of PPF is fibrotic HP. So nintedanib is the only drug which has been studied till now, which we have evidence of, but probably there will be some studies coming up on perfenidone, inhaled perfenidone in PPF. So time will tell about that. But in patients with fibrotic HP with progression, you may start nintedanib and see how it goes from there.
Yeah, I'll agree on that. So any role of starting nintedanib upfront in fibrotic HP?
I would personally not do it unless until patient is very, very sick, and that too, like, that's a rare condition. I would
I
still
mostly
start with steroids and immunosuppressants and see how the patient does and how the lung functions are with that.
Yes, I agree with you. Documenting initial response to immunosuppression is important so that we know how to go about immunosuppression in future treatment. So if there's some response, then you know that immunosuppression might be continued for long. If there is no response and continued progression, then you may as well leave out immunosuppression. So again, duration and dose of MMF. So dose is mostly 2 gram per day, targeted dose. Sometimes you can go up to 3. If the patient does not tolerate, then 1 gram per day might also be okay. And duration is again indefinite, no evidence, but we usually treat for a minimum of 1 year. Then Mansi, there's a question that how long does the antigen which causes HP remain in the surrounding even after you say clean the place or try to remove the antigen macroscopically? And does it also remain in the airway or in the atmosphere?
What literature says, I don't know about the duration, till what time it will be there in the surrounding. That will depend on a lot of factors like the airflow and the other hygiene things. But in the airway, they say that once the person is susceptible and the inflammation has started in the airways, so sometimes the removal of antigen doesn't stop the disease right away. So it totally depends on our genetic susceptibility, how the inflammation goes. When the antigen is taken away, probably some patients will improve spontaneously, but a major chunk will still can have disease progression despite changing the environment also. So that's how it is.
Yeah. So there have been some reports that especially bird antigen. Sometimes if a house which was left empty has been completely infested by birds, and then there is some cleaning done, and then somebody shifts into that house, the antigen may still be there, although macroscopically you have cleaned the house. So that antigen can still be there, and it has been documented that it can still cause HP. Role of okay, if patient is on domiciliary oxygen, should lung transplant be advised?
Mansi, you want to take it up? You are on mute, Mansi.
Transplantation, there are now strict guidelines when to refer the patient and when to enlist the patient. So those guidelines have to be followed. But yes, on a broader level, any patient who's documented to be having a progressive disease and has come on oxygen, at least he needs to see a transplant surgeon, so that he should be referred to a center for evaluation. And especially if it is an exposure has not been documented, we don't know it is a progressive disease. So that time, I think we would like to at least refer him to a center. Yes.
Yeah, so I think
Point.
domiciliary oxygen is not a contraindication. If the patient is moving about, so there are certain parameters of 6-minute walk test, etc. So if the patient is not bedridden, then domiciliary oxygen is not a contraindication. Rather, it may be an indication to refer the patient. But yes, if a person is completely bedbound and debilitated due to the disease, or the patient has advanced disease and is on ventilation, then it's not a routine transplant that occurs. Then it is a transplant which happens in any kind of ventilated patient. For example, even ARDS patients who develop advanced lung fibrosis acutely might go in for transplant. But usually in chronic disease, you'll take this decision to send for a transplant much earlier, because such patients keep on losing their overall physical health and overall functional status. And if you keep on waiting till the time that they have lost all their physical activity, then they are not good candidates. Yeah, Shitu, you try to.
I just
say
wanted
something.
to emphasize that point only. The trend is that we send the patient to transplant when they are very, very sick. So, for example, the patient that I discussed today, we kind of mentally prepared her. We didn't want to send her on an ECMO for a transplant. So we got her off the ECMO, put her on rehab. She was walking 10,000 steps per day when she actually went for transplant, but she was on oxygen. So the outcomes of the transplant would matter on the physical condition and the capability. Now, if she has good muscle mass when she is going for a transplant, that is why she could actually get weaned off and discharged post-transplant on the 3rd week. So if you send a moribund patient with very poor muscle mass, the outcomes of the transplant will also not be favorable.
Yes, I'll agree on that. So we have few more questions, but we may be running short of time. Maybe we'll take one or two. So somebody has asked about BAL. So mostly we go ahead with a 120 ml saline injection into a segment for BAL. Mostly we do not exceed it in patients with extensive lung involvement. So the question was basically whether a 300 ml kind of BAL fluid be tolerated in extensive lung involvement. So that said, that we usually go for a smaller amount. 120 ml has been documented to give a good return. Then there is a question on all right, the use of ICS, inhaled corticosteroids in HP, whether alone or along with OCS.
So, airway-centric diseases, I mean, there is some bit of evidence of use of inhaled bronchodilators, but as a routine, it is not recommended in purely restrictive pathology. But if your patient is like in non-fibrotic HP cases, some patients just do not tolerate very high doses of steroids, and they have some documentation of improvement with inhaled steroids. So in those patients, yes, we do use sometimes.
Chitu, your opinion? Shitu?
Yes, so steroids, the primary studies have been on sarcoid, inhaled steroids in sarcoid, and they also showed very equivocal results. In HP, there have been no studies I only give to some of my patients who say that they get a relief in the cough after they take the inhaler. So it is
Yeah,
only
agree on
based.
that. Yeah. So it is very individualistic and based on clinical judgment only. Sometimes people with sarcoid and HP might have comorbid asthma. They will have very typical symptoms of asthma, might even have eosinophilia. That also happens. So you always rule out comorbid asthma in especially elderly individuals. Go on and look for a kind of cardiac disease, because cardiac disease can also cause some wheezing. The obstruction sometimes can be irreversible, and it is due to actual architectural distortion of the airway. So it might not respond to ICS or even LABA. So you have to really go with the hit and trial method, as Shitu rightly mentioned. So I think we can wind up now, and some of the questions can be answered in the question answers box, which I keep on answering. So I'll clear up all questions, and Shitu, you can take up some of these questions if you like. I'll take just a 5-minute break now, just to prepare for my MDD. Shitu, you can take up some questions. In fact, in that time, you and Mansi can take up some questions. I'll just mute myself. Shitu,
There are some questions. There are some questions here. Yeah. So,
You
Shitu,
can verbally take it. Mansi, maybe you can take the questions, pose it to Shitu, and answer yourself also. Yeah.
so there is a question regarding most common group of antigens which we should be inquiring on our clinical practice in a patient, given the level listing of antigen. So basically, some of the professions are more, like the farmers, that they are. They are more exposed to these antigens based on their exposure to hay, and especially the harvest times. Other professions, like the persons who are working in bakeries, they are working in flour mills. So wherever there is more chunk of organic dust, you can see. Then poultry workers, the workers who are working in cattle farms, those kind of patients would have it more. Then certain, newer. If you're really interested into digging more into these things, then probably painters and those people who are working in industries which are for paint and ceramics. Those kind of exposures are also important. So these exposures can be specifically looked into, and use of this pigeon exposure. A lot of times in India, these people on religious grounds, they start feeding pigeons at a particular pace on daily basis, so they are more exposed there as well. So those kind of exposures can be specifically asked into. Otherwise, if you have no specific forthcoming history from the patient himself and the questions that you have decided to ask, then probably you have to just look at the extensive list, and then find out that probably he's exposed to that. The next question regarding would be, we had a patient of cystic lung disease diagnosed as HP on surgical lung biopsy with no known exposure history. So any experience with such cases and pathologist report needs to be reviewed. Shitu, would you want to answer that? Presence of cystic lung disease in HP, surgically diagnosed case or biopsy diagnosis case.
So yes, we also get a lot of discordance between the imaging findings and the pathology findings. So here, because even the pathologists are understanding how to see the slides, and they may also, so here a second pathologist opinion would be very useful. I agree to that, as this Dr. Prakhar has mentioned here. So a second opinion is important. And even if the second one says that this is HP, yes, so there can be such cases where you see discordance. There are some areas HP can have a varied presentation radiologically as well as pathologically.
Is doing conventional TBLB equally good for making histopathological diagnosis of HP, and which pulmonary lesions should be targeting while taking a biopsy? So I've answered this in my, I have already mentioned that TBLB is not recommended routinely, or it is a person's individual choice, but it is more likely to give a good yield in non-fibrotic HP patients than fibrotic HP, and also the complication rates are lesser. So if you are substantiating, if you really want to substantiate your diagnosis with a biopsy, But I'm only talking of patients where you're not able to make a highly confident diagnosis, which rarely happens in a case of non-fibrotic HP. So yes, the role of TBLB is little low these days, and with a good quality scan and an exposure history if you're found. But if you have to perform a TBLB, then you can actually, and since it is typically HP is a diffuse disease and a peribronchovascular distribution, so you can target based on CT scan, you can target any of the sites which are more involved with the disease. So TBLB definitely can be performed in such patients. We used to do more TBLBs earlier, but now with scans and other things coming up, we are able to make high confidence diagnosis without invasive procedures. So we are doing lesser number of TBLBs nowadays for HP also. The other question is, what is your opinion on starting antifibrotics in patients presenting with acute exacerbation on the background of progressive ILD? Would you start in an acute exacerbation antifibrotics?
So, because of the PTF, I may start the antifibrotics, but there is currently no evidence for antifibrotics in acute exacerbation of ILD. So, I will start them, but for the PPF, not for the acute exacerbation.
So you will not start them while the patient is in acute exacerbation. It was already, suppose a patient is already on antifibrotics for PPF and gets an exacerbation, then you might as well continue it. That is what you say.
Yeah, even like if they have
Yeah,
PPF,
Shitu, I think there has been some confusion created on this, and you rightly answered it. Because nintedanib has been shown to reduce acute exacerbations. I see a lot of people asking me that whether these drugs are good for the exacerbation. So it's not that these drugs work during an exacerbation, it's actually they prevent exacerbations. So you rightly pointed out that an acute exacerbation needs to be treated with supportive measures, with finding the cause and treating it, and finally with some steroids, but not with antifibrotics. You can start an antifibrotic as soon as the exacerbation is through and you are now ready to discharge the patient. That will be the better time, because if you have a sick patient, you already are giving him a lot of drugs. Maybe you are covering with antibiotics. Maybe you are giving some kind of PCP treatment. And then if you give another hepatotoxic drug, it's not a good idea. He may not tolerate it at that time. So once you are discharging such patients, that will be a better time to start antifibrotics. They don't start their activity immediately. The antifibrotics take some time to really have to start their activity. So I think we can end the session now. Some of the questions can be taken up by typing into the Q&A box, and we can start the MDD. So we have Shitu in the MDD as the clinician. Do we have Dr. Alok there? I don't see Dr. Alok here. So Mansi, you can join in sir's place, I think. And do we have our rheumatologist? I don't see our rheumatologist. I'll just. Yeah, so he's here. Aadhar, you're there, so right. Okay, so I might as well start with the case. It's a very short and simplistic case, I would say, but it is slightly off the routine that we usually see in a lot of our MDDs. So I see commonly the same cases being repeated. So I have put a case which is slightly off the usual, and it is not very difficult, and it is also very short case. So with that background, I'll start sharing my screen.
so I get to meet Aadhar online rather than in person, despite being in Jaipur.
Okay. So can you see my screen? Yeah, Aadhar, can you see my screen?
Yeah, it's visible.
Okay. So I'll give you a very short history and we'll proceed with the basic kind of findings. We just need to impart some. Dr. Uma has not joined us, I think, the radiologist. Dr. Uma?
Yes, Dr. Sajal, I'm there.
Yeah, okay. Can you switch on the video also?
I don't want to switch on. It's
Okay, that's fine. So the basic history was that this was a 40-year-old female who presented to us. She belongs to Yamunanagar, Haryana. She is a homemaker. She has been symptomatic for almost 5 years. She had breathlessness of MMRC grade 2. She had some cough with mucoid expectoration, which was minimal. She had some vague chest pain. On like a routine kind of history taking in the chest clinic, we didn't find any evidence of any complaint of joint pain, significant morning stiffness or swelling, no Raynaud's skin thickening, muscle weakness, and no history of exposures to organic and inorganic dust. She was a non-smoker. Additionally, there was nothing to really feel that there was anything cardiac. So there was no orthopnea, no paroxysmal nocturnal dyspnea, and there was no angina. So that was the kind of short history that we have. So do you want any more particular history concerning any particular system or anything? Shitu or Mansi or Adhar? We just have a patient with cough and breathlessness, and we are just looking for some CTDs here. We have ruled out cardiac based on history, any cardiac disease, and we don't have any other exposures. Obviously, we are discussing ILD, so it is somehow related. So I'm not going to into the details of other kinds of history. So I may as well proceed to the next. So on examination, there was no clubbing. The saturation was 96% on room air, so might be in the normal range, but a little low normal. The chest, CVS, and abdominal examinations were all normal. Within no abnormalities were detected. I would say that it was mostly a OPD kind of examination where we did auscultate the chest, auscultate for the CVS, and did a simple per abdomen. So that was within normal limits, nothing found. Breath sounds were clear. There were no adventitious sounds. The usual investigations, blood counts, blood sugar, hepatic and renal function tests were all normal. Yeah.
So
Dr. Aman, are you listening to the case? I'll just
the
confirm.
family history would also have been interesting because, like a young female, 40-year-old, probably family history would also have helped.
Yeah, so there was no family history of any particular chronic respiratory disease or interstitial lung disease. That is true. Family history should be asked for. I'll once confirm with the pathologist also. Dr. Aman, are you online? Dr.
Yes,
Amanji?
yes, I'm
yeah,
there.
yeah, I saw you. So, okay, you might as well switch on your video, ma'am. Yeah. So this is the CT of the chest of this patient, and it is quite obvious what is the major abnormality. But I would like Dr. Uma to really comment on that and give us some differentials. Dr. Uma?
Yes, it's audible.
Yeah, so Dr. Uma is our radiologist. She's an additional professor of radio diagnosis and imaging at PGI Chandigarh. And I requested her at a very
Am I audible?
the CT. I don't have DICOMs, so I just have these film images.
Okay, actually my internet is unstable. So this is a HRCT film, film cards, thick section films. A mediastinal window is not provided. Only how we are seeing the pulmonary windows. Here, multiple variable size cysts are seen in bilateral lungs. Some cysts are rounded and some are elongated. And few of these cysts are seen, I think there are thin septations are there. The cysts are multilobulated. They are predominantly in subpleural and paramediastinal location, diffusely distributed in bilateral lungs, and broad-based towards the few of the cysts shows broad-based towards the pleura. They're relatively thick-walled, not that much thin-walled, and some cysts are clustered in the right middle lobe and superior segment of the right lower lobes also. And in addition to that, the bases are relatively spare. In addition to that, there is a small penury of consolidation is in right middle lobe with surrounding gigios. The bronchi, relatively peribronchial thickening is there. And few ill-defined nodules are there.
I can really go to the next image, which just gives us a bigger picture. So now you can
See,
really
here
see
the cysts are elongated in right middle lobe, and few of them showing septations are within it. The cysts are also multilobulated. And adjacent, these are not bronchiectasis, because adjacent to the cyst, the bronchi are seen clearly in right middle lobe. Dr. Sehgal, right middle lobe with peribronchial thickening. The bronchi are here adjacent to this cyst. So, and there is no bronchiectasis. I think, according to me, these are the cysts only. And few predominantly right side, cyst predominant is on right side, and there is no pneumothorax. There is no suggestion of rupture of any of these cysts. Can I go to next slide, please?
Yeah, sure. But I would like to ask here, because the walls of the cysts are a bit very thick, I suppose.
Yes, yes.
Do you agree, Dr. Shitu? Do you feel that the walls are thick? So cystic bronchiectasis is really a kind of differential, and we have had such questions yesterday during the last session, whether how to differentiate between cystic bronchiectasis and cystic lung disease. So actually, Dr. Uma gave a very good point. If you have the entire entire DICOM on the console, then you can really trace all the bronchi and see whether they are getting dilated to result in cystic bronchiectasis. But even in the films,
you see that oblong type of thing, and it looks like a bronchiectasis or a ABPA patient having the dilated bronchi till the very end. But if having a DICOM image can really help and help you follow.
Sure, but the point that Dr. Uma really pointed out was that, see, you can see these bronchi at in the walls of the cyst, near the walls of the cyst. So actually, these are the places where the bronchi are ending. So these are not bronchi which are getting dilated. They are there in the walls of the cyst. So that's why we call them cysts rather than cystic bronchiectasis. Am I right, Dr. Uma?
Yes, these are cysts. Looks like, but because they are going to the periphery also, and they are quite dilated, and it looks like elongated cyst rather than bronchiectasis, because the bronchi are nearby. It's seen.
So this is the last image. So it essentially shows the same thing. You can just maybe comment on the location of the cysts.
The cysts are predominantly, few cysts subpleural, paramediastinal, and peripheral cysts are also seen. And left side the bases are spared actually. Otherwise, the cysts are more pronounced on right side, and there is no nodule or any other. No nodule within the cyst. Otherwise, I think few ill-defined nodules are also seen in left lower lobe. I'm not sure, because these are thick sections.
No, these seem to be thin section to me. I think 1 millimeter sections they are.
Okay. Yes. So peribronchial thickening is there, but and so there is few nodules in left lower lobe. I think posterior basal segment.
Maybe these are supposed to be vessels. Maybe some bit of scattered nodules, but not prominent. That you're right, that they are not very prominent. There we might see some nodules. Yes, there's some ill-defined nodules here. Some ground glassing.
Actually, one of the cysts is showing air fluid level also. If you see in the inferior lingula, maybe impacted mucus is there. I'm not sure.
So there's some thickening of the, either a localized thickening of the wall, not a very clear level, but yes, there is some thickening there at the wall. There is some consolidation and ground glassing.
Yes, in the right mid. Yes.
Some ill-defined nodules. And do you see a lot of ground glassing, Dr. Uma, whatever we can make out here?
Actually, I'm not sure, because this is not a proper inspiratory film also. Diffuse ground glass maybe there. Yes, maybe there in left side, but
so really, you cannot really
difficult to comment upon.
Yes.
Can you show the one with the tracheal cuts? Tracheal sections help out sometimes.
Unfortunately, we don't have all the cuts. Shitu, we had lost the image, the main CT film at that time. But I can just tell you that it was lower lobe predominant. Most of these cystic areas were in the lower lobes. There were some in the upper lobes. Only this much ground glassing, as you see in this particular image, was present, not anything beyond. And we had these areas of some nodule-like formations, some ill-defined nodules, and these cysts, which really have some blood vessels also in the wall. Dr. Ma, as you can see,
Yes, yes,
in the
yes.
walls, we can
Huh.
make out some blood vessels.
Yes, perivascular
And yes, these
cyst.
bronchi go very close to these cysts, and they are not
Yes.
actually, those bronchi are not getting dilated and getting into the cyst. So the first learning point here is that these are not cystic bronchiectasis, although in the first go you might confuse it with the cystic bronchiectasis. So these are mostly lung cysts. So I'll first ask Sheetu, what kind of differentials will you entertain here? And then I'll come to Dr. Uma. If Mansi is there, so Mansi can also comment what differentials can we have here.
Is Mansi there?
You can start first.
Okay, so in a young female, although they are not very uniform, but it's a cystic lung disease, we will think of lymphangioliomyomatosis. Then the second would be other cystic ILDs such as LIP. I think that's about it. Mansi, you take it forward.
Would you consider PLCH? Would you consider Birt-Hogg-Dubé? So we had a cystic lung disease lecture last evening, and a lot of attendees might who are currently there might have attended that. So these are the four classical cardinal cystic lung diseases that Dr. Nishan Gupta also dealt with. So amongst them, Sheetu has put LAM as the first differential. 2 is LIP. And will you consider PLCH or Birt-Hogg-Dubé?
So we can consider what histiocytosis in a female unlikely.
Yeah, so LCH in a female is less likely, correct? Also, the cysts are at the septae. Several cysts are located at the septae, which is also a feature of Birt-Hogg-Dubé. So that also remains a possibility. Now, Dr. Uma, would you like to comment whether this is consistent with the LAM or more
No.
consistent with the other one of the other three?
Now, my first differential is Birt-Hogg-Dubé that you told. Actually, the cysts are predominantly in lower lobes, as well as multiseptated, elongated, as well as round subpleural paramediastinal cysts that are more common in Birt-Hogg-Dubé. And otherwise, these nodules and patchy consolidation, I am not sure. There are few ill-defined nodules are there. These are not consistent with Birt-Hogg-Dubé, and this is not a LAM, because in LAM the cysts are actually well defined, and in between the lung parenchyma will be normal and they are diffusely distributed. And in pulmonary Langerhans cell histiocytosis, the bizarre-shaped cysts are there, bilateral, diffusely distributed, and nodules can be seen. And the patient are there male predominant, because in smoker these are more common, and nodules will be there. And in between the lung parenchyma also not that much good, but the bases are spare in case of pulmonary Langerhans cell histiocytosis. So my first possibility is Birt-Hogg-Dubé.
So Sheetu keeps LAM first. Dr. Uma has kept Birt-Hogg-Dubé first. I'll agree that LAM might not. LAM will be much more uniform and smaller sized and uniformly sized cysts. Mansi, do you have any other differential to offer? We need the first differential because we might know we have 4 differentials. It might be something fifth also if you want to bring in. There are other causes of cystic lung disease if you want to get something in, but those 4 definitely we are considering. Beyond that,
in a young asymptomatic patient without any prior history and this kind of CT, again, my differential are 2 main will be Birt-Hogg-Dubé and LAM in this patient. And I don't know, somehow I feel that considering the LIP, I don't know, I'm not very sure of LIP keeping it as a differential here, LIP, because the cyst size and the look parenchyma, I don't know, Uma ma'am is saying that it is not normal looking, but the intervening parenchyma doesn't look that diseased to me as such, in terms of the more cystic changes and surrounding that there are changes. But LAM would still be a possibility. I don't want to keep lamb away from the differentials. It would be the two main differentials for me would be lamb will also be there in this. Berthold Dubé and lamb, yes.
I think the
Okay, LCH is
consolidation and the
LCH is
mucus
LCH, no, I don't want to keep LCH as of now because of the distribution and the intervening parenchyma not showing much changes. And it is a low predominant disease, like Madam has already pointed out.
the rheumatologist. Adhar, you are here, although the history does not show anything rheumatological, nor does a basic examination. So, Shitu, will you send this kind of a patient to a rheumatologist at all?
I think for the initial workup, I would, because you need a complete workup to thoroughly exclude that there is no connective tissue disease. If there is a connective tissue disease history, then it can be explained to have a LIP pattern. So, and nowadays, a lot of patients demand, no, I have to see a rheumatologist, please rule out that. So, I think even in the MDD also, we should get a rheumatologist opinion, and there is no harm in not getting it done.
So that brings me to it that whether in all MDDs we should have a rheumatologist or only in selected
In
MDDs.
clinical probability, young female, you would like to rule out a connective tissue disease, keeping aside the scan also, like even if there is a LIP, but a young female, you need to rule out CTD.
Okay. Adhar, are you there?
So the clues that you can get whether you need a rheumatologist or not would be from a set rate. So if you have an elevated ESR, a positive CRP, or if you have a lymphopenia on the CBC, so you have not given us the differential counts. So they'll point towards Sjogren's, the possibility of Sjogren's.
Sjogren's, why will you keep the possibility?
Because the only CTD with the cystic lung disease at the initial onset will be a Sjogren's syndrome. You don't expect that as the first possibility in RA or in CTD or for a myositis.
You're just guessing by this is that you see there.
So
Okay, do
that's
you want
how-
anything more in the history?
So Sika is something that we usually ask for, and especially the dry eyes and the dental caries more than the dry mouth. Because once the patient reaches you, already there is a dry cough. And so there is cough, there is brittle.
You told us last evening that for IPAF, interstitial pneumonia with autoimmune features, Sika is not at all true
Yes,
symptom which
so
can be
that's for
considered.
IPAF. That's
Yeah.
not true for a cystic lung disease,
That is
where the
right.
first possibility, the only possibility from our side is the Sjogren's.
Okay, so what this patient complained of was some vague dry mouth. That is all. She had some vague dry mouth, vague meaning that she did come out with the history. On asking, she said that yes, that types. So, what would you like to do next? So Shitu, what would you like to do next?
Did the patient have any skin lesions?
No skin lesions.
Okay.
No specific skin lesions, I would say.
So I
Yeah,
think
the question is right. So why do you ask for skin lesions? See, we are just delving on the approach. So these questions are what we need to discuss.
sometimes you often miss these Berthold Dubé skin lesions, and
T-shirt के लिए
which
So
are
fibrofolliculomas, right?
कर
So
लो।
as we came to know from Dr. Nishant also, all the audience, that
क्या बोल
Dr.
रहे
Uma,
हो?
can you mute yourself? Dr. Uma, can you mute yourself? Yeah, so skin lesions, and he showed a very good image of the skin lesions last evening. So a good thorough skin examination. Sometimes these lesions can be missed, as Shitu said. So a good thorough skin examination, sometimes even by a dermatologist, is required if you are suspecting Birt-Hogg-Dubé syndrome. Anything else, Shitu? You also suspected LAM, so maybe something for tuberous sclerosis also. So skin lesions.
Again, skin lesions. So for both Berthold Dubé and for tuberous sclerosis, you need to have a look at the skin properly and to see the lesions, and then get all the accessible tests done, such as an ultrasound abdomen can give you insight for kidney lesions in LAM and tuberous sclerosis. So I think getting the genetic testing would be slightly difficult, but before that, every feasible test to rule out the differential diagnosis of cystic lung disease can be done. Getting a rheumat opinion, if they feel they can get a connect like a ANA. Would Dr. Adhar, would you like to do a ANA in this, and would that give us insight?
Usually, yes. Because that offers a hope for treating the patient actually.
So there was another question yesterday that whether you need ANA-RF in all patients. So this patient has some vague Zika symptoms, at least to a pulmonologist, it seemed to be a vague kind of dry mouth symptom. Whether it is required that we do RF and ANA in all diffuse lung disease patients, and this patient has diffuse cystic lung disease. So what is your take? Like we saw from the rheumatologist that antibodies are ordered only on the basis of clinical suspicion. So what do you say, Adhar?
That's a catch-22. So had this been, let's say, UIP, and from what you have shown us till now, had this been UIP, I'd have said, no, don't order an investigation. It will mislead you. But once you're looking over a cystic lung disease, and unless I'm very wrong, patient would be better off having Sjogren's rather than anything else. So then, yes, then order just an ANA, don't order an RF.
Okay.
Take
Right.
it as
So
an
that is-
IPAF. Yeah. So the problem with the cystic lung disease is it's not part of IPAF.
Yeah.
It's
So
not-
what we do is, yes, you are true. You are right. So we're not dealing with IPF, that's for sure. But it was just a discussion whether antibodies, autoantibodies, are routinely required in most of the patients with diffuse parenchymal lung disease, whether it is inflammatory, fibrotic, or cystic. So you say that it may be individually decided. For example, an elderly smoker with a UIP pattern. So you have diagnosed IPF clinically. So you might not require any antibody at all. That is true, but as a routine, we usually do an ANA and RF somehow, and we are open to interpretation. Like even if it is positive, we don't completely conclude that the patient has a CTD. And especially for us pulmonologists, sometimes we might miss actually some signs of rheumatological disorders in a quick clinical examination in the OPD. Either we send all our DPLD patients to the rheumatologist, or sometimes we take help of these investigations to sound us that we might have missed something. That happens with me at least. That sometimes I get an ANA positive, a clearly positive, and then I go back to the patient and go into the details because of the short time I usually have with my patients. So that way it helps. So Adhar has asked for an ANA. Shitu has asked for an ultrasound, abdomen, and skin examination, and she has asked for some kind of genetic testing. What genetic test do you want to do, Shitu? What genetic testing you asked something about?
Yes. So I have forgotten. I'm
Follicular
jet
gene,
lagged.
mean, yeah, right?
FLCH.
Yeah, FLCM, yeah, follicular gene, right?
Yes.
So Mansi, anything
Yeah.
to add? Anything
I
to
just
add?
no, I think the discussion is going great, but I think I want to ask Adhar and this patient in cystic lung diseases, if any patient would come with this CT, so we will be doing the connective tissue workup, serological workup, even if the patient is not having any frank signs. We are routinely doing these kind of tests. So you don't recommend in the OPD seeing a cystic lung disease? I mean, I just want to know because we are doing ANA and RA screening in all the patients, and this one HIV also.
See, this patient with respiratory symptoms and especially cysts will not go to Adhar at all unless we send that patient to him. And if we are sending
No,
that patient
if the
to him,
history, I wanted to say that if the history is not forthcoming, that even the pulmonologist will shy away from sending to a rheumatologist. So I want to know at your center probably, sir, that are you sending such patients to a rheumatologist at all? Cystic lung diseases.
No, we are not. We are not. We
are not
just
sending.
rely on whatever some bit of history and clinical examination we are doing in the OPD. But we do at least 4 antibodies, rheumatoid factor, CCP, ANA, and as part of our data collection. And sometimes, as I said, we get a red flag there that this is positive, significantly
After
positive.
you're doing the serology, so that's what I'm saying. We are doing serology in these the tests we are doing.
Yeah, so
Okay.
If I can interject.
Aadhaar serology is a
So if I can, yeah.
poor
So the
replacement
point is-
for a rheumatologic evaluation.
No,
But
you see-
sometimes, yeah.
If I can say something.
Yeah.
So the point is, you don't have to follow a broad-based approach for these patients. So once you have so let's say for IPF, yes, or if you have a UIP, then yes, the workup should be done for all patients. Because there it makes a difference. For NSIP, definitely, without a doubt, the referral should be taken. For a cystic lung disease, rather than go for an RA, CCP, ANA, and ANCA, that's actually wasteful. Because even if you get a positive report, other than a Sjogren's syndrome, you'll not be able to fit in. So it's better to go for an anti-Ro and anti-LAS specific antibody rather than end up. See, if you're going to do a lot of tests, the probability of getting a false positive increases magnificently.
Yeah, true.
So once you have cystic lung disease, just rule out Sjogren's.
Yes. So I completely agree with Aadhaar that for cystic lung disease, all these routine tests might not be needed. What I meant was that in DPLDs as such, not cystic, but in DPLDs as such, we will mostly do these 4 autoantibody tests. So we'll go to the next slide finally. So we asked for skin, there are no specific lesions, follicular gene, no mutation, ultrasound purine, no renal tumors. So how to proceed now? So Aadhaar asked for an ANA and a ROLA, right? So we did an RF and a CCP, and RF was positive, but less than 3 times the upper limit of normal. ANA was 4+, and the pattern was speckled. So should we do a RO and LA?
Yeah, absolutely. Now you have to do that.
Or should we go for the entire ANA blot?
So makes more sense to go for specific antibodies by ELISA.
Yeah. Right.
Immunoblood is likely to give you a very good false positive rate, actually.
So it seems that the row 60 was 3+, row 52 was also 4+ amount, and the La was again 4+. So we did it by blot basically, and we got these results. So what to do next?
Now refer to the rheumatologist.
So Aadhaar, you tell us what to do next.
Actually, what you now need to do is go for a Sherman's test and do either a minor salivary gland biopsy or a salivary scintigraphy, because now you have to, so you have already.
So salivary scintigraphy revealed impaired function of the right parotid and submandible glands. Minor salivary glands showed multiple focal periductular fibrosis and moderate lymphoplasma cytic infiltrate with focus score of 1, and Sherman's test was normal in bilateral eyes.
I think that's good enough to call it Sjogren's. Now comes the part for you to do a biopsy and prove that it is LIP actually.
Yeah.
We did a cryolung
biopsy here. Did we do a BAS or
cryobiopsy? In connective tissue disease, we already
No. So I'll tell you why this was done. So why this was done was because initially we got an ANA and the patient got it from outside, and she brought a whole panel. She got this RF ANA and everything done. And the ANA was somehow done by ELISA, and it was some positivity was there. The upper limit was 20, and she had some 30 or something. And we didn't expect any rheumatologic disease to be there. So actually, we proceeded with the biopsy, and then when we got the biopsy done, then we had to go in for ANA by IF at our institute, and then we got these results. So this is the pitfall that we fell into. That ANA by ELISA, we just ignored it. We thought, okay, it's not required. We also didn't really expect LIP. That was not our first differential, I would say. But yes, it was one of the differentials. And then we went ahead with
us also.
Yeah.
In the biopsy, when you get such a diagnosis and you get the test, sometimes they are negative at the first instance, but when you get them done the second time, they come out to be positive.
Yeah, so I'll go to the CT, to the biopsy. And I have robbed Dr. Amanjeet of the pleasure that a pathologist always sees, at least in our PGI, especially in CPCs, that the clinician has no clue, and then the pathologist always shows something surprising. but we have taken that pleasure of Dr. Amanji. Dr. Aman, are you there?
Yes,
Dr.
yes,
Aman?
I'm there. I'm there. Yeah.
Yeah, you can please present. You can keep telling me to move the slide, and I can.
Okay, right.
Or do you have the presentation with you?
I have, but then I'll have to share the screen.
Yeah,
If
yeah.
you
So
have the slides, then it's better.
yeah,
You
no. I'll stop sharing because you need to point out also certain features. So you can start sharing.
okay? Can you see my screen?
Yes, ma'am. Can you? Yeah.
Okay.
Can you make it full screen really, because it is not coming on the full screen. It is showing the next slide. Maybe it's due to you have an Apple, right?
Yes, yes.
The
So I think for me,
okay,
it's
I think
full
it's fine.
screen.
It's fine.
Yeah.
It's
Okay.
fine. It's fine. Yeah.
So in this case, we received a cryo-lung biopsy, and as you see, majority of the surrounding lung parenchyma appears normal, and the pathology is limited to the centrilobular areas, or we can say peribronchiolar. So this is bronchial lining epithelium, and we have inflammatory infiltrate around the bronchioles, and here also. So on high power, if we see the type of infiltrate is dominantly mixture of lymphocytes and lots of plasma cells, and it's around the bronchioles, and there is some smooth muscle hypertrophy also. And in addition to, there were formation of lymphoid follicles and with some prominent geminal centers also. And this infiltrate was slightly extending into interalveolar septa also. But the interalveolar septa were not widened and they were not diffusely involved by this lymphoplasmacytic infiltrate as we see in a lip. So the infiltrate was dominantly concentrated around the bronchioles. And this is a closer view to show one lymphoid follicle with prominent geminal center. And in addition to this, we had these cysts, which were thin-walled, and they were in the periphery of these bronchioles, which were showing lymphoid infiltrate. And they were lined by flattened lining epithelium only. So with these findings, we called it follicular bronchiolitis, and there were secondary cystic changes in the adjoining lung parenchyma.
Yeah, so it was my mistake. It was a VATS lung biopsy, I suppose, not a cryo biopsy. I made a mistake there. So, Dr. Amanjit, you have committed on a diagnosis of follicular bronchiolitis. We were suspecting more of LIP. So, there is a pathological differentiation between the two, right? So, you can just elaborate, like you said, that the septa and the lung parenchyma.
So for lip, the infiltrate should be in the interalveolar septa and they should be quite widened. And the type of infiltrate is lymphocytes plus plasma cells. But here it's only peribronchiolar and there is no extension into the interalveolar septa. So lip is not the finding here.
All right. So we had a discussion last evening with Dr. Nishan Gupta, who's an expert on cystic lung disease. So what he said that we usually don't make that differentiation between follicular bronchiolitis and LIP for clinical purposes, because both the diseases may be associated with cysts and they essentially are associated with the same kind of comorbid illnesses, and they are treated in a similar manner. So that's why we have this diagnosis, and that is what you gave us. This is an old case, but for the audience, clinically you will deal with them similarly. Any views on this? Adhar, first you might comment.
So now that you have shown us the salivary scintigraphy and the biopsies, this goes towards Sjogren's. But let's say, so it's not infrequent for patients to be Rho and La positive and not have any features on either salivary imaging or on the eye testing. And that is where it actually gets interesting. So, like yesterday, also someone had asked that if you have a renal tubular acidosis alone with ROLA positivity, would you call it Sjogren's or not? So, there, the idea now is that yes, if you have organ specific manifestations, you can. But now, let's say you go with a diagnosis of follicular bronchiolitis, some ROLA positivity, and the biopsy, as ma'am has kindly shown. So now you can actually go towards IPAF also. Because this lymphoid aggregates that you have shown, that ma'am has shown, is one of those histological descriptions of IPAF.
But other follicular bronchiolitis with ROLA positivity, salivary scintigraphy being positive, and even salivary gland biopsy being positive, why would you not commit on Sjogren's?
That's what I'm saying. Now that you've shown salivary dysfunction, this is Sjogren's. Not everyone will have access to salivary scintigraphy.
Yeah, sure.
There's a lot of variability and problems in reporting of nuclear imaging everywhere.
Right. So what you are telling is that LIP with Rho positivity without any symptoms or investigational evidence of salivary gland involvement, then you can call it IPF. That's right. That I agree.
That's what I'm saying. Because there is a big problem now. Once you move away from the institutes and you go to the other centers, so nuclear imaging and nuclear reporting is a very contentious issue. So that's one thing. But I think for me, this was Sjogren's the moment was Rohan lab positive. But that will carry a treatment significance, what you're classifying it as.
Any comments from Shitu, Dr. Uma?
So you had already leaked the paper to Dr. Aadhar.
No, not at all. Not at all.
I was
Aadhar,
just
it's a joke, but yeah, not at all. That
See,
is the point.
this is not the typical HRCT finding of LIP. So it doesn't look like
agree.
at all. Another sisters.
Some features are a bit different, but I would say that it is not inconsistent also. We saw yesterday also in Nishant's lecture that these last cysts are known to occur, and now we have all the corroborating evidence, and that's why it is an interesting case. It's not really straightforward.
Yes.
Right. So any other comments? Maybe we can take up some questions if they're there for the MTD.
Dr. Sehgal, can I leave?
Yeah, you might. Yeah, sure. Carry on, please.
Thank you.
Okay, Aadhar, somebody has asked, which is better, ANA blot or ENA profile?
So if you have money, ENA is better. The blot by definition is an imprecise method. So it's the poor man's ELISA.
Okay.
So if you're able to, the idea behind doing a blot is, so let's say if you have no clue as to what you're looking for, then the blot gives you more antigens. But if you have narrowed it down to a differential diagnosis, the ELISA is better.
Okay, so the message for the audience is that always go for an ANA with an indirect immunofluorescence. But when you are subtyping the ANA, ELISA is the better method. Is it the better method for all the ANA subtypes, all the Aadhar?
So the problem with the ENA profile by ELISA is that the number of antigens are limited to 7 or 8. The most commercial labs are going to do a very limited number of antigens. So that's why if so, like in this patient where we are very, very clear that we're looking for Sjogren's.
Yeah.
Let's say we're looking for lupus, so then it helps. But let's say if you're that's the difference. Okay, so as Aadhar said, if you know the particular autoantibodies to look for, and if they are available in the ENA profile, for example, ROLA here, or if you have dsDNA, which you want to look for lupus, or even SCL70, so you can just ask for that specific ELISA, SCL70 ELISA or ROLA ELISA. Don't go ahead with all the autoantibodies in the ENA profile because it becomes very costly for the patient. Mostly it costs 5,000 rupees or more in our setup. So don't go for everything in every patient. That's the message. I think we can wind up now. The other questions we can take later. And so we'll have the next session at 12:40. And I'll announce we'll have another quiz. We had a quiz yesterday. So we have the second part of the quiz at 3 p.m. today. So all the participants who are currently there, please inform your friends and you also be there. And the Google link will be mailed to you. Also, we'll have a QR code on screen, which you can immediately scan at that time and answer those quiz questions. So we'll take a short break of about 10 minutes and we'll be back, and then we'll start with the rare ILD session. Any parting comments from Dr. Amanjeet? I didn't invite her to. Ma'am, any other comments, any other particular
No, that's all. Yeah, thank you.
Right. Okay. Thank you so much. I'll take a short break and then we'll join back in 10 minutes. Welcome back. Manu, you are there, right? So can you unmute yourself? So this is Manu. Yeah.
Yes, sir.
Manu?
Can you hear me?
Yeah, so this is your link that you got, right?
Yeah, I've got my link, sir.
Okay. I can't hear you. I can't somehow hear you.
Can you hear me now, sir?
Can't hear you. Just a minute. Just a minute. Okay, maybe there's some other problem. I've connected this right now. Yeah. So yeah.
Yeah, can you hear me, sir?
Yeah, I can hear you.
Okay.
So okay. Next we have Dr. Naveen Dutt. Is he here? Dr. Naveen Dutt is here. Dr. Naveen, are you there?
I'm here only.
All right. Okay. So we can start with the next session in about 3 minutes. Dr. Vikas Marwa, are you there? Dr. Vikas Marwa? Dr. Vikas, are you there? Okay. Kalmanu, can you check with Dr. Vikas and maybe he can join?
Yes, sir. I'll just call him.
Yeah, he'll be the next speaker after Dr. Naveen. So we'll start at 12:40 sharp. Thank you. Next session, which is on rare interstitial lung diseases. And I purposely kept this session in this particular conference because these are diseases which are usually don't find a place in the usual ILD workshops that we have. So we are devoting a full session to this particular entity. So we'll discuss a lot of rare ILDs. ILDs are already rare diseases, but amongst ILDs also we have certain rare subtypes. We are going to discuss drug-induced lung disease, pulmonary alveolar proteinosis, PPFE, which was proposed in the last classification of ILDs, then some depositional diseases, and then finally occupational lung disease in the form of silicosis and pneumoconiosis. So first we'll have drug-induced diffuse lung disease, and for that we have Dr. Naveen Dutt with us, who is professor and head department of pulmonary medicine at AIIMS Jodhpur. He has more than 100 publications. He is a fellow of several societies and has won numerous awards. So over to you, sir, to start dealing with drug-induced interstitial lung disease. You can start your video, audio, and start sharing your screen.
Dr. Sehjal, Very good afternoon. First of all, I like to congratulate you for this very excellent program with all the important topics and the rare topics also. So I think this is the need of the hour. So without wasting much time, I'll start with my presentation. Uh, so my topic today is the drug-induced ILD. I hope you are able to see it.
Yeah, so can you make it full screen?
Just a second. Hmm. There's nothing.
You're not audible, sir.
Naveen sir, what I'll request you to do is that unshare the screen and then share it again with the PPT, sir.
Okay.
Yeah, so actually select the PPT while you are sharing the screen.
Correct.
Select the particular PPT.
Is it fine now?
Now go
Yes,
to
but
the full
can you?
slideshow. Just on the top menu bar, there's a slideshow option.
Slideshow.
Yes. If you
There
can
is
see your home, in the home bar itself, the sixth one is a slideshow.
more. There is not home.
No. See in the top row, you can see file, home, insert, draw, design, transitions, animations, and then slideshow. In the top horizontal bar.
I'm not seeing any horizontal. Only there are mute, stop video, participants, chat.
No, in your PPT, sir.
Okay, no worries. Sir, I'm going to ask for request control. Just give me the control, sir.
Okay.
Just accept it, what I've sent it to you.
Approved.
Thank you. I'll just do it for you. Okay.
Okay. Oh, sorry. Okay. I was.
Yeah, you can go back to the first slide, sir.
So my
Yeah.
topic today is drug-induced ILD. So drug-induced ILD is one ILD which we all know, and the diagnosis, especially the presumptive diagnosis, is not very difficult to make. But somehow in the real life scenario, we miss a lot of drug-induced ILD. So today I'll be discussing drug-induced ILD, but my focus will be mainly on diagnosing drug-induced ILD. And the important thing is, for diagnosis of drug-induced ILD, we might not be knowing the every drug or the pattern associated with it, the pathology associated with it. Just few important things are sufficient to make the diagnosis of drug-induced ILD. So when we are doing the workup of an ILD patient, so we are given the clinical picture as well as the radiological picture. So what is the first question which we try to answer? Normally, what we try to rule out is whether it's UIP or non-UIP, because we need to decide whether we want to give antifibrotics or we want to give immunosuppressive therapy to the patient. Basically, we want to rule out IPF or non-IPF. So, but in most of the ILDs, especially the fibrotic ones, whether we start antifibrotics or immunosuppression, normally disease still progresses. So there is one more important question, more important than IPF or non-IPF, which is important in all ILDs, whether it's idiopathic or secondary. So if a ILD is secondary and we are able to diagnose it, so we can stop the further progression of the disease. And in many cases, especially in the drug-induced ILD, we can stop the disease progression and we can reverse the disease also. So the first question which we should be looking to answer doing the workup of a patient with ILD is whether it's secondary or not. The important secondary ILD are CDE, the CTD, drugs, and environment. So the drugs and environment, the drug-induced ILD and hypersensitive pneumonitis, these two are very important and should be ruled out in every patient. So when we talk about the drug-induced, around 5% of the all ILDs, they are drug related. And it can be a understatement also, because many a times, especially the new ILDs, they are missed. There are more than 400 drugs which have been associated with the ILDs. And it can be a very mild disease, which might be a subclinical disease only visible on a CT scan, or it can be a very life-threatening disease, it can be fulminant respiratory failure. So the most important part, we should be knowing what are the drugs which can cause the drug-induced ILD. So it's a systematic review. So the cancer drugs and the DMARDs, these are two groups of the drugs which cause around 75% to 90% of the drug-related ILD. So the anti-cancer drugs is the main bulk. Around 50% of ILDs is caused by the anti-cancer drugs, and rest, the DMARDs and the minority are the antibiotics, anti-arrhythmics, anti-epileptics, anti-psychotics, so all sort of drugs. So when we talk about the anti-neoplastic drugs, the mTOR inhibitors, they have the highest frequency of the drug-induced ILD. Then immune checkpoint inhibitors, TKIs, the monoclonal antibodies. Then there are traditional anti-cancer drugs like bleomycin, busulfan. In DMARDs, we use them in the treatment of ILD also. Methotrexate, leflunomide, gold, cyclophosphamide, these are the drugs. Antibiotic, the nitrofurantoin is most common, and the antiarrhythmics, amiodarone. So these are the common drugs which cause the drug-induced ILD. So when we talk about the anti-cancer drugs, so the mTOR inhibitors, the sirolimus, they have 10 to 60% incidence and up to 20% mortality in drug-induced ILD. So in immune checkpoint inhibitors, the incidence is 1.1 to 3.6%, and the mortality is less than 10%. Similarly, in TKI, the incidence is low, 1 to 6%, but mortality is high, 30 to 50%. When we compare with the other traditional, the anti-cancer drugs and DMARDs, so in bleomycin, incidence is 10%, amiodarone 5%, methotrexate, although questionable, but the literature says 0.06 to 15%, and mortality is varying. So knowing the subclass of the drug or the class of drug which cause drug-induced ILD will help us in suspecting the diagnosis of ILD. So why these drugs, mostly they are given systematically, either orally or intravenously. So why are they selectively toxic to lungs? Some of the drug, they achieve higher concentration in the lungs. Some, they get activated in lungs, like bleomycin, in presence of oxygen, it gets bioactivated and produce reactive oxygen species, which cause the DNA damage in the lungs. And for some medicines, the mechanism is unknown. So the host risk factors are smoking, pre-existing lung disease, previous drug-induced ILD, poor performance status, and advanced stage of the underlying cancer. So very important question. So why are we unable to diagnose, or we diagnose drug-induced ILD less frequently? One, there is low awareness. Secondly, time constraint, because when a patient comes with the suspected ILD, we need to take a complete drug history. So it takes a long time. So in the time constraint, many times the things are missed. Then there is variable symptoms, because there is a period between the initiation of the therapy and the development of ILD. One, this period is variable, and this is not established for many drugs. Say for immune checkpoint inhibitors, the mean period is 3 months, but the range is very large, 9 days to 19 months. So at times it becomes difficult to associate the ILD with the drug exposure. And in certain drugs, it can develop many years after stopping the medication. These are the drugs where the ILD is the development of ILD is dose dependent, like bleomycin, the amiodarone, doxorubicin. So because the exposure was few years back, so quite a time, frequently the exposure is missed. Then variable patterns. Same drug might cause NSIP in one patient, can cause the ground glass centrilobar nodules HP type pattern in one patient, might cause DAD like picture in one patient. So same drug can cause different patterns in different patients, and even in a single patient, a mixed pattern might be seen. And there is no definite diagnostic test. The biopsy and CT scan, it can suggest us the pattern, but NSIP caused by CTD or idiopathic NSIP cannot be differentiated from a drug-induced NSIP on a CT scan. Similarly, biopsy also cannot differentiate between the drug-induced patterns. So there is no specific test which can diagnose a drug-induced ILD, and that's why many a times we miss the diagnosis. So there are only 4 small steps for the diagnosis of drug-induced ILD. First is we need to sniff it. When patient is coming to us with the ILD, we need to sniff the medication history. Then we need to suspect it. We need to suspect, okay, there is a drug patient was taking and it might cause ILD in this patient. Then we need to exclude the other causes of ILD in this patient, and ultimately stopping in drug, the stoppage of drug and clinical improvement will confirm the diagnosis of drug-induced ILD. So there are only 4 steps. We need to sniff it, we need to suspect it, then exclude the other causes, and we need to stop the medication. So sniffing. When a patient come to us with the ILD or progressive shortness of breath, dry cough, and we are suspecting ILD, we need to take complete drug history. So there are 2 ways we can do it. This is the one which is ideal way. We need to take complete drug history, the duration, the compliance, route. Then we need to consider all the drugs, whether they were recreational, the alternative therapy, over-the-counter drugs, or even the combination treatment. Then we need to see which of these drugs can cause the ILD. So there is a easier way also. So in our busy practice, many a times we are not able to take the complete history. So there is a poor man's way also. So there are 4 important clinical scenarios. So we can ask 4 important questions during the history taking to rule out the drug-induced ILD. And we should be able to cover around 80 to 90% of the drug-induced ILD. 1. Whether patient has taken treatment for any malignancy, including hematological malignancy, whether patient is having rheumatological disease and taken treatment for it. It should be including CTD, the inflammatory bowel disease and vasculitis, any cardiac or rhythm disease, and any antibiotics. Antibiotics may be given in the inpatient, the department also, and the outpatient also. For nitrofurantoin, especially in females, we can ask regarding the recurrent UTIs also. Say we have taken the complete history, and now we get the history. The patient is having ILD like symptoms, and there is a history of taking risperidone 6 months before the symptoms. So we have heard many different medications which cause ILD, but risperidone is not one of them. So how to go about it now? So this was sniffing. We were sniffing for medicine use. Now we need to suspect whether this drug can be a cause of the ILD in the specific patient. Now, to suspect, we need a temporal association of development of symptom with the starting of the drug. Secondly, drug should be known to cause specific pattern of ILD. So we need to see the clinical picture to see the temporal association. So in this patient, there was the drug was introduced 6 months before the onset of symptom. Now the pattern was NSIP in this patient, the fibrotic NSIP. So now we don't know about this medication. What to do about this now? There are normally we divide the drug-induced ILD pattern into 6 patterns, but in this presentation, I don't want to discuss too much of the patterns because radiology has already been discussed, and the drug-induced ILD patterns, they are similar to the idiopathic ILD and the other secondary ILDs. So my main focus is diagnosis only. So now there is a very important database. It is pneumotox.com. So this is being run by Dr. Philip for last so many years, and he is single-handedly handling this resource, very important for the pulmonary and cardiac toxicity of drugs. So here we can search the drugs by name, or there is a search panel also. We can search for the drug. So now we type the name of the drug into it and search for it. For risperidone, we get eosinophilic pneumonia, acute eosinophilic pneumonia, pulmonary fibrosis, and pathologically it has been seen to be eosinophilic pneumonia, organizing pneumonia, and NSIP fibrotic pattern. So there is one star. 1 star means this star value shows the number of case reports which have been reported with this presentation. So there is when 1 star, it shows less than 10 cases. So although with risperidone, the fibrotic NSIP has been reported, but the case reports are not very huge. The number is not very huge. So what will you do? So in this patient, the symptom developed 6 months after starting the therapy. It was fibrotic NSIP, and there are less than 10 case reports. So what should we do? Obviously, the pattern is associated with the drug and there is temporal association. So we will suspect the diagnosis, right? Now we need to exclude the other causes because there are so many causes of the NSIP. It can be in some cases idiopathic, but more commonly it can be the CTD associated. So we need to rule out all the other causes of NSIP. So the ruling out the other causes depends on the scenarios. Like if the patient is a CTD patient, then there can be different causes. And if patient was having malignancy, then there might be different causes to exclude. Like in a CTD patient, we want to rule out infection because patient is taking immunosuppressive therapy. So we need to rule out infection, especially the PCP. Then cardiac involvement might be there, so we need to rule out the hydrostatic edema also. In scleroderma, there can be GERD or aspiration, so we need to rule out aspiration. And there can be development of ILD or progression of ILD if patient is already having ILD. So there are so many causes. If the patient was having malignancy, we additionally want to rule out the relapse of malignancy, lymphangitis, and radiation pneumonitis. So a BAL can be useful at this step to rule out these causes. Especially the BAL can be helpful in ruling out the eosinophilic pneumonia, in ruling out infection, malignancy relapse, and DH also can be ruled out with the BAL. So other than the ruling out the exclusions, the BAL is not helpful in making the diagnosis of the drug-induced ILD. So now we were able to rule out all the other causes. There was no CTD, no infection. So what is the diagnosis? Now, risperidone has been associated with the fibrotic NSIP, but the number of case reports is few. So it can be a risperidone-induced ILD. So we can make a provisional diagnosis of drug-induced ILD, but there is possibility that is a idiopathic ILD because the ILD association with risperidone is less, and it can be at times the other undiagnosed ILD at that time. Many a times we miss the diagnosis of CTD ILD initially because at that time there is no other feature of any other system involvement. Antibodies might be negative at that time, so we can miss the diagnosis, and later on we can make the diagnosis. So we can make the provisional diagnosis here. Now, how to confirm the diagnosis? To confirm the diagnosis, we need to stop the medication. If after stopping the medication, the patient clinical symptom improve, then we can safely make a diagnosis of the drug-induced ILD. But there are many scenarios where the drug, there is no effective alternate of the drug, then it becomes difficult to stop the drug. Secondly, patient can be very sick. At that time, we need to give steroid or immunosuppression along with the stopping the medication. And in such a scenario, it becomes difficult to differentiate whether the patient improved because of steroids or because of stoppage of drug. So in such case, it becomes at times difficult to make the diagnosis of drug-induced ILD. Now, how do we treat the drug-induced ILD? So there are four possible the options. One is discontinuation of the treatment. Secondly, to decrease the dose and continue. It can be a risky option at times. Then we might need to give steroids or immunosuppression. So it depends on the severity of the symptoms and the ILD. If the disease is asymptomatic and we on screening CT we found out that patient is have ILD, so this is one category where we might consider continuing the treatment if there is no effective alternate. In moderate patient, when patient is symptomatic, we should be discontinuing the treatment. In severe and life-threatening, when there are significant symptoms which interfere with the daily activities of life, or life-threatening when patient is in ICU or admitted in the ward, in these we need to discontinue and we need to give steroids along with the discontinuation of the drug. And in life-threatening, we can consider the immunosuppression also. So in severe and life-threatening, the re-challenge is completely contraindicated. So it can be tried, re-challenge can be tried if there is no other alternative, especially in the newer therapy of cancer, because in 1/3 of the patient, the re-challenge, the ILD occurs again. So prognosis is good if we are able to stop the drug. It's unpredictable if we continue the drug. So if we continue the drug and we miss the diagnosis, there is high chances that the patient will end up in pulmonary fibrosis, ARDS, and ultimately lead to disease progression and death. So thank you. So there are two important messages in my presentation. One, it's very important to sniff for the drug use. We should be asking at least 4 important questions regarding any treatment for cancer, for rheumatological drugs, any cardiac drug and antibiotics. Thank you. I think we have time for questions.
Dr. Naveen, can you stay back for some time? We'll have the discussion at the end. It'll be better that all of you are there so that we can discuss any question that comes up in other ILDs also. So the discussion will take place at about 2:30. Can you be there?
I hope I'll be there.
Okay, sir. Then we'll take up the next lecture first, and we'll take up the discussion at the very end.
Okay, that's fine. Thank you.
Thank you. Yes. So you have stopped. So next we have a talk on another rare diffuse parenchymal lung disease, which is pulmonary alveolar proteinosis. And to deliver that lecture, we have Colonel Vikas Marwa, who is working as a professor of respiratory medicine. He has been a fellow in pulmonary critical care at the Leeds Royal College, UK. And currently he's posted, I think in Rajouri, in the 150 General Hospital. His areas of interest include interstitial lung disease, non-invasive ventilation, severe asthma, and pulmonary vascular diseases. He has won several awards, including Army awards. So, Dr. Vikas, you can take over. I'll just stop sharing the screen and you can start.
Is my screen visible?
Yeah. Please make it full screen. It's already full screen, I think. Yeah.
Very good afternoon to all of you. At the outset, I'd like to thank the ICMR INPF team as well as Dr. Sehjal for this academic feast, and I've been attending most of it since yesterday and I've hugely benefited. The topic for today would be the diagnosis and management of pulmonary alveolar proteinosis. As we all know that pulmonary alveolar proteinosis is a very rare disease, and very few of us would come across and manage it with whole lung lavage. And in view of the rarity of the disease, there are not very many robust randomized controlled trials. The RCTs for the drugs is not, the data is not huge. So this would be the outline of my talk. So the incidence is approximately 7 cases per million, and it is essentially due to the deposition of the surfactant material, which is the lipoproteins in the alveoli because of a dysfunction which we see in these patients. So this is the classification of pulmonary alveolar proteinosis. So we have the autoimmune or the primary PAP, which is the most common variant and seen in approximately 90% of the patients, where there is an issue with the GM-CSF signaling disruption, which may be because of the autoantibodies, or it may be because of mutation in genes encoding the GM-CSF receptor, which we see in hereditary PAP. The second, most common spectrum which we see is secondary PAP, which we see in a host of diseases, which may be in hematological malignancies, especially the leukemias and the myelodysplastic syndromes, and secondary to infections such as tuberculosis, pneumocystis, nocardia, and fungal infections such as aspergillus, and in various inhalational injuries, especially exposure to silica. The congenital PAP is uncommon, and it is usually seen by the pediatric pulmonologist, and these patients usually succumb because they have got major genetic defects in the surfactant encoding proteins. So this cartoon basically shows the pathogenesis. I'll not delve much in detail, but it is important to see that in the most common in which we have a primary PAP, there is usually an autoantibody which is present, which binds to the receptor, and this leads to a dysfunction in the alveolo-macrophage function and the impaired clearance of the surfactant which gets deposited in these patients, as compared to secondary PAP, where there is reduced number of normal macrophages or they may be dysfunctional, and in congenital, where there is an abnormal production of the surfactants. So coming to the clinical features, when do we suspect PAP? We suspect PAP in young males coming in the 3rd to 5th decade of life. It has a very insidious onset, mostly with progressive dyspnea. They may also have cough material which they cough up, or they may have systemic symptoms non-specific like fatigue. And usually there is a long delay between the onset of symptoms and the diagnosis in these patients. The congenital PAP, as I've told, they present early in life and may be fatal. The PAP is a disease of paucity of findings. You have crackles in 50% of the patients, and in 25% you may get cyanosis or digital clubbing. Usually the clinical examination is unremarkable, and this is a classical X-ray which you find in these patients. Like we came across a 39-year-old female, a non-smoker, who presented with progressively worsening dyspnea and cough of 1 year duration, and she was treated elsewhere with steroids, ATT, and usually in our country, these patients, it has been found, they come pretty late when the disease is quite advanced. And the most common radiologic findings is bilateral acinar or alveolar opacities, which we see in mid and lower zone, and which mimics a pulmonary edema. And it's classical batwing in these patients, though it can be asymmetric or it may be unilateral in some of the patients. So this is the classical HRCT, which is called the crazy paving pattern, in which we have a ground glass haziness with a superimposed interlobular septal thickening, which we see in these patients. As you can see here, there is septal thickening and there is ground glass haziness. And this was the HRCT in our patient. Usually they have got a lower lobe predominance, but it may involve the upper lobes as well. So it was thought that crazy paving is sine qua non of PAP, but it is non-specific. As you can see, a host of other conditions in which you can have crazy paving, most common being pulmonary edema, but in these patients, there would be some pleural effusion, malignancies such as adenocarcinoma, infections like pneumocystis pneumonia, CMV, a host of other conditions like alveolar hemorrhage, organizing pneumonia, lipoid pneumonia can also present with crazy paving. So mere presence of crazy paving is not diagnostic of PAP, which is very important to note. Lung function in these patients tells you about the severity. as I've told you, most of the patients come very late, and it also dictates the pace at which you have to, evaluate these patients, because most of the time these patients are in hypoxemic respiratory failure. And it also dictates the invasiveness of evaluation, because most of these patients, you might not be able to do a biopsy if they are hypoxemic. The importance of, the lung function is that they are important in following these patients up with various therapies, or after the whole lung lavage or the drugs which you give in these patients. These patients classically have a restrictive pattern with reduced DLCO, and the diffusion is out of proportionally reduced to the lung volumes. Lung volumes are usually maintained, but the DLCO is markedly low in these patients. This is, and you do a bronchoscopy not only for confirmation of diagnosis, but also to rule out the alternative diagnosis in these patients. It is milky, opaque, and there is a large amount of sediment, as you see in these patients. If you let the ball stay for a while, you'll find a thick sediment in these patients, which is the surfactant or the lipoproteinase material which is there. And if you subject it to PAS stain, it will be positive for PAS, and you might also see some foamy alveolar macrophages, the macrophages which have engulfed this, the PAS positive material. So this is a busy slide, but what I want you to note is that if you get a milky ball, it is highly suggestive but not diagnostic of PAP. You need to further evaluate and rule out the secondary causes, and you need to do a autoantibody. Now in our country, the issue comes here, because for diagnosing autoimmune or primary PAP, you need to do an anti-GM-CSF antibody, and it is not available by any of the commercial labs. So that is why many times you have to resort to biopsy in these patients to demonstrate the pattern. But if you have excess, and what we do is we ship it across to the Cincinnati hospital in US, where they do it complimentary for us, and we just need to pay for the courier charges. Then you can get a diagnosis of autoimmune or primary PAP. Short of that, and or if it is negative, then you need to do whole lot of these tests which are not available, but only reference labs have it, such as the serum GM-CSF levels. If they are high, that means there is some issue with the receptor, and the patient might be having hereditary PAP. If it is normal, then this might be a case of in congenital PAP, where you need to do a mutation testing. So you start off with the basic test. You need to have a history which is suggestive, a presence of crazy paving on CT. Then you do a ball which shows usually a milky ball, but it may be normal as well. Then you go ahead and look at the underlying cause or etiology, do an autoantibody. If it is positive, that is good enough. If it is not, then you probably need to go ahead. So normally, in our country, we have to resort to the transbronchial lung biopsy, which increases the yield, in approximately 30% of the patients. And the sensitivity of TBLB, because it's a diffuse disease, is good around 75% in various studies and in a meta-analysis. But you need to, perform the ball from a different subsegment to diagnose it. So biopsy, we commonly don't, go beyond the transbronchial lung biopsy, but there may be patients where, the autoantibodies are negative or they are not available, and there is a suspicion of malignancy. So in these patients where alternative diagnosis is suspected, you might need to do a surgical lung biopsy. But now with easy availability of cryobiopsy, we usually subject these patients to the TBLC. And this was one such case where it was very helpful, where the ball was not milky. The TBLB was inconclusive, where we confirmed the diagnosis with the transbronchial lung biopsy, and the patient did very well with the whole lung lavage. So approximately 5 to 10% patients may need a surgical lung biopsy, or nowadays a cryobiopsy in these patients. So, highly suggestive. But if the antibody is negative and normal GM-CSF levels, that might be an indication to evaluate these patients further with a biopsy. The test, as I have showed you, that in our patient, we had to ship the sample across, and we sent it to Cincinnati, where the report came back was highly positive. So less than 3 mcg per ml is a normal level. Our patient had 55.6. So this was diagnostic of autoimmune PAP. So this is a very important step which can prevent a biopsy in these patients. And the sensitivity is as high as 100%, and the specificity is approximately 98% in some of the studies. We don't have facilities, but if you do have, then a BAL anti-GM-CSF antibody is more predictive, and it correlates better with the disease severity. And serial levels may be done. And if the patient has got very high levels, then they are more likely to progress, and they may be helpful in monitoring the disease. So now coming to the management, the gold standard or the standard of care of management over the years since 1963 is whole lung lavage. But unfortunately, since it is a rare disease, the method has not been standardized, and there are no such international, guidelines available to do that. But most of the centers, they would do, a whole lung lavage if the patient is symptomatic and has got a progressive decline. He has got worsening symptoms with a decline in lung function. So that is what most of the centers do. So this is a, study from 27 centers where they looked at the various practices published by Campo, and they showed that the decline in lung function with a symptomatic patient and declining oxygenation, these are the most common indications to do it. So as I have said, a PaO2 less than 65, so mild and asymptomatic patient you can just observe, and if they worsen, then you do a whole lung lavage. But patients who are hypoxemic, you might need to do, and especially if the alveolar arterial gradient is more than 40 in these patients on the ABG, or if they have got severe symptoms at rest or exertional desaturation. You should be mindful of the absolute contraindications in which the patients, if they have hemodynamic instability, active infections, you cannot do it because that might lead to flare, or if the patient has got a bleeding diathesis. So, the methodology of doing whole lung lavage is not standardized. What everybody practices is it's done under GA with a double lumen tube. This is how a double lumen tube looks like. So you need to isolate the lung which you are lavaging, and you do a single lung ventilation at the time, and you pour in from one side and do a gravity assisted drainage from the other side. So the position in which you do varies from center to center. 50% of the centers do it in the supine position. We do it with the, on the non-dependent side, and we ventilate the dependent side because that maintains a better ventilation perfusion in these patients. And if you are lavaging the lung which is towards you, which is superficial, it's easier to do percussion and remove this thick, surfactant material with the aid of gravity. So the patient is, all the centers use the saline, which is warmed to 37 degrees. It is instilled into the lung in aliquots, and then you drain by putting the patient in Trendelenburg position and doing the chest percussion. So this is the confirmation. So most important step is the confirmation, because there might be migration of tube and the other lung might get inundated. So this is the percussion and gravity dependent, drainage. And endpoint in most of the centers is a clear effluent, though in some of the research settings they do an optical density, and they may also do the protein analysis on the effluent. But what we follow is the initially you find that there's a thick sediment, and then sequentially there is clearing of the effluent. This is after the right side whole lung lavage, there is significant clearance, and the results are dramatic, and so is the improvement in oxygenation in these patients. So again, this study, most of the centers do it under GA, and the position may vary, but you see that the number of procedures done, they vary from 2.5 to in 5 years, and the period between the two whole lung lavage, the two sessions from one lung to another lung usually is between 2 to 3 weeks. Some centers do the bilateral in one go under ECMO, but such case reports are very far and few. I think PGI does it in the same setting, probably because of the long waiting period. We do the more severely affected lung first, and then after 2 to 3 weeks, then we go ahead with the other. So this was our experience. Being a rare disease, we had only 10 patients, and that too it was a multi-center experience. And the lung volume, the volume of fluid which was used ranged from 18 to 35 liters with a median volume of 23.5, and all the patients showed significant improvement. So over the years, the effect of whole lung lavage is more durable nowadays because of longer lavage times and longer lavage volumes which we do, and better monitoring. So the period, longer the period, more the fluid instill, better and durable results which you get, which has been shown in this paper from Beccaria also, that 70% of the patients followed beyond 3 years remained free of recurrent PAP, which was not there previously. It's a safe procedure done in the experience centers. Most common complication is fever, which may be transient, and hypoxemia during the procedure. Some centers have reported pneumothorax. We do not use bagging. Many times, some patients do, some centers use bagging for the clearance. So that might be associated with higher risk of barotrauma. We found, HFNC very helpful because these patients, after the procedure, they bring out chunky phlegm. So if you put them on HFNC, then the secretions get humidified and physiotherapy is much better. So in our experience, using HFNC post WLL is quite helpful in these patients. There is no drug which is licensed for use, but there is a lot of data for use of GMCSF by the nebulized route nowadays. The issue is with the inhaled GMCSF therapy is that there's a significant cost, and after COVID, the only company which used to manufacture MCure, they have also stopped manufacturing it, and there's difficulty in procuring and issues with compliance because it has to be taken daily. So this was a meta-analysis which looked at subcutaneous versus inhaled and found the inhaled to be more efficacious with a higher response rate, 89% compared to 17% in the subcutaneous, with better improvement in PO2 and alveolar arterial gradient with less side effects. So there was a recent paper published this month only in the European Respiratory Journal from the Campo and Bruce group, Dr. Trapnell's group, where they showed that WLL followed by the nebulized GMCSF therapy is much better than being alone. This is the off-label indication for rituximab, but we also used it when we were pushed against the wall in one of our patients who relapsed within few weeks of the completion of the procedure, and we gave rituximab 2 doses, 1 gram, 2 weeks apart, and this patient did well thereafter and did not need the repeat whole lung lavage. But these are anecdotal, and what you need to know is that please do not give steroids to these patients, because steroids, they may be harmful, as these patients are at a very high risk of infection. So depending upon the cause, secondary PAP requires treatment of the underlying condition. You need to vaccinate these patients because they are prone to secondary infections, and also institute smoking cessation in these patients, as they frequently develop infection. So this is a quick flow chart which shows autoimmune, mild, just observe. If it is severe, then you need to do whole lung lavage and then observe. If they progress, either you repeat the whole lung lavage or you resort to these novel therapies, which is GMCSF as well as the rituximab. Prognosis nowadays, with better lavage volumes, longer periods, 70 to 90% achieve remission, and the duration of benefit is variable from various centers, but the 5-year survival is much higher in patients who undergo whole lavage. It is 94% compared to 85% in those who do not. So to summarize, it is a rare depositional disease, and where whole lung lavage is the standard of care. Crazy paving, it is important to note, is non-specific. Most important cause of crazy paving is heart failure, and malignancy always remains in the differential. And the novel therapies, there is not much data to support, but when you're pushed against the wall, you can use that. Steroids should not be used. And what we need to have is a multi-center trials and more RCTs to have standardized international guidelines in this field. Thank you.
Thank you, Dr. Vikas. Please stay back till the discussion and we can have the next lecture. Please unshare your slides.
Sure.
Thank you. So next we have depositional diseases, which includes pulmonary alveolar microlithiasis, amyloidosis, and others. So for that, we have Lieutenant Colonel Manu Chopra from the Armed Forces Medical College. He's a professor of pulmonary medicine there. His primary area of interest lies in interventional pulmonology. He has several awards to his name, including a UN Peacekeeping Award, and he has more than 30 publications. So over to Dr. Manu.
Thank you, Dr. Sejal. Thank you for inviting me for this esteemed conclave. Can you hear me clearly?
Yeah, I can hear you. Please share your slides. Yeah, I can see your slides. Please make it full screen.
Yeah, good afternoon, everybody.
Okay, please go to the next slide once. Next slide once. Yeah, okay, go back. Thank you.
So I'll be talking on some extremely rare lung disorders. I'll be talking about pulmonary microlithiasis, and other depositional lung diseases. So these depositional lung diseases, as the name says, are the diseases wherein some exogenous or endogenous constituents get deposited in lungs in amount which is sufficient to disrupt the function and structure of the lungs. They may cause symptoms depending where they are located, maybe in the parenchyma, in the airways. And as we have seen that various other things can get deposited in lungs. We can have water, which is there in cardiac failures, it is edema. We can have amyloid in the pulmonary amyloidosis. We can have surfactant, as we have heard Colonel Marva with pulmonary proteinosis, and fat, which was lipoid pneumonia. I would restrict only to lipoid pneumonia, pulmonary alveolar microlithiasis, and pulmonary amyloidosis. So pulmonary alveolar microlithiasis is extremely rare lung disorder wherein there is accumulation of calcium phosphate crystals in the alveoli. It was described long back by Malpighi in 1686. The name was given somewhere 250 years later by Dr. Pure. As of now, around 1,050 cases have been reported worldwide. So that's the rarity of this disorder. It's always found incidentally in various of patients when they present for recruitments, X-rays are done, and they find some strange X-rays, start evaluating these patients, and then if the patients have been diagnosed with pulmonary microlithiasis. This review was published in 2015, where they had reported on 1,032 cases of pulmonary necrosis across the world. The number has not changed much. It's about 1,050 cases as of now. They found the majority of the cases were in Asia, 57% of the cases, followed by Europe. Majority of individuals were male. Most likely they were the people who were reporting for recruitment, or with other causes they reported to the medical facilities. Usually diagnosed in second to third decade of their life. Majority of time it is a sporadic mutation. Only about 37% of cases are familiar. In India also, of these 57% of the cases, the 80 cases were from India. The 80 cases were India, and till now, 86 cases have been reported from India of pulmonary microlithiasis. So doctors in India are aware, but still it's a very, very rare disorder to be reported or to be seen in routine practice. The problem lies in the autosomal recessive mutation, which causes dysfunction of a sodium phosphate co-transporter presented in the apical membrane of type 2 alveolar cells. So this co-transporter is not able to secrete or excrete the phosphates which get accumulated in the alveoli, binds with calcium, forms the calcium phosphate stones, and these stones then they disturb the alveolar structure, disrupting the oxygenation and subsequently all the damage which take place because of the deposition disorder. The signs and symptoms, as I told earlier, also that it is diagnosed incidentally. So the most majority of patients are asymptomatic. If there is a family history, then some of these cases have been evaluated and they have been picked up. Rarely, as the disease progresses, then these patients present most commonly with dyspnea or some dry cough, rarely have chest pain, asthenias. Rarely, these stones can lead to rupture of the vasculature causing hemoptysis. Pneumothorax is extremely rare in these cases of pulmonary microlithiasis. Again, pulmonary function tests, as you can see, if the patient is asymptomatic, initially the pulmonary function tests are usually normal, but as the disease progresses, it causes restricted defects with reduced GLC. The blood investigation also remain normal in this patient. Nothing is seen. Surfactant protein D can be increased like other ILDs, oblique IPF, or as in case of PAP. The surfactant protein D can be seen in the serum. Genetic testing can be done. It's available in some centers. Whole genome sequencing is being provided by some labs, but not readily available in our country. The cornerstone of diagnosis is X-ray. This is the type of X-ray which you see that the patient is usually with very minimal symptoms, but the X-ray is speaking volumes that the lung is totally damaged. So you can say a designer lung, wherein almost all segments of the lung are involved. There is a fine sand-like macronodular opacities are seen scattered in the whole lung, more so in the bases, and apices are usually spared. The cardiac borders of the diaphragm are usually obscured, and the heart may vanish in these opacities, called a vanishing heart phenomena. A characteristic thing you can see is that there is a small black lucent line which is seen between the chest wall and the pleura, because the pleura gets calcified. So this black line can be seen with this calcified pleura and the chest wall, which is called a black pleura sign, can be seen in these cases of pulmonary microlithiasis. It can also divide in some phases. The first phase of wherein the precalcific stage, rarely seen. Very few cases have been reported. The precalcific fine nodularity can be seen in the lungs, but usually this pattern is not commonly observed. Second pattern, wherein the sandy pattern appearance is seen, but here in the heart and the diaphragm is not obscured. The disease starts progressing. The interlobar sepals are involved. The nodular opacities are seen more in the bases and the peripheries. Subsequently, as these micronodules get accumulated more in the alveoli, the alveolus collis, then you can see the third phase of the this disorder, wherein the heart borders as well as the diaphragm starts getting obscured. In the fourth stage, you can see that the lung is totally opacified. You can't see anything in the lungs. This is a pattern when the patient is extremely symptomatic with dyspnea. Some infections will be abnormal in these patients. This is known as a whiteout lung, characteristic of pulmonary microlithiasis. PET-CT is also not very helpful in picking up these cases. Why? Because the calcium latent pattern of lung, it has a low uptake of 2.6, but high uptake is seen of areas which have more of inflammation. So the pattern, the uptake of 7.3 is opportunely seen in those areas, but they are not the areas which have got more of calcification, more of inflammation. More scan has been tried, but with the HRCT, it has overtaken HRCT, and bone scan is really done for these things. Ultrasound can show us pleural thickening, but there is absence of comet sign, that those artifacts which we usually see when the pleura is thin. But when the pleura gets calcified, that comet sign is not seen in these cases of pleural pulmonary microlithiasis. Sputum on ball, if suspected and has been obtained perfectly, you can have a past positive calcareous concentric crystals in the sputum, which can be confirmed on von Casa stain. As you can see, the white calcification can be seen in the brownish stain in the slide. Electron microscopy has been used in these patients, and the samples show that small porous microliths can be seen in the various segments of sputum and ball or the lung biopsy segments, which are very porous, which have calcium phosphate crystals, and the consistency of the ratio of calcium to phosphate is usually 2:1 or 3:1, which is consistent with hydroxyapatite seen in these cases of PAM. In our country, we have to resort to further investigation with biopsy. Biopsy can be a transbronchial lung biopsy with a cryo biopsy or surgical lung biopsy to see for the lung parenchyma and to see differentiate these other disorders involving the lungs. We can have various variable size concentrically laminated concretions which are present both in alveolar areas as well as in the interstitium. The PAB may also have involvement of other areas with this co-transporter is involved, that is intestines and the testicular areas. So these patients may be have azoospuria, may be infertile. So that also can give us a clue that patient who has got a this nodular opacity in the lungs and is infertile, maybe this patient maybe have a pulmonary microlithiasis. Again, this patient, when the intestines involved, they have recurrent abdominal pain, recurrent hematuria, infertility. Finger clubbing is rarely seen, and mostly seen the patient who have got who are picked up the stage of whiteout lung. Then these patients are hypoxemic and may have finger clubbing. The diagnostic algorithm is from the simple thing you have to go to the complicated thing. If the patient gives a history of a sibling or of other family history of having PAB and the X-ray is characteristic of PAB, the patient has PAM. But in case the patient does not have a family history and we can have a genetic testing of SLC34A2 mutations, we should go ahead with that. If it is positive, the patient has got PAM. If not, a poor man sample, we can go for sputum analysis. If we are suspecting the same, go for a ball analysis for microliths. If that is picked up, well and good, PAM is confirmed. If not, then we have to go for a biopsy. Initially, a bronchoscopic guided biopsy and subsequently a VATS biopsy may be required to confirm the diagnosis. It can mimic various disorders with nodules. It can mimic tuberculosis, sarcoidosis, amyloidosis, silicosis, metastatic pulmonary calcification. So a lot of things have to be excluded before we can make a diagnosis of PAM. So it is, of course, the thing we should be there in the back of our mind, that PAM is also a disorder of lungs, and it may mimic any of these other disorders. The treatment again is not simple, it's not easily available. As you can see, only 1,050 cases have been reported in the world. So treatments are again in experimental stage. People have tried bisphosphonates and low phosphatide to have low this phosphate levels, steroids to reduce the inflammation, but none has been successful. In procedure, of course, a whole lung lavage has also been tried in these cases, and there has been a series of lung transplant, successful lung transplant in 17 cases of PAM. So maybe the treatment of choice subsequently would be lung transplant in these patients, and other things are not as of now are showing any improvement. Coming to my second illness, the rare lung disorder, that is pulmonary amyloidosis. Pulmonary amyloidosis is an extremely rare disorder. It actually primary pulmonary amyloidosis is usually not seen. It's a part of a systemic amyloidosis. In any form of systemic amyloidosis, the lung may be involved. The most common types when the lungs are involved is systemic AL amyloidosis or systemic autoimmune amyloidosis, systemic wild type amyloidosis, hereditary transthyretin amyloidosis, and localized AL amyloidosis. The pattern seen in the lungs is most commonly diffuse alveolar septal pattern, cystic pattern, nodular, or tracheobronchial involvement. They usually have extra parenchymal involvement with the lung being involved in the secondary stage. The diffuse alveolar septal pattern is the most common pattern associated with the systemic amyloidosis, but it's not very symptomatic. The PFT, because the alveoli and the septa are involved, usually show a restrictive pattern. In the nodular cystic pattern, it usually have a localized amyloidosis. The symptoms are more with a cystic pulmonary amyloidosis, where is cough and dyspnea, and rarely hemoptysis can be seen in these patients. But in the nominal amyloidosis, the symptoms are very minimal. The spirometry in both these cases are normal. Tracheobronchial amyloidosis is amyloidosis wherein these amyloid deposits take place in the tracheobronchial tree, and this is the most symptomatic of the amyloidosis. Whichever part of the tracheobronchial tree this amyloid gets deposited, it may lead to cough, dyspnea, wheezes, hoarseness of voice, stridor, and we can have the obstructive pattern on the PFT. This can be visualized on a bronchoscopy. So this is the most symptomatic type of amyloidosis. In case of radiological appearance of these amyloidosis in diffuse alveolar septal amyloidosis, as the name says, it has got reticular opacities involving the interstitial septums. It has got interloboseptal thickening and some micronodules. Ground-glass opacities, bronchiectasis may also be rarely seen in these patients. In case of nodal pulmonary amyloidosis, varying size nodules, usually less than 1 centimeter in size, are seen in the lungs, more so in the periphery, more so in the lower lobes. They may coalesce to form a large mass. Case of more than 50 centimeter mass of amyloidosis has also been reported. In cystic pulmonary amyloidosis, there are two types of cysts. There may be central cyst or a peripheral cyst. Central cysts are usually seen with the patient in patients who have got a connective tissue disorder related amyloidosis. In case of peripheral amyloidosis, the CTDs are usually absent. They are less than 2 centimeter round lobulated cysts which are thin walled. Tracheobronchial amyloidosis, as I told earlier, it can cause irregularity in the tracheobronchial trees. They may have bronchial thickening, lumen irregularities, some focal nodularities, calcification will be seen in airways, or a sacrofacial calcified wall thickening can be seen. How do you diagnose these patients? If the patient has got systemic amyloidosis, and if the pulmonary lesions have been found, and our diagnosis will change with or our management will change if we diagnose pulmonary amyloidosis separately, then of course we can go ahead with surgical biopsy or cryo biopsy or transbronchial biopsy. But if it is not going to change our course of treatment of systemic amyloidosis, we should continue the same line of treatment, and the the deposit in the lung or the lesions in the lung can be simply attributed to the systemic amyloidosis. But in the case where the cause is not known, where the case is unknown cause of amyloidosis, we can go ahead. The screening test for urine or serum immunofixation can be done for, and the protein electrophoresis can be done in these patients. For confirmatory tests, we require biopsies, and biopsies are usually not done from the lung because there are high chances of bleeding. Also not from the kidneys because again it will cause much damage to diagnose amyloidosis from the kidneys. So a bone marrow biopsy or a fat biopsy from the salivary gland are usually done to diagnose amyloidosis, which is subject to histopathological tests. And as we all know that apple green birefringence from the polarized light can be seen on the congruent smears of these tissue. That's characteristic for amyloidosis. It can also involve some medicinal lymphadenopathy. Pleura is involved in amyloidosis, and usually they have exudative bilateral pleural effusion, which can be seen in cases of amyloidosis, usually extraparent amyloidosis. Rarely, a patient can have pulmonary hypertension and is usually a marker of an advanced disease. Treatment-wise, the treatment, of course, remains the same as the treatment of systemic amyloidosis. In case of diffuse septal amyloidosis associated with multiple myeloma or MGS, the treatment continues with the same treatment of the systemic amyloidosis, and the confirmatory or the treatment of choice is autologous stem cell transplant. In case of nodular pulmonary and systemic pulmonary amyloidosis, the treatment is usually surveillance in these patients. And tracheobronchial amyloidosis is the amyloidosis where we all start intervening. We can have localized treatment with the cryotherapy or electrocautery and placement of stents in these patients to take care of this obstructive airway disorders or the obstruction in the tracheobronchial tree. The third is the lipoid pneumonia, again a very rare type of pneumonia wherein the fat or fat-containing products are accumulated in the lungs. First described by Lawlin in 1925, and these products in the lungs, they lead to inflammatory reaction in the lung parenchyma and hinders the gas exchange. This lipid can accumulate in lung in two ways. It can be an exogenous lipid, wherein the patient may have aspirated or inhaled the lipid-containing products like mineral oil, laxatives, lubricants, etc. Or it can be endogenous, wherein subsequent to obstruction in the terminal bronchioles and all, the fat-containing surfactant is metabolized, the macrophages accumulate there. It can lead to cholesterol pneumonia, or there is secondary inflammatory reaction where the fat gets more accumulated in these areas, and further tissue damage takes place. So that's also part of a fat metabolism disorder in our body, which can also lead to endogenous lipoid pneumonia. Incidence, as shown, is very rare. 1 to 2.5% is the rare incidence of lipoid pneumonia. Exogenous lipoid pneumonia can be diagnosed in all age groups. The children's more there were very case reports of young children having exogenous lipoid pneumonia because of lubricating the tubes or lubricating feeds to before they are fed in these areas. Usually reported from Africa. Or the patients who have got neurological disorders or cleft lip palate, cleft palates. These are patients, they start aspirating the lubricants applied in their oropharyngeal tract, and they may lead to exogenous lipoid pneumonia. In our newer generation, it can be seen that vaping or other occupational lung disorders have been associated with exogenous lipoid pneumonia. In case of endogenous lipoid pneumonia, it depends on the underlying cause. It can also be lead to the lipid and fat storage disorders like Niemann-Pick disease, wherein we can have lipoid pneumonia. The pathophysiology of exogenous lipoid pneumonia is like a foreign body reaction, wherein the foreign body is fat is aspirated into the lungs or inhaled into the lungs. It is taken by the macrophages and alveoli. It cannot be metabolized. Again, further macrophages or alveoli and macrophages are exposed to this fat-laden macrophages. Inflammation continues and the granuloma is formed, and that leads to exogenous lipoid pneumonia. In case of endogenous lipoid pneumonia, there is a damage to the alveolar epithelial cells. The secretions are retained. There is increased endogenous cholesterol and cell breakdown. It causes significant inflammation. Inflammation leads to leakage from the vessels, more inflammatory cells, more fluid. The local hypoxia and carbon dioxide retention further complicates this inflammation, and foamy macrophages get accumulated in the lung parenchyma, leads to endogenous lipoid pneumonia. It, again, a very rare disorder. The diagnosis of exclusion. These nodules or these masses can mimic a number of diseases. The symptoms are rare. Usually, patient may have dry cough, dyspnea, scanty expectoration. Hypoxia may be seen with excessive lung deposition is there. Rarely, they may have hypothesis, weight loss, and fever. Chest X-ray as with amount of reported pneumonia, it may show bilateral infiltrates. Lung examination may show crackles if excessive lung is involved with the aspiration of fat-laden materials. Again, we should have high index of suspicion before we diagnose these cases. CT is very suggestive of lipoid pneumonia only if we are able to have a good history, and history is rarely forthcoming in this patient. So almost all these patients are first treated for infectious disorder, other ILDs, and subsequently have been thought to have lipoid pneumonia and manage appropriately for that. The CT findings may have a crazy paving pattern. The ground glass opacities may be seen. They may have air bronchograms of pneumonia, or they may also mimic malignancy. As you can see in this patient, a 60-year-old female who had chronic aspiration, the patient had chronic ground glass opacity and constellation in bilateral lower lobe, and subsequently on the medicinal card you can see that this attenuation, they had a significant fat attenuation could be seen in this constellation. That clears the diagnosis. The patient may have lipoid pneumonia, and subsequently as the history was asked from this patient, then it was seen that she was habitual of taking Vaseline or aspirating Vaseline. This Vaseline had led to all this lipoid pneumonia in this patient. Patient had taken antibiotics and further immunosuppressant treatment for years altogether before being diagnosed. Again, in this patient, as you can see now, 80-year-old male who has got a secreted mass lesion in the left upper lobe. Appears to be malignancy. Clinically, also the patient may fit into a case of malignancy, but the CT scans in the medicinal skirt, if you can see, there's a fat attenuation which can be seen within this nodule. That subsequently with the biopsy clears the diagnosis the patient had lipoid pneumonia, and the patient was saved from surgery for this malignancy, suspected malignancy. Bronchoscopy is of course very helpful in these patients. We have the ball can give us lipid-laden macrophages with large vacuoles. It's seen very positive with oil red O stain. Multi-vacuolate cells with a soap bubble-like cytoplasm can be seen in this patient on ball. The treatment is again, if once we are able to establish diagnosis, the treatment is only stopping the exposure of these patients. If there is extensive involvement, the patient is severely hypoxemic, the treatment of course remains corticosteroids. Again, there are few observation studies which have been able to describe the disorder and say some amount of treatment. Again, if extensive lung involvement is there and the lipid has been their lipid occlusion is there in significant amount of lung with excessive hypoxia, whole lung lavage can be tried. So to summarize these three cases, these three scenarios of pulmonary microlithosis, typhoid pneumonia, or pulmonary amyloidosis are extremely rare, and we should of course keep them in the back of our mind in seeing these patients, that the patient with various lung pathological manifestations may have these disorders. Thank you.
Thank you so much, Dr. Manu. Please stay back for the discussion, and I can then proceed to the next talk.
Thanks.
Dr. Barney, are you there? Dr. Barney Isaac, are you there?
Yes, Dr. Shahjat, I'm there.
Yeah,
Hi.
thank you. Thank you. So next we have a talk on pleuroparenchymal fibroelastosis. It's called PPFE. So this was a new kind of entity which was introduced in the last revision of the ILD classification. And it can be idiopathic, it can be related to certain disorders. So we have Dr. Barney Isaac, a professor of pulmonary medicine at the Christian Medical College, Vellore, who will present this. He has a total of more than 40 publications, has won several awards. And we'll listen to him talk on PPFE, how to diagnose in the Indian setting and treatment principles. Over to Dr. Barney.
Thank you so much, Dr. Shahjal. I'll just share my screen. Is my screen visible?
Yes. Yeah. Can you move to the next slide?
Yeah.
Yeah, it's fine. Right. You can go back.
Right. Thank you. At the outset, I would like to thank Dr. Shahjal and Dr. Vijay Hadda for having put this excellent workshop for 2 days. So I'm going to talk about PPFE, the diagnosis and treatment. I bring greetings from the Ranipet campus of Christian Medical College, Vellore. We will be looking at the what PPFE is. We'll be looking at the history, epidemiology, etiology, pathogenesis in brief, but we'll focus more on the diagnosis and the treatment, and in between we'll look at the prognosis and complications in a bit as well. So I would start with the case. Is a 41-year-old lady who presented with cough and breathlessness for a year, had a VATS biopsy 9 months back, presenting to us for ILD, and was reported as fibrosing interstitial pneumonitis. And she was treated with steroids, azathioprine and pirfenidone sequentially, despite which had progression, had a spontaneous pneumothorax on the right side, had a post-VATS loculated pneumothorax on the left side, and with this scenario, she came to us. So what is PPFE? We will look at the radiology and the histopathology of this patient as we go along the talk. PPFE is a upper lobe predominant disease, which is subpleural in involvement and involves the pleura. So there is fibrosis of the pleura and there is elastosis of partly the pleura and the subpleural alveolar space. So this is what pleuroparenchymal fibroelastosis comprises of. This is probably identified in the literature way back in 1992 when it was reported as idiopathic upper lobe fibrosis from a group in Japan. The current term of PPFE was coined in 2004 when the elastosis was described and a cohort was described in 2004. From then, there have been multiple publications. It came into the ATS-ERS classification of idiopathic interstitial pneumonia in 2013 and was mentioned among one of the 2 rare idiopathic interstitial pneumonias. So far, more than 120 cases have been reported. There is not much epidemiological population-based data, but what we do have is from patients who are undergoing ILD workup, and about 6% of 205 patients who were biopsied have come as PPFE. In IIPs which have been looked at in a tertiary center, about 8% of them do have PPFE. But in those listed for transplantation, nearly a quarter of them do have PPFE among the fibrotic ILD. PPFE can be idiopathic when we do not know or understand the cause, or it can be because of a known or inciting factor. It can be transplant related, particularly related to lung and stem cell transplant. Lung transplant, about 7 to 8% of lung transplant could have PPFE, but only about 0.2 to 0.3 of stem cell or bone marrow transplant do develop PPFE. Some chemotherapeutic agents like cyclophosphamide have been attributed. There is a strong genetic predilection. There are short cohorts which have reported up to 57% familial link in PPFE. The TERT or the TERK genes are the ones which are mostly implicated, which cause the short telomere, similar to the genetic predisposition in IPF. There are certain infections like fungi and mycobacteria which have been postulated to have been the inducing cause. Occupational exposure like inhaling aluminum and asbestos have been reported in few cases of PPFE, and the whole range of connective tissue diseases which can cause interstitial lung disease could have a component of PPFE along with it. The pathogenesis is really unclear. There is an injury which causes a abnormal aberrative response, and when they have probably the particular genetic predilection goes on to cause fibrosis and elastosis, as opposed to only fibrosis in most of the other interstitial pneumonias that we know of. The diagnosis, again, gold standard is the ILD-MDD, but it puts together the clinical, radiological, and pathological parameters to come together, come to the diagnosis. We need to understand certain differentials when we are thinking of PPFE. All the upper lobe DPLDs would form differentials, which is the hypersensitive pneumonitis, sarcoidosis, and other IIPs which have atypically upper lobe involvement. Atypical infections could be the differential. There can be post-lung injury and post-infectious sequelae in the upper lobes, pneumoconiosis, malignancy, and apical pleural capping, which is not that uncommon. But the point to remember is in PPFE, there is bilateral symmetric involvement. There is not only pleural, but subpleural parenchymal involvement, and over time is progressive as well. So these are the things really that put the key on to PPFE rather than any of these differentials. There are a few associations which is important to understand. It is not that PPFE happens only in isolation. It can happen along with UIP, NSIP, or fibrotic HP, which means in NSIP, UIP, and fibrotic HP, if you look carefully, probably it will have an additional component of PPFE as well. In fact, in 25 to 50% of PPFE, there has been UIP in certain cohorts. Clinically, it happens over a varied age group. 40 to 70 is the most. Mean age is 53. No gender predilection, not associated with smoking. Cough, breathlessness, and particularly weight loss is a symptom. They have respiratory insufficiency and significant weight loss and loss of muscle mass in the around the chest. They take quite some time to get diagnosed, up to 24 months. Clubbing is not very common. They have what is called acquired platythorax, which is decrease in the AP diameter compared to the transverse diameter. The common genetic causes are pectus excavatum, but here it's an acquired cause. And they have a deep suprasternal notching. So a patient we managed just a couple of months back came in respiratory failure, and she had this suprasternal notching, which is deep, that is seen here. And this is the upper CT cut, which shows that the trachea is pretty much just adjacent to the sternum and the vertebrae posteriorly, and the suprasternal notching is seen in the CT cuts as well, and there's classical platythorax. The radiology is about bilateral apical pleural thickening with subpleural involvement. So this is a case report which we published in 2015, which shows apical pleural thickening in the right side, and the left side there's a loculated pneumothorax. This is the patient we saw at the beginning of this presentation, and here we see that there is this capping and the loculated pneumothorax post-VATS biopsy. There is some lower lobe disease as well, as we can see. The same patient went on so she went on to respiratory failure and died, and we did a autopsic biopsy which showed so this is the pleura, that's the lung, which is showing in 500 par here. There is elastosis here seen by this pink stuff here in higher magnification, and further confirmed by specific stains for elastin to be elastosis. There have been certain pathological criteria that has been postulated, but this came up in 2015 by 5 detailed patients analysis, but this didn't stand the test of time probably and has not been related to subsequently. But what has been referred to repeatedly and probably could be taken as the acceptable classification or diagnostic criteria is the histopathology and HRCT correlational one, where they put 3 categories. One is definite, consistent, and inconsistent. Definite on HRCT is those who have pleural thickening with subpleural fibrosis and predominantly in the upper lobe. If they do not have the distribution only in the upper lobe or have coexistent disease in other places, they would come as consistent. And histopathologically, both pleural fibrosis and alveolar elastosis would be definite. If all these features are not there, it would be classified as consistent. And if none of these are there, it would be inconsistent with PPFE. PFT shows reduction in their lung functions. However, KCO can be increased in significant pleural involvement like extraparenchymal restriction. There are a lot of biomarkers which have been anecdotally reported, but these do not have value in the routine evaluation of PPFE. This is one diagnostic score which includes both clinical, radiological, PFT, and histopathological parameters called the Diagnosis Assessment Score, but it's been just propagated by this one author group in Monaldi Archives of Chest Disease. Again, they've written a review this year as well. So they have a classification based on the scoring into inconsistent, low, indeterminate, and definite. But this is yet to be validated prospectively. So the general approach, when do we need to suspect PPFE, is when we're dealing with patients with ILD, we should look for clinical signs of platypnea or deep suprasternal notch, biapical subpleural involvement on the CT scan, and if so, if biopsy is feasible, we fit for biopsy. Diagnosis in the MDT, look for etiology, look at coexisting ILDs and prognosticate and treat. The other scenario is when we look at pneumothorax or pneumomediastinum, we need to look at the abscess carefully and look at subpleural involvement apically to suspect PPFE. In India, the additional consideration would be when we are suspecting TB. We have bilateral apical disease, but it's involving the pleura as well, and microbiology is negative. We need to consider PPFE, and we could consider for biopsy for proving it rather than giving empirical ATT if the radiology is fitting it. Prognosis is pretty heterogeneous. There are certain patients which, if we can call it like a super rapid course, like the patient we had last month, she within 6 months, she was in respiratory failure and died. And first patient as well, only 1 year. But a lot of patients have a rapid course, which is similar to IPF, but there are a cohort which have a indigenous insidious course going on for several years. Complications are pneumothorax, pneumomediastinum, and type 1 respiratory failure. The treatment is, there are no pharmacologically proven treatments. Steroids have been used without much benefit. Second-line immunosuppressants really do not do anything. Antifibrotics have been recently tried. Again, there is no clear benefit. There's a large cohort of about 35 patients with PPFE and UIP being treated, but they really fared worse compared to the counterparts who had only UIP in slowing the decline of FEC. So there are really no pharmacological treatment that is helpful in PPFE. Oxygen type 1 respiratory failure, antimicrobials in those who have recurrent infection, and non-pharmacological therapy like pulmonary rehabilitation, psychological because they quickly go into a lot of respiratory failure. They have a nutritional problem because they lose their BMI. So these are where current supportive treatment can focus on. The only definite treatment is lung transplantation. We have only a few case reports where it has been successful. So to summarize, PPFE is a rare DPLD and needs to be suspected in the appropriate clinical setting. The diagnosis is by clinico-radiopathological information that we get, which is confirmed in ILD, MDT. The approach should be appropriate based on the knowledge about PPFE. That's why sessions like this, which increases the awareness of PPFE, would enable us to diagnose PPFE better. But we need to understand that it's a progressive disease, but there is variable prognosis and treatment options are really limited. And we need registries like INPF and more population studies, which really get the true prevalence for the world and also for India. So thank you very much. I close that.
Thank you so much, Dr. Bani. Please stay back for the questions. I really want to thank Dr. Naveen Dutt, Dr. Vikas Marwa, Dr. Manu Chopra, and Dr. Bani. They have really done the job in a very precise and concise manner. That was what we had planned, that we should cover these rare ILDs, and so that some knowledge is imparted on these less talked about subjects. So another less talked about subject in our part of the world, at least, is certain pneumoconiosis. We mostly miss out on that in most of the academic sessions. So for delivering a lecture on silicosis and other pneumoconiosis, we have somebody who is right in the midst of all these disorders, right in the sandstorms of Rajasthan, Western Rajasthan, Dr. C.R. Chaudhary, who is a professor and head of the Department of Respiratory Medicine at Dr. S.N. Medical College, Jodhpur. He has been a medical superintendent there, and he's a member of several societies and has won several awards, including presentation of more than 20 papers at different conferences. So, Dr. Chaudhary, are you there? Can you unmute yourself? Can you put on the video? Yeah. So can you unmute yourself and put on the video also?
Unmute.
Yeah. I'll unmute you, sir, and you can also put the video on, sir, and make the slide. Yeah. And make it full screen. Can you make the slide full screen, sir? No, go to the slideshow and make it. There's a tab right in the middle and right at the top, slideshow. No. Okay, this is fine. Okay, right. And you can unmute yourself, sir, now, and you can start.
Hello.
Yes, sir, we can hear you, sir. You can start, sir.
Good afternoon to all of you. First of all, I'm thankful to Dr. Durya and their team for organizing such a wonderful ILD workshop, comprehensive ILD workshop. I'm pretty sure that at the end of the session, there will be a lot of knowledge exchange between the pulmonologists, especially for young pulmonologists. So I will, after a couple of minutes, I will discuss mainly about silicosis. This is a silent killer in the western part of Rajasthan. And our Jodhpur is a epicenter of silicosis. There are the highest number of silicosis patients in the Jodhpur. Next,
Sir, you just once bring the cursor on the screen and click on the screen, just on the screen, and then you move the down button.
Yes.
Yeah.
My presentation will be in the following heading: Introduction, Complication of Silicosis, as I narrate that silicosis is the most silent killer in the western part of Rajasthan. A fortunate part of silicosis is 100% preventable disease. That is beauty of this ILD, that we can prevent 100%. But once it develops, it's very difficult to treat, and further complication of silicosis is again will lead to more seriousness of the disease. There are few studies in our department on the ATP Mycobacterium tuberculosis that is very common in silicosis. And in the Mycobacterium tuberculosis, atypical organism is very common, and the treatment of that is very difficult. And there is also association of scleroderma, systemic sclerosis, and silicosis. And another study is 6-minute walk test. And then lastly, on role of serum biomarker, and then prevention of silicosis. So if we look in the pneumoconiosis as a part of ILD, this is the mineral or inorganic dust ILD, which is a known case of etiology. This is ILO classification of, I will not go in detail. These are small shadow, linear shadow, and the large shadow. Silicosis, as we all know, is a diffuse interstitial fibronodular involvement of the lung caused by inhalation, retention, and pulmonary reaction to this crystalline silica. Perhaps it is the oldest occupational disease prevalent in the industrialized and developing countries, and tuberculosis contributes significant morbidity and mortality, and the most commonly from exposure to quartz and chrysoberyl and tritomite silica particle. This silicosis occur when worker inhale the respirable size, that is 0.5 to 5 micrometer. These are some industries work: mining, tunneling, quarrying, stone masonry, and sand blasting associated with silicosis. The etiological determinant for severity of silicosis depends on concentration of the air, duration of dust exposure, crystalline structure of the silica, presence of free silica particle, and particle size. And there are some host factor, that is genetic, smoking, and underlying disease may play a part in development of silicosis. This is pathogenesis when patient inhale the silica particle phagocytized by alveolar macrophage. The alveolar macrophage damage, inactivate, and lead to interferon alpha, interferon 1, and TNF alpha will lead to fibrosis and formation of classic skin appearance granuloma that is characteristic for silicosis. Depending upon intensity and duration of exposure, inhaled silica worker, there are 3 types of silicosis. One is chronic or classical silicosis. Second is acute silicosis or silicoproteinosis, and then accelerated silicosis. Chronic silicosis is the most commonest form of silicosis, occurs after many decades of exposure, will lead to fibrosis and scarring of the lung. This is typical picture of progressive massive fibrosis and egg cell calcification. Then acute silicosis occurs after exposure to very high concentration of dust over a few months. The acute silicosis associated with pulmonary proteinosis and following by high level of exposure. The often microscopic examination of bronchoalveolar lavage revealed to pass positive. This is radiographic of acute silicosis. Then accelerated silicosis occurs after a few years of exposure to the silica associated rapidly progressive feature of dyspnea and pulmonary fibrosis. This type is most commonly associated with complications like tuberculosis and CTD related complication. When we look about silicotuberculosis, there is 8 to that tuberculosis contributes significant morbidity and mortality and more common and accelerated. These are some radiological pictures of how when we suspect silicotuberculosis in silicosis. If lesion is in apical location, there is cavitation, rapidly changing the opacity, pleural effusion, pericardial effusion, all will lead to manifest or strong suspicion of silicotuberculosis. This is chest radiograph. Then approach to, this is a new guideline, how to approach and to preventive aspect of the latest PMDT guideline. We can go for IGRA or tuberculin skin test. All TST positive patients should be directed to treatment prophylaxis for tuberculosis. And individual who have positive skin test should sent for sputum examination for AB microscopy and culture, and ball, if possible, to be sent for culture and CBNet also to rule out active disease. And if there is no active disease, then prophylaxis should be given. This is another study in our department and very ready to publication. There are more chances of atypical organism, and the treatment of, as you all know, is atypical organism is very difficult and very challenging, and treatment has to be taken for at least 2 years. So this is again problematic for the patient. And this is a NIOS review of health implication of silica exposure. Most commonly associated autoimmune disease is scleroderma, followed by systemic lupus erythematosus, rheumatoid arthritis. And this is skin manifestation. Then there is obstructive pathology in silicosis. Exposure to silica particle will lead to development of chronic bronchitis, silica-related emphysema, and small airway disease, even without evidence of radiological confirmed silicosis, is known as mineral dust airway disease. And this study was done in our department. 6-minute walk test and spirometry parameters help in early disease identification. That is very beneficial for further prevention of exposure and alter the final course of disease. The significant decrease the morbidity and mortality. So they can be used as screening test people working in exposed area. The total duration of exposure, working hours, type of occupations, and factor associated with pulmonary function test will lead to. This is radiographic picture. This is EBLB. This is progressive massive fibrosis. And this is in 1997, the world became stunned, but that there is a discovery of the silica particle is responsible for cancer in the silicosis patient. That is group 1 carcinogen. That is very, again, challenging for silicosis patient. Then pneumothorax. The involvement pleura in silicosis is rare, but secondary spontaneous pneumothorax is only recognized pleural complication of silicosis. They usually unilateral, but bilateral may be there. This is unilateral, this is bilateral. This is again CT scan of the same patient. This is high resolution scan. And then renal disease. There are 5% excess risk of end-stage renal disease. The granulomatous nephritis and nephrotic syndrome has been described as a silica particle. And this is a rapid serum biomarker for early detection of silicosis, even before the radiological manifestation. That is serum CC16 should be used as predictive biomarker for early detection of silicosis, which would be helpful for reducing and delaying the premature death caused by silicosis. It would be to control the silicotuberculosis additionally, and limitation of this marker is this is highly sensitive, but specificity is very low. So this is the challenge. And now a few slides on prevention of silicosis. Avoidance of working in dust exposure as much as possible. Be aware of health effect of silica. Know the cause of silica and workplace. Remember of their visible dust. Use a water spray and ventilation working confined to the structure. Use as a water hose to dust before it becomes airborne. Do not eat or drink or wash hand without using the mask. If you use, must provide the properly fitted respirator. That should be there. And always use the NIOSS approved respirator. These are the some type of respirator. The covering your face with cloths such as bandana and t-shirt will not protect you. So this is disposable N95. These are the types. This is half face mask. This is full face mask. And lastly, the take-home message is once a worker has silicosis, there is no treatment that affect the course of disease. So prevention is the highest priority. I am requesting all the scientists, please do more and more research work on this. This is totally preventable silicosis and preventable ILD. That is a very beautiful part. There should be a regular health checkup and educational program. Else silica mine worker, the termination of any continuing exposure is advisable. Prevention of silicosis depends on prevention of exposure. All workers should be avoid to put the face mask. The complication of silicosis should be treated accordingly. Any respiratory illness in install workers should be taken immediately. This is 6-minute walk test, and spirometry can be used, a screening tool for silica at the site of the exposure. And the serum CC16 marker can be used for early detection of silicosis even before appearance of SAD on the X-ray. The assessment of autoantibody and HRCT for connective tissue related manifestation of silicosis. And all TST positive patients should be directed to prophylactic tuberculosis treatment. And last slide, the use of AI we have already deleted because we have another ongoing research work and ready to publish the role of AI in early diagnosis and screening of silicosis that I have not covered in this presentation. And this is our silicosis wing. And thank you. Silicosis leaves minus in gasping for breath. So prevention is highest priority and more research work required for the better outcome of the silicosis patient. Thank you, sir.
Thank you so much, sir. You have done a wonderful job giving an overview of silicosis in the short time that you had. So we can now be joined by other panelists and we can take up some questions. Dr. Manu, Dr. Vikas. I think Dr. Naveen is not there. Dr. Barney. Yeah. This is a question to Dr. Vikas. What is the role of LDH in pulmonary alveolar proteinosis diagnosis, monitoring, etc.?
So it's not a very specific test. In fact, LDH, if it is high, it is suggestive, along with other features, the clinical features.
There's some problem with the audio, Dr. Vikas. Is everybody finding a problem with the audio?
Yes, got it.
Dr. Vikas, can you join us again? Yeah,
is
now it's
corroborative.
Now it's better. Now it's better.
And in
So
the
can you
years,
just
we didn't
repeat?
have other ways to.
Dr. Vikas?
So LDH, can you hear me? Yeah. So LDH
So
is
we had a problem with your audio.
non-specific. All right. Can you hear me now?
Yes, sir. Can hear you.
Am I audible?
You are audible, sir.
Sure. So if LDH is high, it is supportive. So LDH is a very non-specific marker. And it used to be used in yesteryears when we had, less sophisticated technologies like advanced pulmonary function tests, HRCTs to follow up these patients. In the current, era, if it is high, it is suggestive and it corroborates with a diagnosis in the right clinical context. So nothing beyond that because it is very non-specific.
What is the percentage of patients who? What is the percentage of patients who have a non-milky ball in PAP? When you do a ball, you find it non-milky. So what is the proportion of patients?
See, it is uncommon. So non-milky ball will be seen if you do a bronchoscopy earlier in the course of the disease. As you're aware, when you're doing a ball, we are taking alveolar samples. So if it is an early disease, there's no marked alveolar involvement is not there, you might get a non-milky ball, or if it is taken from a site which is non-representative. So like you have predominant involvement of the lower lobes, if you're taking from the upper lobe, the sample may not be milky. So that may be a false negative or earlier in the course of disease. Otherwise, when the disease is far advanced, you have a lot of alveolar involvement, you would get a milky ball. So the percentage I'll not be able to tell because it's a rare disease, but it is uncommon.
What is the role of serial bronchoscopic segmental lavage in the management of PAP, and which patient should be selected for that? Do you have any experience on that?
So if you see more, surfactant you remove, higher the benefit. So with that view, we usually do a whole lung lavage because more the amount of, lipoproteination material you get off the lungs, the physiological as well as the oxygenation improvement is much more. So in patients where you're not able to do a whole lung lavage, probably because of very severe oxygenation issues, or especially, it has been reported more from the pediatric centers where there's difficulty in doing, whole lung lavage, especially in congenital PAP. So they do a lobar or a segmental lavage. But in adults, if you are able to do, you should be doing a whole lung lavage, because the benefits which accrue from, a larger lung being washed is much higher.
Right. So are BAL findings sufficient for making the diagnosis of PAP, or do you need a histopathological confirmation in all cases?
So, as I had mentioned, that if you have the autoantibodies in addition to BAL and picture of crazy paving on HRCT, a compatible history, radiology, and a milky BAL with a positive autoantibody, that should be sufficient. But unfortunately, in our country, there are hardly any labs which are doing the autoantibodies. So that is why you have to go ahead with a transbronchial lung biopsy in most of these patients.
But don't you feel if the CT
If you have
findings are
access
typical,
to serology,
if the findings are typical on CT and you have a milky BAL, is that not good enough for most of the patients?
so milky BAL is highly suggestive. It's not diagnostic. So you have to go ahead and know the
No,
etiology.
you
So-
look at the see, you can look at the microscopic findings of BAL also, and you have a consistent CT. So is that good enough?
So, you have secondary PAP, you have got other differentials also. Malignancy, adenocarcinoma can also present with milky BAL. So if you just do a BAL, you don't do a biopsy, so then probably you might miss an underlying malignancy, lipoid pneumonia, diffuse alveolar hemorrhage. There's so many other entities you need to be looking at. And what we are worried about is, malignancy. So that is why probably just stopping at BAL is not good enough.
Yeah. Dr. Barney, there's a question for you. How do you differentiate between PPFE from post-TB fibrosis? So, yeah. Sorry. Yeah. Dr. Barney?
Yeah.
So we see, I'll put up the question again. So we see a lot of post-TB fibrosis, which presents in the form of fibrocavitary disease, some cystic changes in the upper lobes, and a lot of pleural thickening also. And another such disease is chronic pulmonary aspergillosis. So are these actually just forms of PPFE with a known cause, or there is no elastosis in such cases? And how do you really make a diagnosis of idiopathic PPFE in our country? Because that's the dilemma I also face in my OPD, that if you don't have a history of TB, the gene export, etc., is negatives, CPA workup is negative, you just have some pleural thickening, then when do you call it idiopathic PPFE? Because several times we see such patients and we attribute it to a past case of TB which got self-healed.
Yeah, thank you for that question. I think that is a very unique challenge of our country, and we need to go only. I mean, logically, if there is a fibrocavitary disease and parenchymal fibrocavitary disease, that is the predominant radiological feature, minimal pleural reaction to that could be just part of that, or maybe there is a TB induced PPFE, we would never know. But if there is the pleural involvement and the pleural thickening is out of proportion to the parenchymal involvement, and the parenchymal involvement is only in subpleural location and it's not of cavitary disease, there the possibility of PPFE would be radiologically higher. The second thing would be progression. Post-TB sequelae will not progress over time, and the PPFE is likely to progress over time either insidiously or in a rapid manner. So if it is progressing, then certainly the possibility of it being PPFE would become much higher. And in ambiguous cases, biopsy is required. But if someone is not progressing and quite stable, then we just have to keep it on follow-up and have a possibility that it could be a TB-induced reaction. Only a biopsy would say whether there is elastosis or not, and that's probably not required if the patient is not symptomatic or progressive.
Dr. Barney, I've seen several times that sometimes patients will come with a lot of restriction. There's no chest wall disease, there is just restriction due to lung disease. The lung parenchyma does not show much, but there is subtle pleural thickening noted all over. So sometimes I'm not able to get a biopsy in such patients because they have a very low lung function, mostly FVC in the range of 1 liter or so. So can they be fitted into PPFE or idiopathic PPFE? So there is some apical pleural thickening, some bit of pleural thickening all around, and little lung inflammation or lung abnormalities on the CT, there will be some kind of signs of fibrosis within the lung, but they'll be very subtle, and they will not correspond to the kind of restriction we might have. So in that case, should be suspected. Mostly we are not able to get a biopsy in them because of low lung function.
Yeah, so that would be like radiologically consistent with, or if they have all the features, maybe even definite of PPFE. And and in that situation, if that is causing so much of restriction, preventing a biopsy from getting done, and then we need to take that as a possible or a probable diagnosis of PPFE and keep on close follow-up.
So one question to Dr. C.R. Chaudhary. Sir, you mentioned very clearly that LTBI needs to be treated in all silicosis patients. So
Yes.
generally we are not treating LTBI in like routine normal people who just have been found to have a positive MAN2 in our country, although in the
Yes.
West it is treated. So we have certain populations like HIV and say anti-TNF alpha antagonist recipients who need to be treated. So silicosis, as you mentioned, under the program itself is an
Yes,
indication.
this
Can
is
you
very
just
well
elaborate
mentioned in
on
the
that?
program.
Yeah.
This is very well mentioned in latest PMDT 2022 guideline. The silicosis is one of the in the TPT,
Right.
along with HIV and immunocompromised condition. So you
what
have
regimen
to
do you
look out
use,
for
sir, for
these,
that?
and then
What regimen do you use? Do you use HR or only rifampicin, only isoniazid, or both?
we can use depending on the availability of drug. We can use H, HR, and depending on the availability of drugs.
But sir, there's always a debate whether H is sufficient enough because the background prevalence of H resistance
Bilkul, high
is
resistant
quite
of
high.
H is there, so we can use both. The combination is better than single drugs.
Yeah. So how long will you use HR, sir, for treating LTBI?
3 to 6 months.
Right. Okay. So is the treatment duration for active pulmonary TB any different in silicosis? Should we go for 6 months therapy, or we have to go beyond?
We can extend the treatment for 8 to 9 months.
But is it routinely done, or if suppose a patient, like the way we used to test AFB positivity and then the conversion. Nowadays we are shifting
There is a
to
problem of positivity because all silicotuberculosis patient usually sputum negative. So it's
Yeah.
whole depend on clinical radiological picture and depends on symptoms of the patient. So we may extend 3-month course. Usually guidelines says 6 months, but practically we are seeing that 6 months is not enough. So we may extend 3 months. So that is total duration will be 8 to 9 months.
So it will be similar to any other smear negative case where you have to take a clinical decision. For example, if a patient has no symptoms after say 1 month of therapy, and then we complete the 6-month course, then we can as well stop in such a patient, right, who responds early.
Yes.
Right. A question to Dr. Vikas. Okay, this has been answered. What's the suggested duration of nebulized GM-CSF in PAP? Actually, it is not available to my knowledge in India. Actually, even the injectable form was not available for a lot of, I think, more than 6 months in the last 2 years or so. But now it has become available. Anything about inhaled GM-CSF, duration, how to use, and whether it is going to be available?
So there are various trials, and there I think there are two parts to the question. One is regarding availability and one is regarding the dose and duration. So various trials, they
Dr. Vikas, you have a problem at your end, probably with the internet connection. I'll take up another question then. Dr. Chaudhary. Sir, there's a question on use of antifibrotics in silicosis.
This is I want to ask the all especially you and all teams, because this is the real time for research work on the silicosis, and there are huge number of patients. So there is role of antifibrotic drug, or we can plan some research work of trial of drug and the antifibrotic drug. This is the real questions for all of us.
Yeah, true, sir. I would really like to work on that. I've recently published a review article on in COPM on silicosis, and
Yes.
really it's an unmet need of to test various therapies in silicosis. So off-label, I have used in a couple of patients who seem to stabilize with that. But again, just off-label use in a few patients does not mean anything. We really need to have some good quality RCTs before we can really conclude. So as a kind of a palliative therapy or a kind of a off-label use, one can use, but it is always better that you at least get some kind of expert guidance or sent to a referral center before.
We need some ethical
Yeah.
trial and ethical committee permission, and after
Yeah.
that we can use.
Yeah. So for the audience, I would say
a
that
multi-center trial from your department, from AIMS, from our medical college.
Yes.
Because we have a lot of patients, plenty of patients, and their patients are really creeping.
Yeah. So for the audience, the message is that we cannot really recommend the use of antifibrotics because we really don't know. Off-label, everybody might have used in a couple of patients, but we really don't know how good they are. So it is an open question right now, as Dr. Chaudhary clearly pointed out. Okay, so Dr. Chaudhary, what is the kind of somebody has asked, Dr. Mangla has asked that what is the kind of a distance from say a blast site or say a stone crusher till what is the safe distance from such places to avoid silicosis? So what is the range of the silica which moves around?
This is very pretty question. This is depend on type of exposure, condition of exposure, type of dust, whether the drug is dry or wet.
Yeah, so actually true, because if it all depends, like the wind conditions will be important. So if it's a windy zone, the dust can be carried to even further off locations. Even
Yes.
in Ladakh, we have environmental exposure to such dust. So we have also seen a couple of cases from Ladakh where the environment itself has crystalline silica possibly. So silicosis becomes an endemic disease there, even without a clear occupational exposure. So it all depends on site to site, what kind of, then again, as sir pointed out, what kind of measures you are using. Like wetting is the cheapest method that is advised, that whenever you are, say, if somebody is stone cutting, then you just keep on wetting the area where the drill or the cutter is performing the action, so that the dust does not fly out at all. You just keep it wet and settled. So that is the most important measure which should be taken everywhere, but it is not being taken. So we have the agate industry in Gujarat, we have the sand mines in Rajasthan, we have other industries, we have the denim industry in several other countries. In Australia, even a breakout of silicosis was recently pointed out in the last few years due to, again, this stone cutting thing. They have some tabletops which they also use cutters without proper precautions, and then suddenly they have found an epidemic of silicosis in a developed country like Australia. So we need to be very careful to really evaluate. So any odd job, if somebody presents with an ILD and does an odd kind of occupation, not a standard office job, then you always get into the details of what kind of occupation it is, especially if it's a construction site, a quarry site, say an industry, a factory. So you really have to go individualistically into the kind of exposures that the patient might have. So another question is, for the diagnosis of silicosis, is history and imaging enough, or do you require a BAL or biopsy in each case?
Yes, for diagnosis of silicosis, history and radiology is enough as far as guidelines says. But if we rule out some complication of silicosis like tuberculosis and other, then we should go for BAL. Otherwise, as far as for labeling the diagnosis is even X-ray is enough. History and X-ray is enough because we have a Center for Silicosis Compensation Certificate, and we have given a more than 15,000 silicosis certificate to the person for their compensation.
Yeah, so I will completely agree with sir. So if you have a clear exposure history, then you don't require anything beyond history and radiology. But sometimes you might not have a clear exposure history, and there may be other differentials. For example, tuberculosis itself, especially in an early disease. So, for example, if you just have central lobular nodules and you really want to, if the patient presents with fever, sometimes you may have silicosis, you might have tuberculosis, you might have silicotuberculosis. Sometimes you might have perilymphatic nodules with silicosis, so that sarcoidosis may be a differential. So if you don't have a clear exposure history, then definitely you might need a biopsy. But in a clear exposed person, like the ones sir might be seeing in the coming from the sand mines of Jodhpur, so there it is not required. All right, so I think most of the questions have been taken care of, although we have a lot of time. Pawan, you had really recently published some literature on silicosis. So how common is it in your area, and what kind of data you have shown in your paper? What is your experience? Any experience on the management and treatment of the disease? So Dr. Pawan Singh is our fellow. He is faculty in the PGIMS Rohtak currently. Dr. Dhruv Chaudhary works he works with him, and he has an interest in a lot of different areas of respiratory medicine. Yes, Pawan.
Sir, I would like to thank sir for inviting me here. As Sir Dr. Chaudhary already mentioned, the focus point of the place where we get these patients are basically the boards and the areas of certification. So our institute is also part of Haryana State Silicosis Board, which hands out compensation certificates and everything. And we have screened around 4,000 patients, and of them, around 500 of patients were diagnosed with silicosis and were given certifications, and we published this data in occupational medicine recently. The important thing to realize is there's at the time of presentation, nearly 1/3 of these patients will be in progressive massive fibrosis. So this is a huge number. Second, there's a significant discordance between the radiological presentation and the severity of the clinical symptoms that patient usually have. The centers where we are actually diagnosing these patients, where these patients are approaching for the compensation certification, are liable to several symptoms which are actually not present, because everybody wants a certification and they will try to get the certificate even if they don't have the disease. So the symptoms will be very common among them, that they have dyspnea on exertion, that they have cough, and finally you use the radiology whether actually these patients have silicosis or not. So symptomatically it is very difficult to follow up these patients, because many of these patients will not even come to treatment to you. So for example, of the 500 patients which we handed out certificates and compensation for being diagnosed with silicosis, 75% are still working in the same center because they don't get jobs anywhere else. So to convince these laborers that they have a disease and they need to use the precautions and everything is very difficult, because they are actually not that symptomatic as severity of the radiology is. Second, the National Green Tribunal last year had released some specific stringent guidelines for the sites where this stone crushing and stone cutting is happening, that they should have a specific type of plants with height more than 20 to 30 feet. The exact numbers I don't remember. They should have blue colored tin sheets standing above 10 feet above the maximum height of that plant, and regular wetting, as you have already mentioned. So this is some preliminary experience. As far as multicenter trials in silicosis are considered, currently neither ICMR or DBT are releasing any disease. They are all releasing disease specific grants, like they are working in ILD, they are working in COPD, they are working in cancer screening and everything. But none of these, because it is an orphan disease, nobody is looking after this. So even if you apply for grant in these specific areas for ICMR and DBT, you will not pass the first screening test because these are not falling into one of the theme areas of disease. That's all.
Yeah, true.
Try-
So
we tried this.
which are the industries around you that where these patients are coming from?
Sir, Mahendragarh and Narnaul have almost these are the hub of stone cutting industries. The cement is they are raw materials for cement and that crushing bajri and all.
Yeah, I lost you, I think. Dr. Marwa, have you been posted near Ladakh, or some of your friends might have shared? Have you come across some cases of silicosis from Ladakh who are not occupationally exposed, just environmental silica?
It's more of pulmonary edema there. Hardly any silicosis from Ladakh.
Sites, you have to cross some farmlands and you have to.
Okay, so right. But actually, it has been reported, and I have also seen a couple of patients who came from there, and even the patient himself said that it's an endemic disease there. Maybe not very common, but it has been well reported even without occupational exposure. Yeah. So another interesting suggestion is that if you are not wetting the place of the stone which you are actually cutting, can you just wet a normal mask, not use a N95 mask, use a wet mask? Dr. Chaudhary, can it help? A wet normal mask without you're muted, sir. Yeah, I have unmuted you. Yeah.
Yes, they can use it, but as far as good respirators should be used N95 or
yeah.
But they
So
can
it'll be-
use this is again good idea.
Yeah, so it'll be a
I
crude way if you
I
don't.
usually advise to the patient, please use wet handkerchief if you have not any mask.
Right. So it's a poor man's thing. So it's a poor man's,
Yes.
we can say N95, but yes,
Mhm.
it will not give you 100% protection. So it's better that you, if any industry worker is there, the employer has the responsibility to arrange for at least an N95. Better is a respirator, which might be reused with the filters changed, which will be helpful in preventing this disease. And okay, so
Problem of
and
these
if-
masks is again the patient is discomfort with workplace.
Right.
That is the
So
biggest problem.
Yeah.
Even owner is usually provide to the mask, but the patient not able to not use because constant work के साथ use करना, इसलिए मेरे हिसाब से smart industrial technology should be there.
Right. Correct. Dr. Marwa, what are the other causes of milky bar, like apart from PAP? That is one question.
So milky bile is seen with PAP only, but many times you can confuse it with turbid bile. In infectious diseases, you find that the bile is turbid and look milky. So, but otherwise, it is specific for PAP. You can confuse it for turbid bile though.
What are the causes of secondary PAP in our country, and PAP secondary to TB? Is it common?
So it's not common, but if you see, it's two ways. Many times, these patients of PAP have got immune dysfunction. They have got alveolar macrophage dysfunction. They develop tuberculosis and then come to you with it. So we treat it with ATT, but the PAP still persists. So that may be PAP leading to tuberculosis, which doesn't get better with ATT. You still need to treat PAP. And during follow-up, many of these patients, due to immune dysfunction, we have seen that they do develop tuberculosis in our country. So it's not common, but we have seen.
Yeah, true. So this is a very important point to be taken home, that don't label anybody who has TB or who has some other infection and PAP as secondary PAP. It is mostly in several times the other way around, especially if you have diffuse disease. It will be primary PAP patient who has got an infection due to the macrophage dysfunction. So it's an important thing to be pointed out. Secondary PAP is mostly localized. That's what I think. It is more localized than primary PAP, right?
Yes, and silica actually is a common cause. Silica again, silico.
Yes.
tuberculosis
Acute
and
silicoproteinosis, yes, right. So there also a whole lung lavage has been attempted in some patients. Correct. So role of steroids for silicosis. Dr. Chaudhary, any role of steroids for silicosis?
Only subjective response, but guideline don't says the use of steroid, but sometimes depend on patient condition, we require steroids.
So maybe for some kind of bronchospasm, I believe, but
Yes,
not routinely
because
it will just increase
because
the risk of
in silicosis there is chronic bronchitis, emphysema, and nodularity.
Yes, correct.
There are three components, so sometimes few patients require steroid.
So do they respond at least acutely?
Some patients respond, and some patients are or even on steroid dependent. They are usually readmitted many times, and they often require steroid. So this is
Steroid dependent, meaning
limitation.
they do show some response. That's why they are steroid dependent.
Yes,
but
yes,
is
yes.
the response objective? Like, does the lung function really improve?
No, lung
just
function and radiological clearance, there is no reference response, but only clinical or subjective response.
Right. So, so the conclusion is that generally steroids should not be prescribed just for silicosis. On an individual case-to-case basis, if you feel something else is contributing to symptoms, for example, as Sir said, chronic bronchitis, then you might use it. Sometimes people may exacerbate. Also, smoking is very common amongst silica workers. So, for that purpose, for acute exacerbations of COPD, that may be required. Again, it will be a short course mostly, and not a prolonged therapy with steroids. Right. So anybody encountered bloody ball in whole lung lavage during PAP? So bloody ball would be just trauma, I suppose. Dr. Vikas?
No, we haven't encountered. In fact, if you get bloody valve, you must think of, diffuse alveolar hemorrhage presenting with crazy paving, which is a differential of basically PAP, crazy paving on CT.
Correct. So he has said whole lung lavage. So it will be, if it is all bloody, then again, DAH, or if you have already diagnosed it, some trauma might have happened, right? Okay. So PAP after, okay. Blood stained ball. Okay, that's fine. Right. So we have covered most of the questions. The rest we can answer in the question answer box. I think it was a very informative session and something which we don't normally discuss, as I've repeatedly emphasized. So thank you so much, Dr. Vikas, Dr. Manu Chopra, Dr. Naveen Dutt has not joined us back, Dr. Barney, and Dr. C.R. Chaudhary. So next we'll have the second part of the quiz. I would request the panelists also to stay back and fill up the quiz options, and we'll show you the QR code, so with which you can go to the Google form link, and then I'll show the questions live, and then one by one you can fill up the answers to the questions. So Kulvinder?
Yes, sir.
Yeah, can you show the QR scan?
Yes.
QR code. Everybody can scan it, and maybe Dr. Vikas, you can tell me whether it is scannable or not. Does it take you to the Google Form site, and are you able to fill up the form easily? Is there any problem anybody is facing? The audience also can scan this. All the audience are requested to scan this and go to the Google Forms site. I'll show you the questions for the quiz. The form just contains the question numbers and the options, but it does not actually contain the questions themselves. So you just need to scan it and be ready with the form. Okay, Pushpender Singh asks, sir, how can I access to join quiz? Okay, you have the code, the QR code on the screen. You can just scan it. And please, from the audience, keep on telling me in the question and answer if you are facing any problem. If you are able to get to the Google form which says quiz 2, then it'll be nice, and you can just inform me on the question and answer box whether you have got the quiz 2. You have been able to reach that page and you are able to fill up the options. Please tell me in the Q&A, those who are able to open the Google form and able to mark the answers. Please tell me in the Q&A that we are able to reach the form and mark the options.
We are able to see the form, but what are the questions? Because it's come to the. Can't hear you, Sajal.
Right. Yeah, so the questions will be streamed live, and you just have the question numbers there and the options there. I'll show you the questions live. With each question, you keep on marking the answers. So Sunita says not possible to either scan or open through the link. Can we send another link in the chat box? Just send a simple link in the chat box which somebody can easily copy and Pavan says questions are not visible. Okay, questions will not be visible. I'll show them live. Kulvinder, can you paste the link in the chat box? It should be visible to everyone. So we'll need some 5 minutes to be ready and for the delegates to get ready to troubleshoot any problems which people might be facing, and then we'll start with the quiz. I have sent another link. Maybe you should be able to open with that. Pavan, can you try with this link also?
Sir, I have sent the link.
Okay,
Chat
okay.
box.
Right.
Sure, sir.
Puneet, are you there?
Sir, it is opening.
Okay. Right. You are able to mark the choices also?
Yes, sir.
Right. Okay, Mohammad Rahim Hussain. You can just click on the link that I've sent you on the chat box, or you can copy it and paste it in your web browser. Then you should be able to open it. And just reply, Mohammad Rahim Hussain, just reply if you're able to do it with the help of the link that I have sent recently in the chat box. You just copy it and paste it in your web browser. And just make sure it opens quiz 2. Pushpender asks, questions are not visible. Questions I'm going to show live in a PPT presentation. Mohammad Rahim Hussain, are you able to get to the form? Just tell me in the chat box, in the question and answer box. Okay, he's able to open. So I suppose that everybody will be able to open now with that link that I've sent. Okay, so we will start with the quiz in just a minute. And I'm switching off the Q&A box for now. Just look at the questions and try to think of the answer and mark it in the Google form. Just give me a minute. I'll start the quiz. Pavan, can you see my screen?
Yes, sir. Yes, sir.
Okay, so the rules of the quiz are that only a single choice will be correct. You'll have 4 options, and the 5th option will be don't know for each question. One of the choices will be correct. You have to mark the most appropriate choice. So if you have a confusion between two options, just mark the most appropriate. You have to attempt all the questions. So if you don't know, just mark don't know, but you cannot leave any questions unattempted, because that will not allow you to submit the form. And you have to submit the form immediately, because the form submission window will end with the quiz. I'll just give you a few seconds after the end of this quiz to submit the form. So just mark your designation, etc., and your degrees, current affiliation in the first few questions of the form, and whether you have attended the sessions today and yesterday's session, whether you have fully attended, whether you have partially attended. So all those things during the time we have, you can mark them, and then I can start with the first question. If you leave any question unattended, you will not be able to submit the form. So please, please, please mark all choices. If you don't know, then you just press don't know. And there is no negative marking as such. You just have to attempt. If you want to put a guess, you can put a guess, but you have to attempt all questions. And as I said, the submission window will close as soon as I stop the quiz. I'll give you a few moments time to just check, and then the window will close. So, okay, I'll just check. Right. So we are ready to really go ahead. So the first question is, which is true regarding pulmonary function or exercise tests in interstitial lung disease? Choice A is presence of obstructive airflow pattern excludes the presence of significant interstitial lung disease. Choice B is a 5-point decline in the percentage predicted forced vital capacity suggests disease progression. C is diffusion capacity for carbon monoxide may be normal. And D, choice D is oxygen desaturation on a 6-minute walk test helps differentiate ILDs from other lung disorders. Okay. I move to question 2. So question 2 is, which imaging feature on chest CT is consistent with usual interstitial pneumonia or UIP? Which imaging feature on chest computed CT is consistent with usual interstitial pneumonia or UIP? A, profuse traction bronchiectasis. B, profuse ground glass opacities. C, profuse micronodules. And D, profuse cysts. Question 3 is, a diagnosis of idiopathic pulmonary fibrosis, IPF, can usually be made despite the exposure to or the presence of which of the following factors? A, connective tissue disease. B, significant exposure to smoke. C, significant exposure to birds. And D, significant exposure to bleomycin. Question 4 is, which drug combination is known to increase mortality in IPF? A, prednisolone plus azathioprine plus N-acetylcysteine. B, pirfenidone plus nintedanib. C, nintedanib plus sildenafil plus omeprazole. D, low-dose prednisolone plus dextromethorphan plus pirfenidone. Question 5 is, which is not a feature of non-specific interstitial pneumonia on lung biopsy examination? A, temporal heterogeneity. B, expansion of interalveolar septae. C, moderate lymphocytic inflammation. D, presence of collagen in the interstitium. Question 6 is, in association with which connective tissue disease organizing pneumonia is a characteristic pattern encountered? A. Systemic sclerosis, B. Systemic lupus erythematosus, C. Sjogren's syndrome, and D. dermatomyositis. Please choose the most appropriate answer. Question 7. Which of the following statements is correct with regards to smoking-related diffuse lung diseases? A. Respiratory bronchiolitis interstitial lung disease is characterized by the presence of numerous lung cysts. B. Desquamative interstitial pneumonia is characterized by squamous metaplasia followed by the shedding of the airway epithelium. C. Pulmonary Langerhans cell histiocytosis is not associated with smoking. And D. Respiratory bronchiolitis pattern can be encountered on lung biopsy of smokers, even in the absence of significant interstitial lung disease. Question 8 is, which of the following drugs has not been found to reduce the lung function decline in systemic sclerosis interstitial lung disease? Which of the following drugs has not been found to reduce the lung function decline in SSC-ILD? A. Tocilizumab, B. Mycophenolate mofetil, C. Nintedanib, and D. Hydroxychloroquine. Question 9 is, which of the following antibodies is an anti-aminoacyl tRNA synthetase antibody found in the anti-synthetase syndrome? A. Anti-MDA5, B. Anti-endomycin, C. Anti-PL12, D. Anti-MI2 alpha. Question 10 is, which of the following is not a risk factor for interstitial lung disease among patients with rheumatoid arthritis? A. Female sex, B. Tobacco smoking, C. High titers of antibodies to CCP, that is cyclic citrullinated peptide, and option D is other extraarticular manifestations. Question 11 is, which of the following signs on the chest CT which of the following signs in the chest CT does not typically suggest the presence of a CTD related cause of usual interstitial pneumonia pattern, that is UIP pattern? A. Central lobular nodules, B. Exuberant honeycombing, C. Anterior upper lobe sign, D. Straight edge sign. Which of the following signs on the chest CT does not typically suggest the presence of a CTD related cause of UIP? Question 12. Which feature supports a diagnosis of interstitial pneumonia with autoimmune features? A. Presence of anti-GM-CSF antibodies. B. Presence of non-specific pneumonia, interstitial pneumonia on chest CT. C. Presence of usual interstitial pneumonia pattern on chest CT. And D. Presence of anti-GBM antibodies. Mark the most appropriate choice. B is presence of non-specific interstitial pneumonia, that is NSIP, on chest CT. There's a correction there. Question 13 is, which cystic lung disease is associated with a mutation in the folliculin gene? A. Follicular bronchiolitis, B. Lymphangiomyomatosis, C. Birt-Hogg-Dubé syndrome, and D. Tracheobronchial papillomatosis. Question 14 is, all the following laboratory investigations are suggested by international guidelines to screen for extrapulmonary manifestations of sarcoidosis, except A. Serum calcium, B. Serum protein electrophoresis, C. Serum alkaline phosphatase, D. Electrocardiogram. Question 15 is which of the following is true regarding the treatment of pulmonary sarcoidosis? A. Almost all patients require initial treatment with glucocorticoids. B. Methotrexate is contraindicated in lung sarcoidosis. C. Treatment can be initiated with 20 to 40 milligrams per day of prednisolone in most patients requiring treatment. D. Golimumab is the biologic of choice for treating sarcoidosis. Question 16 is which radiologic feature is seen in typical HP, typical hypersensitivity pneumonitis on chest CT? A. Perilymphatic nodules. B. Hyperattenuating mucus. C. Consolidation. And D. Ground glass opacities. Question 17. Which drug is used in clinical practice for treating hypersensitivity pneumonitis? A. Mepolizumab. B. Montelukast. C. Medroxyprogesterone. D. Mycophenolate mofetil. Question 18. Which of the following drugs is most likely to lead to the formation of lung granulomas? A. Bleomycin. B. Etanercept. C. Azathioprine. D. Benralizumab. Select the most appropriate option. Question 19. Which statement is true about pulmonary alveolar proteinosis, PAP? A. The primary form is caused by the inhalation of environmental protein antigens. B. Severe disease is treated with glucocorticoids as the primary modality. C. GM-CSF can be used to treat mild disease. D. Lung biopsy is mandatory for diagnosis. Question 20 is which of the following is true about silicosis? A. Simple silicosis is characterized by the presence of centrilobular nodules on chest imaging. B. Glucocorticoid treatment can result in complete resolution of lung opacities in simple silicosis. C. Progressive massive fibrosis occurs more commonly due to exposure to amorphous silica as compared to crystalline silica. And D. Antifibrotics have been found to reduce mortality in silicosis in a randomized controlled trial. Okay, so this is the end of the quiz. I'll just show you the questions once again. 5 seconds for each question. Anybody has missed a particular question can really have a look at the choices. Okay, that is it. Pawan, were you able to see all the questions, hear them clearly, and you were able to mark the choices?
Yes, sir. I am expecting a prize as well.
Right. So I think I'll just check all of you. You have submitted the form, Pawan?
Yes, sir.
Yes. Okay, I'll just check how many responses we have received. And I'll prepare for the MDD. Meanwhile, Pawan, could you take up some of the question answers in the question answers box?
Sure, sir.
And some of the remaining questions. And if you have somebody, Dr. Vikas is there, right? So you and Dr. Vikas can take up some of the left out questions, maybe, right? Just give me 5 minutes to just look through the, like the quiz and to prepare for the MDD. So we have about 110 participants currently, but we have received only 68 responses. Please keep on submitting the form. If you are unable to submit it, that may be due to the reason that you have not marked all the questions. So if you don't know a particular questions, you have missed it, you just mark don't know and then submit the form. Otherwise, you'll not be able to submit the form. And please, in the question and answer box, please keep on putting any problems that you are facing with the form. I'll try to troubleshoot. Just keep on typing any problems with submitting the form. So I expect at least 100 responses, and don't feel shy in just submitting it. It's just a kind of survey that how much our program has worked, because as several of you who were there yesterday must have noticed, this is the same quiz which we held yesterday. So I just want to see whether there has been any change with our activity in your knowledge level. So there is nothing to be shy about. Please submit the form even if you have left out some of the questions. Just mark don't know, and you might as well win an award. So there is an award for this. So you might be able to win an award if you are able to submit the form. I'll be closing the window in the next 5 minutes, and I would expect that everybody puts in the form by that time. Okay, Pawan, you can take up any question or any particular issue.
So all these questions actually have been answered. I was searching for some unanswered questions.
Okay, then you can ask some of your own questions. You can have Puneet and Vikas answer it, because I'll need some 5 minutes of time. I don't want to leave the session like that. So I'll need some 5 minutes of time to get my MDD running. You can discuss any of the issues that we have had lectures on. And Puneet, are you there?
Yes, sir. Yes, sir, I'm there, sir.
We can discuss some of the issues, and I will request the audience to even put in some questions for topics which we discussed yesterday or we discussed earlier in the morning, and we can take up those questions right now, because after the MDD, there'll be no other discussion. So any remaining questions for the 2 days sessions may be put up now in the question and answers box, and Puneet and Pawan can easily take them up.
So I have a question for Puneet, sir.
Yeah, Bhavan.
Sir, at what time during the evaluation of ILD or the treatment of ILD would you like to refer the patient to a transplant or cardiothoracic surgeon for an eventual transplant?
Okay, so we discussed this thing yesterday. So the thing is that in our kind of setup, the transplant decision is not based only upon the clinical picture, but upon many other things like the logistics and affordability and insurance and everything else. So what we generally should do is that at the time of diagnosis of ILD, especially if you're dealing with a fibrotic ILD or IPF, we should start discussing
discussing the prospects of transplant in the future right at the time of diagnosis, and possibly at every visit, especially if the patient is not doing well, and if we feel that the patient is on a trajectory towards more and more impairment in the coming times, we should start discussing the prospects with the patient quite early, so that at least those who can afford it, or who can avail benefits through any route and get a transplant done. So at least those people should be properly sensitized so that they can make an informed choice. But as of now, the facility that are available are not very wide, and most of the patients, even if given an opportunity, they are not able to utilize transplantations. But many of our patients have undergone transplantation at the expert centers, especially in Hyderabad and Chennai, and they're doing quite well. But such cases are only few. Most of the cases at the current situation are not able to afford or go for a transplant, or by the time they make themselves ready for the transplant, it's already too late. So I think in the coming years, when the transplant facility becomes more available, and we are able to offer this facility to more patients, we'll have more robust narratives in India.
So recently, I referred a case of progressive fibrosing ILD to the transplant surgeon, and she was started on LTOT around 15 to 20 days back. And a very important question the patient attendant asked me: if we go there and we are offered a transplant in, let's say, in a month or two, should we go ahead, or should we avail the benefit of LTOT for some time and then later on plan for a transplant? Because transplant is eventually going to happen, they can wait for some time on that as well. So how should I answer that person?
So eventually, this is a gamble. The thing is that the best chances of transplant success are when the patient is in a good physical state. When he's got a good body weight, good immunity, good muscle strength, he can walk around, move around. At that time, the transplant is more likely to be successful. If we keep on waiting and allow the patient to go on to a late performance status, then even the transplant is likely to be a failure. So therefore, that timing is important. Too early may be too much of a gamble, and too late may already be the end of the story. So possibly we have to discuss with the patient, and sometimes, though the transplant, since it's not available in most government centers except AIMS at the moment, and most of the centers are private only, and we do not have a clear data of the success stories from there. But yes, most patients who have been transplanted at Chennai and Hyderabad, many of them, they have success stories to tell. So if they go on for the facility in time, it is a better idea than to wait for respiratory impairment, cor pulmonale, muscle loss, bedridden state. Then it is likely to be a failure.
Can I add, Pawan, to that?
Sure, sir.
Yeah. So I agree with most of what Puneet has said, but to add to it, there are referral criteria for transplant and there are listing criteria. So it is better to refer them slightly early, as is mentioned, so that the patients remain under their radar. So they might not be listed, but at least they would start instituting the multimodality management in terms of nutritional, physiotherapy, oxygen, and they remain under the radar. Now, many of these patients, they might have to wait for months or years to get the lung, even if they are, listed. So it is, and they'll have to acquaint themselves in Indian scenario. They might have to have the administrative arrangement of shifting to another city, maybe to move to Chennai, Ahmedabad, which is difficult for many of these North Indian patients. So anybody who's oxygen dependent and is young and does not have any contraindications to transplant, if he's a current smoker, if he's got multi-organ involvement, CAD, and he's got a lot of contraindications, then you should not. But if you have a young ILD who has become oxygen dependent or who has been progressive despite your optimal management, I think you should refer them to these centers and then they remain under their follow-up as well.
So I have a question for you as well. So how much does a cryo biopsy or a TLB add to the management decisions for patients who are non-UIP pattern ILDs?
So it's a very good question. I mean, for non-UIP, especially for the fibrotic HPs, and to differentiate it from the UIP where the treatment would be different, the yield is quite good. So we are regularly doing cryobiopsies for these fibrotic NSIPs to differentiate from UIP, and the treatment does change in many of these diseases. So it's helpful with a good diagnostic yield of more than 90-95% in these patients.
Are you still doing EBB and TBLB for sarcoid suspects, sir?
So endobronchial biopsy is hardly it's non-invasive. We are doing EBB along with IBUS. TBLB, if we get a good amount of tissue in, endobronchial biopsy or with if you have rows, then we don't go ahead with TBLB. In fact, in West, they have stopped doing TBLBs because the yield with IBUS as well as endobronchial biopsy is pretty good. So in our setting, it all depends how much tissue you have got and if you have rows or not.
So have you seen MEN2 positive sarcoid?
Yes, yes. We have seen number of patients who are MEN2 positive, but many of these patients may be having coexistence and they usually come to a referral center after being treated with ATT.
Okay.
So, at our center, we are doing EBB, DBLB, and TBNA for all the patients, because what I have seen, similar to the studies published earlier by PGI, that we are getting the best yield if we do a combination of all three, because there are many patients in whom EBB is negative and TBNA is negative, and we get a diagnosis on TBLB or some other permutation combination. So, in one setting only, once the bronchoscope is inside, we are doing all three procedures. And I think the combination of all three is giving us the highest yield rather than any individual procedure.
Some of these patients are very wary of, pneumothorax and TBLB.
Obviously, sir.
Counseling you need to have before.
Yeah, some who do not tolerate the bronchoscopy very well, they're coughing vigorously, or who are very scared of having pneumothorax, in that we also avoid. But in most other cases, we would go for all three procedures together.
Plus, in cases where you're suspecting TB, if you find a granuloma in TBLB, it will be very helpful for the diagnosis, because it is unlikely that patient will also have a coexisting disease there as well.
Yeah. And MON2 positive TB, we also keep seeing from time to time, but it is always a diagnostic dilemma. You are never sure what you are treating, and sometimes when you do not have a very clear answer, it is always better to treat tuberculosis rather than sarcoidosis.
If you have time, I'll answer that question which was asked to me and my connection was unstable. So regarding the dose and the schedule for GM-CSF inhalation nebulization for PAP. So if you see, there is no standardization for the duration as well as the dose. So various trials have used different kind of doses. They've used 125 microgram twice a day. Some have used 250 microgram once a day. Some have used it intermittently. Others have used it continuously, followed by intermittent. So, the jury is not out as to what is best, but what we know is that nebulized GM-CSF is better than the subcutaneous GM-CSF with higher yield and better safety. And trials have used them from 3 to 6 months. So that is what we know about it as of now. And that's what the meta-analysis also says about it. But what is important is that do not use a normal nebulizer, because a lot of drug would be wasted and the lung deposition will be very poor. If you're using GM-CSF, go for a mesh nebulizer, a vibrating mesh nebulizer, VMN, so that the wastage is less and the lung deposition is much higher. And in terms of availability, pre-COVID, we had easy access to GM-CSF for nebulization, and MCure was the company which was basically marketing it. But post-COVID, MCure started making COVID-related drugs and they shut shop for GM-CSF as the market was not much.
Yeah, I think we are ready with the MDD case. It's again kind of a straightforward case to start with, but it might have a surprise in the end. Okay, so the panelists we have are, some of them you are already familiar with, 4 of them. And the new panelist who we have now in this second MDD discussion is Dr. Zafar Niaz, who is a professor of radio diagnosis at the SGPGI Lucknow. He has published more than 80 indexed publications and authored 4 book chapters and has received several awards. He is an editor-in-chief of a book called Quality Assurance in Radiology, a very important thing which is often missed in our setups. So, sir, are you there? Can you switch on your...
Yeah. Am I audible?
Okay, yeah, you are audible. Next, we will have our pathologist, Professor Amanjeet Bal. You are already familiar with her because she was there in the first case too. She's a professor of histopathology at PGI Chandigarh, and I work closely with her on several aspects of interstitial lung disease. She has special interest in pulmonary pathology, lymphomas, and breast pathology, and she is also a trained molecular biologist. Then, as clinicians, we have Dr. Pawan Kumar Singh, who I introduced previously. He's DM Pulmonary Medicine from our institute. He's currently working as associate professor in the Department of Pulmonary Medicine at PGIMS Rohtak. He has more than 50 publications to his name and several awards. I would also request Colonel Marwa to join in. We do not have, I think, Dr. Yeah, Dr. Naveen Dutt was supposed to be here. I just want to have a lot of clinicians who might give varying opinions. Dr. Marwa, are you there? Can you join in for this MDD?
Yeah, I'm here, Sejal. Sure.
All right. Okay. So next we have Colonel Puneet Saxena, who is an MD from AFMC and a DM from our institute. He is a senior advisor and head at the Army Hospital R&R, and he has several publications, about 40 publications, and a Chief of Army Staff Commendation. His areas of interest are ILD, mechanical ventilation, and several other areas in pulmonary medicine. So we will go to the case, and I'll present the history in brief only. Will not go to any kind of lengthy details. I'll just ask the panelists to just opine what they think about it, how to proceed. And our concern is only the approach and not the diagnosis, the approach that we might impart to our audience. Okay, so this is MDD case 2. So we had a 24-year-old female who is a student. She had pneumonia about 13 to 14 years back. She has recurrent cough and breathlessness, grade 1, since the past 14 years. She had received various treatments. The details were not very readily available. But then she had worsening breathlessness, and when she presented to us, she had grade 3 breathlessness, and this worsening was occurring over the past 1 year. There were no symptoms to suggest any cardiac issues in terms of any orthopnea, PND, angina, or anything like that. There were no murmurs on examination. There were no symptoms to suggest connective tissue disorders in terms of joint pain, swelling, Raynaud's, skin thickening, muscle weakness, any Zika symptoms. She denied environmental exposures to birds and farm dust, and she has been a student. There are no other industry close by. And then on examination, she had clubbing of grade 3, and basal crackles were present. So Puneet, any thoughts on this? How do you proceed with this?
I would want to know, she had pneumonia 14 years back. So since then till past 1 year, was she completely asymptomatic, or did she have any symptoms during that period also? And also,
she had grade 1 dyspnea and recurrent dry cough in the past 14 years or 13 years. And in fact, I will show you just one radiology. Sorry, Dr. Niaz, we don't have all the other radiologies currently in our PPT. We just want to keep it simple. But I'll just tell you that in the first radiology, we had a radiology from 2010 where there was diffuse ground glassing on the CT. That I can tell. So that was the part with pneumonia.
And she did not have recurrent infections in last 14 years. It was just a
She had
insidious.
repeated episodes of this breathlessness and some cough, and she was getting these episodes again and again. Sometimes she was treated. She might have received some antibiotics or even steroids. We don't know, but
Any family history and any relevant drug history?
No relevant drug history. She was not on any drugs, any particular long-standing drugs before the start of the illness or during this period. It was mostly given for her current symptoms, not any other drug for any other illness, and no clear family history of any respiratory disorder.
And no symptoms of infections in any other organ system of the body, like no diarrheas and other urine infections or any other kinds of infections. Nothing to suggest an immunocompromised state.
No. So can you tell our audience, why are you asking all this? What are you suspecting? Why you are asking this history?
So one is that I'm finding that there is clubbing and there was pneumonia 14 years back. So I'm thinking about several things. I'm thinking about bronchiectasis, but then you repeatedly said that the cough has been dry.
But yeah, some exacerbations with some sputum production, but not heavy kind of regular sputum production. Just the usual mucoid sputum, or sometimes during these exacerbations she might have produced sputum. But she was a young female, and she usually would not bring out such sputum. So it was just unclassified episodes of these recurrences. Pawan, your thoughts? Anything you want to know further, or you want to opine on whatever we have right now?
So were there any episodes during which she was absolutely normal in last 14 years? some days or months?
Yes, yes. So she was not absolutely normal. She was already always having some bit of breathlessness. She was not able to really like play around as her peers. But yes, there were some worsening episodes. But this time the worsening had been going on for the past 1 year. It was slowly getting worse and worse. Anything else, Pawan?
No, sir.
Okay, Dr. Marva, do you have any questions, any doubts, any thoughts?
So, is there any wheeze anytime the patient has had any wheeze, or it's just in terms of history and non-clinical examination, or it's just cough and dyspnea?
Whatever records we had, there was no V's documented. So there
Okay.
were a few records only available. Although CTs, 2 or 3 CTs were available, but other written records were few, and we didn't find any mention of a V's.
Childhood onset infection, then lingering. So possibilities which come to mind is bronchiectasis, even though the secretion is not much. But many times in bronchiectasis sicca, you have upper lobe predominant where the drainage is well. You might not be having excessive expectoration, but then you do get frequent exacerbations in these patients. Other thing which comes to my mind is, since girl, so probably some occult connective tissue disease, which is lurking somewhere there, and she might not be having any other symptoms, just a pulmonary predominant. So that is the second thing which comes to mind. So these are two things one would work at. Had there been any V, some airway disease, and also a post-infectious like Sware-James kind of a thing. Many times you have an infection, then you have persistent the McLeod's or the Sware-James syndrome, as we know. So
Right.
these are the possibilities.
So for the audience, I'll sum up. So it's a young patient, and the actual complaints have started when she might have been just 11, 12 years old. So the possibilities that our panelists have kept are basically immunodeficiency, which is very important to ask for. Cardiac disease, we have already said that we had ruled out, so we are not going into that. But otherwise, even congenital cardiac disease, you will also entertain in some cases. Bronchiectasis is an important differential which has been put forward, although we don't have that much sputum production. So it's not a classical case which bronchiectasis presents with, but yes, in children, sometimes they may not be bringing out sputum. Also, if it is bronchiectasis sicca, you might not have that much sputum in the history. So that is fine. Then a CTD, occult CTD might be there, correct? Airway disorders or post-infective like McLeod syndrome, Sware-James McLeod syndrome, which has a pulmonary artery atrophy on one side due to a childhood infection, that might also be there, right? Any other differentials to offer right now? Any other? What about basal crackles?
So these basal crackles, I mean, were they early inspiratory course crackles, or were they fine late inspiratory crackles like we hear in fibrosis?
Right. So they were like, I won't say fine or Velcro like, they were, I would say, coarse. So this is a very tricky thing, which also we need to tell the audience, because we are always getting confused between fine, coarse, what is the quality, and the MD exams and MBBS exams are based on that. In several places, I think you will agree on that several places experts also cannot agree whether it's a fine crackle or whether it's a coarse crackle. We can just say, okay, inspiratory crackles, or sometimes expiratory crackles are also present. Sometimes they're classical Velcro like in early IPF, but sometimes they are somewhere in between. And sometimes you feel that they are wet crackles or dry crackles, but that is not a certainty that each time you'll be able to say whether this is pulmonary edema or it is a kind of a interstitial lung disease. Do you agree? Do all of you agree with that?
It's subjective. Yeah.
Yeah, so a lot of times as students and residents, we are always caught on that, but I don't think it is always very objective or very specific. People may vary on this. Okay, so we have some feedback from the audience. Okay, those are just questions. I thought audience may also give their feedback in the Q&A on the case that we are discussing, on the questions that I'm asking during the case. So next, what do you want to do, Puneet?
Sir, I would want to do an imaging after this.
Okay, right. What kind of imaging? Do you want a chest X-ray? Do you want a CT?
A chest X-ray first.
Okay, right. We did a chest X-ray. We don't have it right now. Okay, we'll show you the CT. Anything else? Pawan, do you differ? Do you want a CT first or anything else first?
So I want a CT first.
You want a CT first. Dr. Marwa, anything else? You want a CT first?
HRCT and a pulmonary function test, full
Yeah.
PFT and both.
Right. So,
So if we can know oxygenation, SpO2, ABG, anything available?
right. So the oxygenation, she had about 95 or 96% saturation at rest. And the rest, what did you ask? The other thing?
ABG,
ABG
exertional
we didn't
desaturation.
perform. ABG we didn't perform.
Exertional
So,
desaturation.
what?
Exertional desaturation.
Exertional desaturation. So a 6-minute walk test probably, or just looking for desaturation during exertion. So okay, I'll give you that. For the audience, we need a imaging definitely. So we'll start with the chest X-ray always. Currently, I don't have that chest X-ray to show, but yes, we'll start with the chest X-ray. If we feel there's any abnormality, we can always characterize it better with a CT chest. And then the other things that the panelists have asked for is a 6-minute walk test and spirometry. Okay. So this is the spirometry. At the time she presented to us, she had an FVC of 1.27 liters, 44% predicted, and FEV1 of 0.95, 40% of predicted. And she had a ratio of 75%. The LLN was 79, but I'm open to interpreting this. Whether you can really term it obstruction, or whether the LLN is there is some problem with the calculation, that the LLN is 79. Although in children it may be reaching 80, but in a 24-year-old, I would hope that this LLN would be lower. There was no V's on examination otherwise. So what we have is, Puneet, can you just comment on this?
Sir, I think with this spirometry, we would also want to have a lung volume assessment, because it's not very clear whether this is an obstructive disorder, a restrictive disorder, or a mixed disorder, possibly a mixed disorder. So possibly if we can have a body plethysmography also along with this, we'll be able to characterize the physiology better.
Yes. So at the time when she presented to us, the getting this spirometry done was very difficult. At that time, she was quite weak and she was not ready to really go for these effortful tests. So we didn't go ahead with a lung volume. We didn't also perform a DLCO. The FVC was quite low. The FE1 was less than 1 liter. And she was not in a shape really to push for these tests. So we didn't do it actually. So next, do you want anything else? So we have a restrictive lung disease. We'll get to the imaging. Okay, so we'll get to the imaging first, then come to other things. Okay, so this is the radiology. Again, I'm very sorry we don't have DICOMs. We don't get DICOMs from our radiology department frequently. So we really have to make a real effort. So I'm sorry for that. But yes, I can show you the film photos. Dr. Zafar? I'll show you the photos. You can first comment on the distribution and then the abnormalities. And if you want me to zoom in somewhere, I'll try to do it. So this is the upper part of the lung. I'll show just one CT because this is all for learning purposes and for approach-based purposes. We are not like going into the details of the radiology. So I'm not showing the older CTs. So basically, this was the kind of. Can you hear me, Dr. Niaz?
We can.
I think we have lost Dr. Niaz's connection.
So basically, we are seeing a lot of central lobular ground glass haze and smooth septal thickening in the first CT.
Yes.
There are ground glass nodules in central distribution, and we have smooth septal thickening. In the second CT, we are also seeing some areas of hyperinflated areas, mosaic attenuation, and also some fibrosis with airway centric.
Yeah, would you say use this term fibrosis? Puneet, I have an objection to this term on radiology. We can always say signs suggestive of fibrosis.
What I'm saying is suggestive fibrosis because there is some traction there. There is some a little bit of architectural distortion at places. So suggestive of fibrosis. I am not saying that we are seeing fibrosis. What I'm saying is that suggestive of fibrosis.
Right. Dr. Niaz, can you hear me now? Somehow he is not able to hear us. Okay.
Can we look at the reduction also?
Dr. Niaz?
So meanwhile, can you show the next slide?
Yeah. So these are the sections, and I can show you some.
हम देखिए refresh करिए.
I don't know what's going on. I think we should proceed for now with the clinician's interpretation of radiology. Dr. Niaz, I'll try for another time.
Means उनका दिक्कत होगा, हमारा दिक्कत नहीं है.
नहीं ये हमारा साउंड डिवाइस क्यों नहीं आ रहा बेटा? अभी आवाज आ रही
Able to hear you.
I'll put something in the chat box to him, and then we can ask him to disconnect and connect back again.
fail to detect your speaker.
टेस्ट इस पे स्पीकर माइक्रोफोन करो.
अभी सिस्टम में कैसे explain?
Yeah, so okay. So these are the individual sections, as Puneet has rightly pointed out. I'll show you with the pointer. So mainly the disease is, I would say, in the middle lung zone mostly, as you can see from these sections. The upper zone is also involved, and the middle zones are mostly involved. And you can see these bands, which suggest that there is some kind of signs of fibrosis are visible, and then you see these traction bronchiectasis. These are the areas where the peripheral bronchioles and bronchi are dilated, and there's a lot of distortion. So architectural distortion, parenchymal bands. You have areas with a lot of ground glass nodules. So I think you are able to see some of these nodules. Can you see the magnified image now, Puneet?
Yes, sir.
Yes, sir.
So as Puneet rightly pointed out, there are some ill-defined nodules within the central lobular region and some ground glassing, this kind of a ground glassing, and some of these nodules are ground glass nodules really. So then we have these areas which are having hypoattenuated areas, which might suggest mosaic attenuation, especially this area. So these areas might be cystic areas, while this area, you can see my pointer, right, Puneet?
Yes, sir, we can.
So these areas, as Puneet rightly pointed out, these are areas of mosaic attenuation, and the vessel density is really low in these areas. So we believe that these may be hyperinflated areas, but sometimes it can be pulmonary hypertension which gives rise to these kind of areas. So for that, you need an expiratory scan, which again, unfortunately, we don't have. It is a problem with our radiology department. Yeah.
So we have the mediastinal windows to see the size of the pulmonary artery.
There was the pulmonary artery was it was less than the aorta at that point of time. It was less than the aorta at that point of time. So yeah, I have not brought in all the radiology because I just really your questions are absolutely correct, but yes, I just want really to focus on what we are dealing with currently in the parenchyma. So we have this impression. Pawan, can you sum it up? Can you sum it up and give your impression?
So to begin with, we have we have ground glassing opacities, central lobular ground glassing opacities. We have some septal thickening, which is actually smooth, no significant nodules, perilymphatic nodules. On the next slide.
Important point that septal thickening is there, and it is mostly interlobular. Will you say interlobular?
Interlobular, sir.
And any peribronchovascular thickening?
No, sir.
Okay, so these areas are there, but they are not clearly peribronchovascular. This may be called sometimes peribronchovascular distribution, some bit maybe, but mostly it is interlobular distribution, interlobular septal thickening, and there are no nodules on the thickened septate. That is correct, right?
And air trapping, especially in the left lower lobe and probably in the middle lobe as well.
Yeah.
And significant traction bronchiectasis and everything.
Right. Okay. Dr. Marva, would you like to offer some something on this?
I do agree there is profound ground
Okay, we have a problem with Dr. Marwa again. Okay.
So
So
if you
actually,
show such kind of city, everybody will have a problem, especially in the internet connections.
no, that's not right. Why this kind of city will cause problems? Okay. So,
smooth
so
septal
what are
thickening
these?
with
What
some
are these? Are these septal nodules? Are these
Can you hear me now?
Pavan, are these septal nodules?
So I don't feel these are nodules, but these can be, sir. Actually, yes, it can be, sir. If when you are magnifying it, it does look like that. These can be nodules. In fact, on the left side as well.
Puneet, do you think these are septal nodules?
I won't be very sure, sir. Probably these are just interjecting points between the septae and the fissures. Not very sure whether these are septal nodules because they're not universally there.
Yeah,
Only
I'll agree. I'll agree with you. Sometimes the septal beading, which you say,
yes.
is sometimes it is due to real nodules, but sometimes it is just wedges, which are suggesting
The
fibrosis or
intersection points.
distortion.
The intersection points they become
Intersection
prominent.
points, right? Intersection points which appear like wedges, and because mostly you see this kind of a structure of the nodules, this kind of a location of the nodules, which is central lobular. These nodules can be easily made out, right? You can make out on the screen, right?
So
The
my
identified
thought process
nodules.
will be that presence of ground glass centrilobular nodules and mosaic attenuation in later films with some suggestion of onset of fibrosis at areas. All that we start thinking about hypersensitivity pneumonitis kind of picture. But the smooth septal thickening is not going with it. The smooth septal thickening, which was very prominent in the first CT, that is not something that we see in hypersensitivity pneumonitis. So that's why I'm wondering if everything is right with the heart.
Okay, that's a very nice question. So whenever you have pulmonary edema, you see this smooth septal thickening. So that is what Puneet has put forward. But again, Puneet, don't you feel that it is not very perihilar? Because if you have some pulmonary edema going on, at least you'll have that interlobular septal thickening, but you'll also have something near the hila. We have just signs of fibrosis near the hila and not ground glass opacities or septal thickening near that point.
Yes.
So that is one point. But Puneet made a very good point. Pawan, anything else? What is your impression? Puneet has put forward HP, but he has given a rider that it might not be because there's some atypical features.
So I still feel that HP should be kept as the first possibility given the history and her response to other medications initially, and mainly upper lobe predominant picture. And in these because of these features, I would like to consider chronic hypersensitivity pneumonitis as the first differential in this case.
Okay, right. Dr. Marwa, do you want to offer differentials here? There was some problem with your connection.
Yeah, am I audible now?
Yeah, you are on.
So yeah, you have got basically ground glass nodules, some interlobular septal thickening, some traction bronchiectasis, and some evidence of air trapping. So yes, definitely hypersensitivity pneumonitis would be an possibility. And second possibility can still be a connective tissue disease, given that she is a female and you got a florid NSIP kind of a pattern. And we don't have an expiratory scan actually, which would have helped in a bigger way. So first differential would definitely be fibrosing HP. Second would be some connective tissue disease which is lurking. It is still not excluded.
Dr. Zafar, can you hear us now? We'll have your
Yeah, there was some disturbance with the audio system
No
actually.
problem. So we have
Yeah.
discussed the CT in detail, but we'll definitely value your thoughts on this. So we have limited films. That is an impediment, but whatever we have will show you. So these are the uppercuts. So actually, I told them that in 2010 she had a CT which she brought in actually, and she had diffuse ground glassing at that time. It was diagnosed as pneumonia at that time. She has been symptomatic since that time, and this was the current CT which we had.
Actually, sorry, I missed something, but this is the present city. This
Yeah, this is
city
the
which is
present.
showing
This
these
is
lucent
the
areas,
this is the
and
present.
that was the earlier city where only ground glassing and septal thickening was there. Huh?
Yeah, so this is just I think 1 or 2 years earlier, and this is the current city. And the earlier city, the 2010 city, was actually full of ground glassing. So this is the current city.
Actually, so this CT suggests that there is some element of lymphatic congestion or venous congestion because the first CT. So there was a septal thickening which was quite prominent, and also there was some ground glassing. So these two things, generally in hypersensitivity pneumonitis, we don't see a lot of smooth septal thickening. Um, so one thing also, I think some kind of like hemorrhagic conditions also repeatedly they produce alveolar thing and later on fibrosis also because those hemorrhagic components gets resolved by macrophages. So that is also if there is some alveolar hemorrhage repeatedly, then also initially it is more of a ground glass and later on fibrotic changes appear. And also the possibility of hypersensitivity pneumonitis. But generally, we don't see this septal thickening component, and mosaic areas also not so lucent. Generally, some lucent areas we see, but in this case, quite lucent areas. So
So
these are.
clear-cut mosaic attenuation here, and possibly these are just cystic areas in the
Yeah, it
middle.
is generally the mosaic attenuation which we see in HP are not that blackish. It somewhat some kind of air trapping, but it is in this case it is somewhat much prominent. But yes, HP is one thing we would like to keep in the differential. Other thing is that we have to rule out any cardiac cause or any cause of lymphatic congestion
Yeah.
and also some form of any kind of like repeated alveolar hemorrhage. So these are the things which we should
Correct.
consider.
Alveolar hemorrhage is a very important thing that you have pointed out because of the central lobular nodules and the kind of septal thickening which we saw.
Yes.
Right. So what next? What do we want next?
So we want an echocardiography
Okay, echo was normal.
and an autoimmune profile.
So autoimmune profile, what all do you want?
An ANA first at least.
Yeah.
by immunofluorescence. Yeah.
So the 6-minute walk test, it was 280 meters with the desaturation from 96% to 91%. The CBC, LFT, RFT were within normal limits. There was some anemia. I would say it was about 10. ANA was 1+, speckled, RF was positive, just 3 times the upper limit of normal. Anti-CCP was negative, ANCA was negative. HP specific IgG antibodies could not be done. So anything that you can get from this particular.
A normal CBC in this case would literally rule out alveolar hemorrhage as a possibility.
No, it was 10. I would say it was 10. But the thing is that she might have had alveolar hemorrhages in the past. And now she's developing this kind of a fibrotic disease. So I would still keep that possibility.
Normally, patients who come with chronic alveolar hemorrhage, generally they come with anemia. Would they have a normal HB even if the alveolar hemorrhage episodes have stopped happening?
Yes, if they have been supplemented, because it is just iron deficiency anemia, right? And also anemia of chronic disease. So if the hemorrhages are no more occurring and she has been supplemented with iron, then I would say that it might be normal right now. So this would be an entity which will be kind of vasculitis related ILD if we are suspecting that. And in that, I would say a hemoglobin of 10 will not be unheard of, especially it's a chronic process. And possibly now not active. Basically, chronic process will lead to pneumonia, but if it is not active right now, then it might lead to again getting HB getting close to normal. Dr. Vikas, Pawan, anything else?
Do we have an echo?
Echo is normal.
Did we do ENA?
Dr. Vikas can't hear you. There was again some problem with your voice.
I think he's asking for an ANA profile.
ANA profile we didn't perform. 1+ it was, and there was no particular suspicion. We didn't go for ENA actually. Okay.
Did you do ENA? ENA profile?
No, we didn't do an ANA profile, ANA blot, because it was a 1+ on IIL, and there was nothing to suggest a connective tissue disease, so we didn't go ahead with an ANA profile. Okay, so any other differentials to offer? So, okay, we have two good differentials. One is the hemorrhage related, which Dr. Niaz suggested, something to do with the vessels or something cardiac. So echo was at least normal. And we have hypersensitivity pneumonitis with some odd features. So next, what do you want to do? We did a VATS that I've shown to you, but what can we do anything else, Puneet?
I think we should, because with the given clinical radiological picture, it will be difficult to have a confident MDD diagnosis, because even HP has some odd points. Even chronic alveolar hemorrhage has a lot of odd points. We do not have anything to suggest a connective tissue disease. She's a young female. I think we should go for a diagnostic surgical lung biopsy or a cryo lung. She is unfit for cryo with the spirometry. So a VATS guided lung biopsy would be the next thing to do.
Right. So can you not label it HP with this kind of radiology, although there is no clear history of exposure?
No, sir. So she's one that she's too young for even HP to go to such severe extensive involvement. It takes years. Without any definite history of exposure, she's too young to have been exposed so much to come to this stage. Plus that smooth septal thickening, not very comfortable with leaving it at that. So I think we should go for a lung biopsy in the absence of anything. We do not even have an HP panel.
Prior to biopsy, you can do a bronchoscopy.
Right. So, yeah, Dr. Marwa, your voice is breaking, but you said that we can do a BAL. That is correct. That is correct. That is correct.
In a patient with poor lung function.
So we can do a BAL, but the problem there was that he had a low. Dr. Marwa, I don't think you can join right now because your voice is really breaking and causing some disturbance. I'll keep you muted. Yeah. So we can do a BAL as Dr. Marwa suggested, but the patient had low lung function. We just wanted to do a procedure which will be more definitive, because BAL itself causes a worsening and acute exam.
What finding are we expecting in BAL which will close the case?
It will not close the case. That's why I said that we went for a definitive investigation so that we have a diagnosis right with one test only, because she has a low lung capacity right now. Yes. Okay, so now I bring in Dr. Amanjeet. Ma'am.
Okay, so shall I share the screen?
Yeah. No, you can share the screen. So after you see the pathology, I need your opinions and views, because the case is still not closed. We still have not reached a consensus diagnosis. So this is a real MDD which we require to solve the case.
Okay, so in this case, we received a VATS biopsy. So this is low PAR. As you can see, there is a lot of fibrosis which is causing architectural distortion. At some areas, it's preserved where there is septal thickening, and we can see these blue areas which are lymphoid follicles. So this is the closer view of here. You can see a lot of smooth muscle hyperplasia is noted. And this is one of the terminal bronchiole. And here we see some brownish material which is getting deposited in the peribronchiolar soft tissue, or you can say interstitial. This is a closer view of the same, which is variable sized particles which are brownish in appearance. And outside these also we have these type of brown spots. In addition to those areas, these are the smaller blood vessels which are congested, and the walls of these blood vessels are also showing encrustation with similar material which we just saw in a wall of a bronchiole. So it's quite prominent here, walls of the interstitial blood vessels which are showing this deposition or encrustation of brownish material. This is the closer view to show one small artery, which is showing this material which is deposited throughout its wall. Here, these were positive for pearls, indicating this to be iron, and it's localized mostly on the walls of the blood vessels of different calibers. This is just the closer view. Here, this is one large branch of pulmonary artery, where we can see encrustation of iron on the elastic lamina of the blood vessel, and even the smaller arteries were showing iron deposition. This was about that material deposition. So second finding was there is thickening of the interalveolar septa, which was also seen on radiology. But in addition to fibrosis, there is a lot of smooth muscle, prominence of smooth muscle, or you can say smooth muscle hyperplasia in the interstitium. And the second thing is these types of lymphoid follicles or aggregates which are present in a peribronchiolar location. And in addition, there were few giant cells which were showing this type of cholesterol clefts or some vague material, eosinophilic material within them. And here again, you can see a lot of smooth muscle hyperplasia. So in this, we have interstitial fibrosis with smooth muscle hyperplasia. There is iron encrustation dominantly on the walls of the blood vessels, and we have lymphoid follicles with giant cells and cholesterol clefts. So we paid a lot of attention to this iron encrustation, and we suggested pulmonary cirrhosis, which could be endogenous, as was suggested. It could be because of pulmonary hemocirrhosis, but odd point was we didn't see much of macrophages which were containing hemocitrin. It was dominantly deposited on the walls of the blood vessels. Second, in view of interstitial fibrosis, which is giving a sort of NSIP pattern and lymphoid follicles, we suggested connective tissue disorder also. And occasional giant cells with cholesterol clefts could represent some sort of microaspiration. So with these varied findings, we could not give a conclusive diagnosis even on VATS biopsy. So we had these suggestions of some sort of cirrhosis plus some evidence of connective tissue disorder. Yeah, over to you, Sajid.
So we have some thoughts from the audience side. I'll just give those thoughts to you. That was based on just the CT and the history. So people have suggested DPB, diffuse panbronchiolitis. People have suggested that the smooth septal thickening could have been lymphangitis carcinomatosis, and also hemosidrosis has been suggested previously. Pneumoconiosis has been suggested. So Puneet, can you take it up? Pneumoconiosis, what is odd for each? Pneumoconiosis, DPB, and
bronchiolitis typically presents with copious amounts of sputum. So the history is not suggestive of diffuse panbronchiolitis, and even the CT picture is not exactly suggestive of diffuse panbronchiolitis.
DPB might not have that much sputum, I would say. But yes, it will have a lot of mosaic, and it will have these central lobular nodules. But this kind of fibrosis signs will not appear, right? Dr. Niaz can comment on that. Diffuse panbronchiolitis.
We don't see these findings. Generally, some bronchial wall thickening are seen, mostly minimal bronchiectasis and bronchial wall thickening, and sometime maybe some mosaic areas, but not this kind of centri assigner, ground glassing, and septal thickening and fibrosis. Generally, we don't see these things in panbronchiolitis.
Okay, hemosidrosis, that we considered, right? On the basis of the CT itself, we did consider hemosidrosis. We'll come to the biopsy. I'm just taking some audience thoughts. Again, lymphangitis carcinomatosis, I would say that it's a long-standing disease, so that is
also it will have a nodular septal thickening rather than smooth septal thickening.
Yeah. So sometimes
history also important.
Can be smooth, but yes, this is a long-standing kind of disease, and it's a DD for septal thickening, but in this case, we are not going to entertain it. Restrictive bronchiolitis post-infectious. So yes, obliterative bronchiolitis or what he has labeled restrictive bronchiolitis. So these are very confusing terms regarding bronchiolitis or bronchiolitis obliterans, obliterative bronchiolitis, cellular bronchiolitis, follicular bronchiolitis, DOS. So all these are very confusing terms, but there is some new classification of bronchiolitis which has been proposed, which has simplified all these terms. So we'll just call it obliterative bronchiolitis for the time being. For that, you must have a lot of mosaic attenuation, and the central lobular nodules will not be there in just obliterative bronchiolitis. Again, post-infectious, again, you'll have a lot of bronchiolitis findings, right, Puneet? You'll see a lot of mosaic attenuation with that kind of post-infectious bronchiolitis. And even post-infectious disease can also lead to macular syndrome, as Dr. Marva had pointed out earlier. So, okay, so
it seems to be a diffuse disease. Post-infectious is less likely because the disease is very, very diffuse in nature.
I would say bronchiolitis might still like viral infection followed by bronchiolitis might cause diffuse disease. If it's a localized lobar pneumonia, then we expect more of bronchiectasis and sometimes even mosaic might occur. But yeah, viral pneumonias may cause diffuse bronchiolitis. Okay, so what about the biopsy part now? How do we interpret it now, right now?
Can I add something here? We have some smooth muscle proliferation. Is it perivenular? Because veno-occlusive disease many times can have this kind of a presentation. So you can have septal thickening in a veno-occlusive disease where it presents like pulmonary edema, but when you don't have pulmonary edema, think of veno-occlusive disease. So that's a dictum. So did you have some amount of perivenular kind of a smooth muscle proliferation, perivenular fibrosis? Because that would be a case of VOD then.
Yeah, clinically, I will completely agree with you, Dr. Marva, because it explains a lot of things. As Puneet had also suggested, some cardiac cause. Now the echo is normal, so VOD becomes a possibility.
VOD is a possibility.
There are two things. There are two things against veno-occlusive disease. One is that the first CT was suggesting veno-occlusive disease, but the second CT is not. With all that fibrosis and arterial distortion happening, that we do not expect in veno-occlusive disease. Secondly, we will not have pulmonary hypertension. Pulmonary veno-occlusive disease will have some pulmonary hypertension. A normal echo without any pulmonary hypertension with such extensive involvement would take that thing away.
Yeah, so we might need a right heart catheterization.
Right heart cath,
might have missed it on the echo. It's not rare to miss pulmonary hypertension on the echo, right? So, okay, I think VOD is a good possibility, and hemosiderosis due to a vasculitis. Would you say vasculitis is a possibility, or anti-GBM disease is a possibility? She has never she never complained of hemoptysis. I suppose she never had that kind of a
anti-GBM disease. When it involves the lungs, it generally happens in smokers.
Yeah. Yeah.
So, she's never had hemoptysis. Her HB has been quite fine. No other organ is involved. Kidneys are fine. So, low probability.
So I think many times repeating ANA does help. If you do a ANA by immunofluorescence and you do a complete ENA panel, because we are still nowhere. So I think you have this kind of a picture where you've got diffuse fibrosis, so florid NSIP kind of a thing. So you should do a ENA and then look at it again, because it may be.
I agree with you that we can repeat the entire autoimmune profile, especially even ANCA and ANA, all of them, because now there's some kind of alveolar hemorrhage really going on inside the lungs. So veno-occlusive disease, one possibility, again, some odd points, vasculitis as such, or some CDD, which is leading to alveolar hemorrhage. Correct. These are all good, very good differentials. Dr. Aman, can you comment on these differentials? Like, what about idiopathic pulmonary hemosiderosis, IPH? Dr. Zafar, will you see this kind of fibrosis, like signs of fibrosis on the CT if you have idiopathic pulmonary hemosiderosis, IPH?
Actually, very few cases I have seen this idiopathic hemosiderosis. Once in a while, we see these patients. And yes, repeated pulmonary hemorrhage can lead to fibrosis. But here it's more of a central fibrosis. But whatever cases I have seen, there was some diffuse kind of reticular thickening on the background of alveolar hemorrhages. So I have not seen too many cases of idiopathic hemocytosis. A few cases I have only seen,
Right, right. So
and they are only
generally, I suppose they will have these central lobular nodules, but Puneet, there'll be less rare signs of fibrosis, right? IPH is bland; it's bland. There is
It's
no
bland, yes.
inflammation.
There is
So
no focal architectural distortion. This is not something that we would see in IPH.
yeah,
and
correct.
also these areas of mosaic also we have not seen in
Yes,
idiopathic
that is true.
hemochromatosis.
Yes, so ma'am, how do you take all these? We will consider it one by one. So, what about veno-occlusive disease? And the thing that Vikas asked whether there are any perivenular smooth muscle hyperplasia.
So in this, the smooth muscle hyperplasia is around the bronchioles. It's not around the vessels. So
Okay.
it's not like arterialization of the veins. And for examination, actual examination of the veins, we need a proper interlobular septa where the veins reside. So which was not here. So VOD, it will be difficult from this biopsy to exclude it or confirm it.
Okay. Then we take up IPH, idiopathic pulmonary hemocentrosis.
Most of the IPH we have seen in a pediatric age group where we have
But
seen
she
just
presented at 10, 11 years of age. So
usually what we see is presence of hemosiderin-laden macrophages in a central lobular area and to some extent in the adjacent alveolar spaces, but we have not seen fibrotic lung disease, right? And few cases of IPH we have seen in association with celiac disease also, what's known as a Lane-Hamilton syndrome. So probably we can rule out that also in this patient.
but again, yes, that is a definite possibility, because if you're considering IPH in a young patient, you should entertain Lane Hamilton. But because it is not fitting well with IPH, right? Because of the lot of fibrosis that we see. But occasionally some fibrosis might be there as far as I know, but not this much as it is seen on the pathology and CT. Right. So vasculitis.
If it was a vasculitis, we would have seen some changes of vasculitis in this biopsy, either GPA or MPA. So even if it's not active, there are evidence of healed vasculitic changes should have been present in the biopsy.
And you have enough material to just say that the vessels are normal. Okay. Anything with anti-GBM, I know that it is not required, but any pulmonary hemorrhage
Is a one-time point disease. You know, it causes hemorrhage like it's a one-time point. Same applies to the renal biopsy also. So in GBM, all the anti-GBM disease, all the crescents are of same age. So they do not go to like fibrotic crescents or whatever. So same applies to lung parenchyma. So mostly capillaritis with fresh hemorrhage, which may get organized but not fibrosed.
Okay. No, but we do see ILDs in pulmonary hemorrhage cases. So ANCA related UIP patterns have been described. So we can't really say that fibrosis cannot occur.
Not with anti-GBM, but
Not with
ANCA
anti-GBM,
associated, yes.
Yeah,
Not
yeah.
with anti-GBM.
Right. So you said that there are features of CTD, connective tissue disorder. So why do you say that, and what CTD should we suspect?
So like thickening of the interalveolar septa by fibrosis, which you also have been saying on radiology that it mimics NSIP pattern. So there is some suggestion of this pattern on histology also. Second is those lymphoid follicles with geminal centers around the bronchioles, which I still cannot explain by any other etiology. So these are the two features where like CTD is still on, you know.
Correct. So lymphoid follicles, as you told, ma'am, is an important clue to a CTD. So
Yes.
if we get a biopsy, we are not suspecting CTD clinically. We are not at least having any particular sign. But we get a biopsy where we see these lymphoid follicles. It's not just lymphocytic infiltrate. It's lymphoid follicles with geminal centers,
Yes.
which take us towards CTD kind of related ILD. Right. But we don't have any clue what CTD it could be. Right.
No.
Right. So yes, as Dr. Marva suggested, we should go in for ANA and the ENA panel. We might pick up any clue. Maybe we need a rheumatologic consult for this patient. Maybe the rheumatologist will be better equipped to pick some kind of subtle clue. Okay, any other possibility? So we have discussed PVOD, IPH, CTD, vasculitis, anti-GBM. Ma'am, any other possibility from your side? What about pneumoconiosis?
pneumoconiosis, initially we thought, like, I think you gave us history that she was staying near the railway coach
Yeah,
factory.
so I'll come to that history. I've not given to the, I'll give that history right now. So when we saw this iron here, we went into the history whether there is any exposure to some kind of iron dust. So the kind of history we got was that her father was living in a separate city currently. She lives with her mother. Her father only visits her. But before the onset of this illness, they were residing together, and the father works in a railway coach manufacturing industry in a factory where there might have been iron dust. So that is the only connection we made between iron and that. We were still considering a lot of hemorrhage issues, lung hemorrhage, as which explains the siderosis rather than an occupational exposure. But when we got into this history, we got this history. We don't know how to interpret it. So ma'am can comment first. That yeah.
So, for sidrosis or pneumoconiosis, like what we see in exposure to this type of mineral, it's usually in response to iron oxide, which is not that fibrogenic, alone. So iron does not cause this type of fibrosis and architectural distortion alone. So it has to be mixed with some other materials, maybe silicates or asbestos, the evidence for which is not here. So I'll keep that possibility lower down after I have seen the slides again. So probably endogenous, maybe hemorrhage or CTD. These are the two differentials.
Yeah, so we rule out pneumoconiosis, right, from your side. Okay. So I don't think we need any more clinician opinion, because pathologist says that we are not suspecting this kind of a thing. So that history is it's just a red herring possibly. And that also we got only when we saw iron. We got that history after a lot of probing. So it might be just a red herring. Okay,
I have
so
one question for ma'am. Can iron deposition cause development of lymphoid follicles?
No, not really.
Right.
It can cause some amount of fibrosis, but not lymphoid infiltrate.
A foreign body, there would it cause hyperplasia of the
So some of the hard metals have been associated with giant cell proliferation, which is known as giant cell interstitial pneumonia, but that's in response to hard metals like cobalt or tungsten, etc., but not with iron.
Right. So we are back to the hemorrhage part and some CDD related alveolar hemorrhage, which several of you correctly suggested actually. So what we did with this patient in the follow-up was that we actually were confused and we treated with steroids and mycophenolate. There was initial improvement in the lung function, but then she has started deteriorating, and we have added antifibrotic in the form of first nintedanib we tried, but then she had gastric issues. So we are we have now put her on pirfenidone, which she's tolerating, I think, a dose of 1200 milligram per day, and she's a bit stable on that. But we have referred her for a transplant because the kind of lung you see now, and we cannot really offer any great therapy that will improve the fibrotic part of the lung. But yes, we can repeat all this workup, the ANA, the ANCA, look more carefully for subtle signs of CDs. That's true. Any final concluding comments from any of you? Now, Puneet, Pawan, anything?
So in this case, maybe I would suggest that detailed ANA profiling should be done in this kind of a case, even if there are not overt features of CTD.
Right. Correct. In a case where you are stuck, you might need to go all out, like do more and more investigations. Mostly we will advise that don't do much investigations, as rheumatologists have repeatedly pointed out, that don't go for unnecessary antibody testing. It just gives you a false signal. But yes, when you are really stuck, when you have so many differentials with so many minds working, then it's better that you just go all out. Sometimes at least it's my strategy that to go all out with a lot of investigations, then have something on the table and then discuss again, maybe. Yeah. So we'll take up one or two questions because we are already past time. We are 20 minutes past time. But maybe if we have one or two good questions, can it be LAM? It cannot be LAM. There are no cysts really, it's just fibrocystic change. Puneet, if you see any question in the Q&A, you can take one up. Chronic pulmonary venous congestion, if long-standing, it can lead to hemorrhage. It can lead to sometimes fibrosis also. Okay. Sputum AFB was not done. It was not really required. It had been done previously, I think, in our records. We saw it. Swine flu. Okay, she might have had a viral infection 10 years back, 12 years back, but that is not the cause of the current problems. Okay, so most of the questions we have answered, right? So thank you very much to the MDD team, and this is the final session. So I also conclude the entire conference, and we had great fun. Puneet and Dr. Vikas have been there even yesterday and today, and they have been attending a lot of this this session and the last day session. Even we have Dr. Abhishek. Dr. Abhishek, can you switch on if you can be there? Dr. Gitika, are you there? I can again see you there. I would. I have unmuted you. Dr. Gitika, if you can come in. If you can hear me, if you can come in. I have unmuted you right now. Dr. Gitika? Okay, so Dr. Gitika is our like scientist in the ICMR who is supporting our project. So I just wanted if ma'am could say just a few lines, a few words about the INPF, but it's okay. I think she might not be there. Okay. So right. So I just conclude this conference, and thank you very much, everybody, all the participants, all the panelists. We did it at a very short notice, but I suppose it has been successful. We have had almost 1,400 registrations. And at any given time, we had more than 200 participants yesterday. Today, we had more than 150 at least at any given point of time. So that's wonderful. Puneet, thank you so much. Also, we had Dr. Manu Chopra, Dr. Vikas Marwa, Dr. Puneet Saxena from the Army, and several suggestions I received from the panelists to include the others, like Dr. C.R. Chaudhary was suggested by one of our Jodhpur colleagues. Dr. Manu Chopra was suggested, and I'm really thankful to the panelists to really get these people. Also, thank the rheumatologists who are not right here right now, but they were a special addition to our kind of knowledge base. Their knowledge coming from a different specialty definitely added to this program, right? So thank you. We sign out now. Okay, Puneet.
Thank you, sir.
Take care. Thank you. Kulvinder, we can close now. We'll just have the recording and the rest of it later. Pavan, bye-bye. We can close now. Thank you so much.